तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा। शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीमभयदां जाड्यान्धकारापहा। हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं शारदाम्।
नमस्कार। जगन्नाथ पुरी के इस पावन धरती पे आप सबों का हार्दिक स्वागत है। जय जगन्नाथ। बहुत समय नहीं लेते हुए मैं विधिवत क्यूटिकॉन 39 बिहार का मैं साइंटिफिक सेशन शुरू करने का घोषणा करता हूं। आप सबों का स्वागत है और आशा करता हूं कि ये जो साइंटिफिक सेशन है ये आने वाले समय के लिए हम सबों के लिए काफ़ी फलदायी रहेगा। धन्यवाद।
Jai Jagannath. Let's start the 39th CUTICON Bihar 2025 with our first session. For chairing this session, I would like to invite on stage our chairpersons, Dr. Kunal Sinha and Dr. Pushpendra Kumar Singh. Kindly, sirs, please come on the stage.
Hello. Yes, sorry. Good afternoon, everyone. So, our first speaker is Dr. Nirupma Parvanda. She'll be talking about skin, screen, society, the role of social media in derma practice. Please, ma'am.
So good afternoon, everybody. I am Dr. Nirupama. I'm MD dermatologist, and I did my MD dermatology from PMCH, and I've been a recipient of the 11th International Society of Dermatology Global Education Award. So my topic is skin, screen, society, and role of social media in derma practice. So today, more than 60% of the world population is on social media. And that makes it one of the most influential places to create health awareness. In fact, social media has changed the way we seek and share information. From a dermatologist's point of view, it is great for educating people, and it is also great to combat misinformation. And it also establishes us as credible voices amid unqualified influencers. And while doing that, it makes our practice grow from local to global. So a 2023 publication emphasized that social media is fast becoming a source of dermatologic and treatment information for many lay people. But what is worrisome is most of the social media, the content, dermatology related on social media is being created by people from their personal accounts who lack the proper scientific information, they lack the credentials for making dermatology related content. And this in fact can lead to more non-evidence based information being posted out there, which is not scientifically validated, and also misinformation to many patients. And also a 2020 study found that among the popular dermatology content on Instagram, only 38% was being created by healthcare providers. And amongst that, just 4% was by board certified dermatologists. So there is a vast need of us dermatologists creating evidence-based content on social media. In fact, the authors also emphasize that dermatologic medical advice on social media should come from reliable sources, that is, dermatologists. Social media can be used to pass on information to a large audience, posing a unique opportunity for dermatologists and dermatology organizations to provide high-quality, evidence-based education to the public to counter misinformation. Before I begin, I would like to point out a few questions. So I believe many of you might have had patients come to you and ask you, Doctor, I saw this on Instagram, kya ye product acha hai ya nahi? Or you might have recorded videos to educate patients, but you felt awkward in front of the camera, or you did post a few videos, but then that was just it. Or some of you actually want to go on social media, educate patients, without having to dance on reels. So I hear you and I see you. So if this is something that resonates with you, then you're in the right place. So let's explore how social media can be used to educate patients. So first of all, I'll be discussing how to grow your medical social media presence, how to understand the social media algorithm, how to create viral content, what are the content types that work, what are the challenges, and how to use AI tools. So quickly, I want to share why I am so interested and so passionate about this subject. So I have had and I've been doing clinical practice for over 10 years, and along with that, I have created over 3,000 videos. And because of this, I've been fortunate to grow a community of over 1 million subscribers on YouTube, and over 500,000 on TikTok, and over 4 lakh followers on Instagram. So I believe that all the information that I'll be giving today comes out of experience and not just observation. And during this journey, I have seen how social media has transformed our practice today, especially in our field. So let's begin by understanding how can you start as a dermatologist on social media. So first of all, you need to choose the platform. So if it is visibility or daily engagement one is looking for, then Instagram is incredible for that. YouTube is great for long form content and for in-depth education, LinkedIn for networking. So I think the best strategy would be to post and experiment with all mediums. It's best to cross-post on all the mediums so you understand and diversify your reach and reach a wider audience. The second thing to do is to understand what you would be creating your content on, whether it is skincare education, acne, hair loss, pigmentation, or procedural dermatology. This helps you stand out and it also makes content creation much more easier. A 2021 study on the analysis of content and creators making dermatology-related content on TikTok found that the most popular content was educational. And amongst that also, skincare accounted for nearly 40% of the content that was posted and viewed. And then it was dermatologic procedures also that gained a lot of views. Another thing I would like to point out that as this study also showed that most of this content was being prepared by personal accounts and only 39% was being done by healthcare providers. And amongst that too, it was just 13% board certified dermatologists that were creating content related to dermatology, which were actually popular and on TikTok. So after we decide and understand what is the topic that we are going to be creating the content on, we need to maintain consistency. We have to pick a very realistic schedule. Post almost about 3 to 4 reels a week, one long form video a week, and if possible, then probably daily stories for engagement. Now that we know when to post, what to post, to plan this all out, it is best to make a social media content calendar so that we know what is the content that we are going to be posting, what are the ideas that we have in the pipeline. So this is a screenshot from my personal social media calendar so that I'm able to consistently post content and not feel very overwhelmed by this entire process. So once we have the idea what to be talking on, we have to write a script. So script writing is also very simple. You start with a hook to grab attention, then you state the problem that you will be addressing, then you add value or you probably tell the solution, and then in the end, a call to action to engage your audience. The next step is, which can be very daunting for a lot of us, is after we have a script in hand, we wonder how to shoot or we wonder how to create or produce that content. So it is very simple. We don't need very expensive equipment. Even a smartphone is good enough. So start with the smartphone, iPhone that you have. Of course, definitely investment in a good mic is necessary and using good lighting to make the content aesthetically more appealing. After you have created, shot the content, then comes the role of editing. Even editing has been made very simple these days with simple editing apps like InShot, VN Editor. For advanced professional editing, you could use Adobe Premiere Pro or Final Cut Pro. So keep the videos short, 20 to 40 seconds, use text in them, use auto captions. That will make the videos look more appealing. So after you've posted the content, I cannot emphasize on the importance of engaging with the audience. So what do? You answer and reply comments, answer FAQs, run polls. This way, you build a very trusted community which seeks information from you. Another important thing in this entire journey is also collaborating with other dermatologists as well as other doctors and credible creators. This will help you tap into newer audience and strengthen your authority. Again, posting schedule is very important because consistency keeps you relevant. How showing up every day in your clinical practice makes you trusted, relevant, and makes people seek help from you regarding their skincare concerns, so does being consistent on these platforms makes you more relevant. So post about 3 to 4 reels a week and a daily story if you can. After you posted the content, you have multiple contents with you, then it is best to track how these content pieces are performing. Look at the shares, saves, watch time. This will help you refine what you're already doing and build even better quality content. So let's just go step by step. So how should the workflow be like? So plan, jot down all the topics you would want to speak on. Then, of course, build the script. Batch record so that you have a lot of videos to post when you later have to, so that it doesn't become very overwhelming to be very consistent. Edit, then of course caption it, hashtags, schedule and post it. And after posting, it is a must that you engage so that you're able to grow your social media account. So let us understand what is the social media algorithm, because sometimes it becomes very daunting and very overwhelming for a lot of people to be in the ecosystem and not understand what is going to work and what is not going to work. So to succeed in most of these platforms, one has to try increase the the number of views that you're getting, because retention is king. Also, engagement really matters. Every share, every subscribe, every save, every comment, every reply is very important. It is even more important than the number of likes you get. Again, consistency trains the algorithm. Consistency as well as relevance make the algorithm believe that you are a very relevant, very reliable creator and reward you for it. Another thing that really works on these platforms, especially as a dermatologist posting content, is being authentic, being relatable, and of course, a strong hook. It's always better to grab attention in the first few seconds so that you're able to retain the audience and they continue watching your video. Now, another topic which is very interesting is how to create viral content as a dermatologist. The first and the foremost thing is you have to have a very strong hook. You have to grab the attention when you can, especially in the first 2 to 3 seconds. So using phrases like, this is what you're doing wrong, or this will make your skin glow, or this is why your acne is not going, or this could be harming your skin. They engage, grab attention so that the viewer is retained on your video and keeps viewing it. The other thing is, one has to solve a relatable problem like acne, dandruff, pigmentation, hair fall. A very important tool in that is taking the help of Google Trends. So Google Trends tells us how searchable a topic is. If people are searching a topic, then there is more probability of your content going viral on it if you make good quality content on it. So as we found out in the studies that I mentioned before, that cosmetic dermatology related content, acne related content really does well. So keep it short, fast paced to maximize the watch time. Because if you make dynamic, brief content, it has more watch time. Again, the videos have to be very visual, have to be very aesthetic, so use very clean text, use a good background, use close-up, so better clarity, and the other very important thing is simplify your content. Sometimes it is very difficult for people to understand dermatology-related jargon, so whatever dermatological concepts that are complex, break them down into everyday language. And if you can add humor and add emotion to it, then the content becomes much more memorable. The most important thing, all these things might not help, might actually fail if you're not consistent. So being consistent is the most important thing on these platforms and in life, of course. So more content you post, more are the chances of it going viral. Regular posting builds consistent visibility. So as we discussed earlier also, let's again emphasize on the content types that actually work for dermatologists. So educational reels work very well, add simple evidence-based skincare and haircare tips, debunk viral myths. And so I am quoting this study from 2023 where they studied dermatology-related content on YouTube. So they found that acne and cosmetology-related content had more viewers as compared to medical dermatology-related content. Another important topic would be ingredient breakdown. That also does well. Behind the scenes, about the clinic environment would also be an engaging content. So it can become very overwhelming when you start making content. So you can take help of various AI tools like ChatGPT, Notion AI, InShot AI, VN Video Editor, Canva AI for thumbnails, and for answering as many DMs and comments, you can use ManyChat. More important for us as dermatologists is managing misinformation. As I told you, on these platforms, the more popular content is that of non-dermatologists. So we have to guide patients towards evidence-based care. This will help promote skin health literacy and reinforce dermatology as a trusted, science-driven specialty. So another study that was done in 2020 found out that most people, in fact, most people came to know about their dermatologist through friends and family, but a lot of them came to know about their dermatologist through social media, especially Twitter and Instagram. So social media does help us in educating our patients about skin-related concerns, hair-related concerns, but it also helps us expand our practice and reach out to many new patients. Of course, it comes with its own challenges like negative comments. There can be a burnout from content creation. Of course, there is a comparison culture, and there is an ethical gray zone. So even though there are so many challenges, I still feel social media gives dermatologists an opportunity to not just grow practice, but to educate responsibly and to make credible dermatology more visible and more human. So let's not shy away from the screen and make dermatology more credible, more connected than ever. Thank you.
Thank you, Dr. Nirupma, for your nice and brief presentation. Any query? I think no query.
Thank you so much, ma'am, for the wonderful presentation. For the next session, I would like to call upon the stage Dr. Anil Kumar Jha and Dr. Ajishnu Prakash to kindly chair the next session.
Hello. Now I invite Dr. Rajita Demisetti on the dais for antiquary.
Dr. Rajitha Demisetti will be speaking upon dermatology in transition, like clinics, codes, community care, and nomenclature as well. Because most of the dermatologists, they write consultant dermatologist and cosmetologist. At times, they write consultant dermatologist and cosmetic dermatologist, like a plastic surgeon who, after doing MCH, he or she also writes MCH in plastic surgery, burns, and cosmetic surgery. Simply, so many dermatologists are using as aesthetist after the use of this consultant dermatologist and aesthetist. What will be appropriate for the person who are doing the one and the person who are doing the one as a clinician, clinical dermatologist, at the same time he is doing a bit of cosmetic dermatology. Madam, please go ahead.
Thank you, sir. It's a privilege and a pleasure to be here with you all in this beautiful city. And I'm very grateful to Dr. Abhishek Jha, Dr. Vikas Shankar, Dr. Svetlina for inviting me, and especially for giving me this very thought-provoking topic, because this was something that made me pause and think in depth, and what a topic they've given. So over the next 12 minutes or so, I'm hoping to talk about why there is a flux in dermatology practice and why this topic matters. Because now we know that in the past 20-25 years, our lives have changed so much. Dermatologists have gone on from prescribers of tubes to getting into an injectable era, not only in aesthetics, but also in biologics. So technology, social media, patient expectations, patients' disposable income, all these have been game changers, and they have been responsible for the evolution. So there was a time when clinics used to look like this. You know, just a basic small shutter with a very nondescript board, and now we have very fancy interiors, very plush, almost five-star hotel-like ambience, and then we have this threat of the gavel. So we need to combine clinical excellence with legal literacy and procedural literacy, and I hope I will be able to convince you all that community health and public health has to be taken up in earnest by all of us. So when it comes to clinics, we have moved on to advanced diagnostics. We almost routinely use or should be using dermoscopy. We are not far from a day when we will have our own high-resolution ultrasounds to see where a particular vessel is before you inject the area, or if you want to dissolve a filler, or if you're suspecting a vascular occlusion, or if you want to assess the depth of a particular tumor, a soft tissue tumor, you might want to use a 10 or a 15 or even a 20 megahertz of ultrasound. And then, of course, aesthetic dermatology has changed the game. Trichology is here to stay. And even now, there are numerous people who don't realize that a dermatologist is the only and the only true trichologist. I have had doctor patients of mine, after being treated by me for various skin ailments, ask me, do you know anyone who's good for hair? And it's so ridiculous. And I also have patients, pediatric patients whose mothers ask me, do you think you have a friend who could help me with my sagging face? And then I have to go all out and tell them that, you know, this is something that belongs to our turf. Now, regarding the community health, I think quackery in dermatology is become so rampant that if we do not act now, it might be a little too late. And regarding prevention of public harm, and stigma reduction, even now, how many marriages are broken because of vitiligo in the, let's say, the girl's mother? I'm not sure if the boy's mother has it, then I'm not sure if the same stigma would be there. And then even now, access. We've been talking about how so many leprosy centers in the country do not have a dermatologist employed. And this is in a day and age where dermatologists are talking about unemployment. So you have dermatologists, you have the need, but then to marry the two is not been very easy. And then, of course, we have the threat of the legal concerns. So medical legal accountability is paramount for all of us. We need guidelines for ourselves and also for the rest of the people who are encroaching into what should be done by us, not for our own incomes, that's not really the point, but for the safety of our patients and the public. And of course, how to document, how to keep yourself safe, I hope to be touching upon it. So dermatology clinics have moved on from symptomatic treatments, and there was a time when people would tease us and say that what would you all give? Anyway, you're going to give a steroid cream for everything. And we have so many options to steroid creams nowadays. We have come to precision dermatology. So it's not enough if we are talking about just a IL-17 or a IL-23. We've gone far beyond that, and we are talking about disease modification. We are talking about prolonged remissions for chronic dermatosis. We are talking about changing the trajectory of the disease and also of the patient's lives. And we are talking about complex dermatosis, also complicated by the huge number of comorbidities that the average Indian seems to be suffering. Insulin resistance, obesity, be it anthropometric or just a metabolic obesity which you cannot see and diagnose, also known as the skinny fat. And of course, we have these difficult patients who want to behave like clients in quotes. And the day we start treating them like clients, obviously you are going to be on the back foot. So, and then of course we have the unmistakable effect of aesthetic dermatology, and this is no longer limited to the metros. Every small town in India has the demand for aesthetic procedures, and if we dermatologists don't rise to fulfill this demand, then this demand is going to be fulfilled by somebody who may not be doing something that is ethically and technically right for the patient. So it is up to us to fill in this gap, and of course digital tools, not just of dermoscopy but also of electronic medical records, teledermatology, and AI. Of course, artificial intelligence is here to stay. It's not infrequent for our patients to say that, you know, I put this image in ChatGPT and this is the treatment it gave and I used it and then I developed a side effect because of it and that's why I came to you. So these days are not far. I think we are already seeing this. Now moving on from the current scenario of dermatology practice to the medico-legal landscape. Now, you could be a defendant in consumer court. That threat is always there, and in case you do not have a professional indemnity, please do take one right away. You could be called by the medical council for various violations, ethics violations. It could be display of unrecognized degrees. So this is what the Medical Code of Ethics 2002 says, that you are not allowed to display any degree that is not recognized by the NMC. And now not all medical councils of the states are ready to take on this, but Telangana Medical Council has actually brought out a very welcome notice, and this is because a lot of people, particularly dentists and Ayush people, call themselves doctor. Obviously, they deserve to have the prefix DR. They did go to their dental college, and Ayush people did go to their Ayush courses. But once you say doctor so-and-so cosmetologist, how does the normal person know whether this doctor refers to medical doctor, dental doctor, Ayush doctor, or it could be a honorary doctorate in social work for all you know, or it could be, right now we have a case of interest in Hyderabad where this lady is a PhD in economics, or so she says, but then she is doing all kinds of procedures and treating lichen planus pigmentosus and things like that. So when we people say, oh, that is cosmetic, that is aesthetic, and then wash our hands off, who's going to be responsible for the mishaps that happen to these poor patients? So then we come to this very important trending topic of endorsing products on social media. Just like it was illegal and unethical to endorse or advocate any product on traditional media, the same rules apply to social media. So here, you know, you might think that this person is a model and she's good looking enough to be passed off as one, but then this is a dermatologist. Now, if you want to go and advertise a fan or a light or a AC or a plane or a car, that's fine. But then you are not allowed to use your medical degree, because once you do that, then that is going to add weight to your recommendation. So let's say a Kriti Sanan endorsing her own brand versus a dermatologist endorsing that brand, the difference is huge. And once you start getting into this, then it's a slippery slope. Then it is going to be, who's going to get more endorsements, and then young people are no longer going to be interested in mastering biologics and mastering procedures. They might as well start doing this because it gets them so much more money. So we have some cases going on in various medical councils even as I speak. And of course, you might be called for defamation to the court, or you might receive a legal notice. This was a legal notice that I had received from, sadly, IADVL member, because we, as the chairperson of the IADVL Anti-Quackery Legal and Ethics Committee, I was a part of the team which brought this to the notice of the EC, and the EC was the one which took the decision, but then I was the one who received the legal notice for defamation. And of course, I'm super proud that I have a criminal complaint against me. This was filed by a council called Coctracy. Coctracy is association that trains dentists, that creates this myth that it is legal for them to be cosmetologists and that cosmetologists can do medical procedures. I'll come to the point of cosmetology a little later. So why am I showing all this? Because in case you're going to be fighting these things, in case you're going to be speaking the truth on social media, then also you might get into all these things, but do not be scared, because the truth is always going to save you. And of course, you might be a complainant. So this was something that I had filed. So this story can go on, and I don't think I have time to talk about that. So coming back to the high-risk areas where you might be falling under the net of the medical legal complaint. So please make sure that whenever you're doing these aesthetic procedures, cosmetic procedures, or wherever you're doing high-cost procedures, or where you have this risk of PIH, it is not a punishable offense to create a side effect. But if you do not show a standard of, maintain a standard of care, that is when you're going to get into trouble. So whenever you're going to give any of these things, let's say you're giving isotretinoin, you please do your liver function, your lipid profile, and you put that seal saying do not get pregnant while on medicine and for 1 month afterwards. If you're giving a biologic or tofacitinib or any of these newer JAK inhibitors, do your screening for your latent TB, do your due diligence. And then misdiagnosis can be a problem. So always document, write down the options, explain the risks, take informed consent, because that is your shield, and also use what's called the SOAP notes. So the subjective aspect, the objective aspect, your assessment, your examination findings, and write down the plan, and then write down what your patient agreed to do. And in case you are not able to reach a patient, now suppose somebody sent you a WhatsApp message and you're trying to call them back, please send them a message saying we're trying to call you back, because you don't know whether it's a, let's say you've done a filler and you're suspecting a vascular occlusion, or you've given some drug and you're expecting some kind of a severe allergic reaction, so you want to make sure your skin is safe. So always maintain records of all the procedures, and in the court, what you didn't write means that you did not do it. So few practical takeaways: always document, avoid overpromising, maintain protocols, use trained staff. Please do not employ people with BHMS, BDS and all those things. And whatever you're delegating, make sure that that person is trained, and you cannot come to Puri and then tell your therapist to do laser hair reduction in back home, wherever that home is for you, and then you will get into trouble. So make sure, if you have a big practice, hire a dermatologist, pay them well. And then of course, we have a huge responsibility, not just regarding vitiligo and leprosy, but also regarding topical steroid abuse. That's still a reality. And because of what we Indians did, now tinea has gone wild, and we have this ignominy of the name Trichophyton indoteniae. And now this has become a global phenomena, and CDC has taken notice of it. So we have so many problems regarding that. Now Dr. Nirupama has given a fantastic talk on this. So all of you who are listening to this, please do go out there and spread the right information, because that's the only way you can combat misinformation. So if you can do this, you can also do the right ones. And if you want to be sure of what you can do, what you can't do, refer to the Communa app or the IADVL website. You will find this. This was approved by the general body. Now I am going to skip all this. This is the story of 2 deaths in Kanpur, both after hair transplant done by the same person, by this doctor who initially it was suspected that she was a dermatologist, then they said she was an MBBS doctor. It actually turned out to be a BDS person. So this lady did 2 hair transplants, one in November 24, one in March 25, and both these men died. And if now we don't speak up, then what kind of a justice are we going to do to our Hippocratic oath? This story, I think, has to wait for another day, but suffice it to say that, you know, in Telangana, we put up a very strong fight. And Karnataka people are doing a great job. Jharkhand is woken up. Rajasthan is doing some fantastic work. Tamil Nadu had already filed a case in the High Court. So it is time we speak up, and this is being heard. We are seeing the effects of it. So in case so this is the 5-pronged approach. We hope to file a case in Supreme Court if the EC is going to permit us. Awareness all of you can do, and then gathering and compiling data regarding quackery, and go and talk to your clinical establishment authorities, your DM&HOs, or your CMO or your CMHO, and then in whatever is within your purview, please go and speak up on your social media. But because right now it is too late, we have to wake up. And the silence of good people is more dangerous than the brutality of bad people. So we cannot afford to do this. And one thing that all of you can do, all of us can do to segregate ourselves from the quacks is to be ethical in everything you do. And lastly, we are not cosmetologists. What is cosmetology? It is a non-medical specialty. It is a vocational skill-based specialization for which you need to have passed class 10. This is what the government of India is saying. So if you want to call yourself a cosmetologist, it means you are saying that you have expertise in haircut, hair color, manicure, pedicure, and makeup. And I'm sure none of us are talking about that. So I have nothing against cosmetologists, but then we are dermatologists. So how do you convey this message, what sir has said? How do you convey this message to your patients? So I call myself a dermatologist, and your patients will know. So once they come to the clinic, you can always say, you know, somewhere you can have a list of the services offered. In fact, the medical council actually demands that you display all the services along with the price chart there. And if you want to even more make it clear, then you can always say special interest in aesthetic dermatology, special interest in cosmetic dermatology, procedural dermatology. Now, patients don't understand this yet because we have not educated them. It is time we change that. And because actually dermatologists, and by the way, I am not a venereologist. Mine is a pure MD dermatology, but those of you who have a DVL, you want to call yourselves that. But if you want to explain further, do not call yourself a cosmetologist. This is my plea to all of you. Thank you so much. And this is me on Instagram. I don't have a clinic Instagram. I only have my derm activist one, so please do follow, and hope to see you there. Thank you.
Excellent introduction, Dr. Rajita. And we came to know between the distinction of these two. You are expert in dermatology procedure or cosmetic dermatology or things like that. We should preferably write as a dermatologist, and we can add on that we are expert in this procedure, that procedure, and so on. But one thing that I would like to know from you, that you have just mentioned so many side effects of dermatology practice, right from the for the clinician as well. So what do you suggest that on the prescription, should I write that if any side effect or the drug reaction or the idiosyncrasy happens, I am not responsible for that, and take the signature of the patient below that as a commitment?
So I think there's something wrong with the acoustics. So I'm not sure if I heard you right. So you said something about idiosyncratic reaction?
Okay, definitely, because
No, I couldn't hear you clearly.
no,
There's
no,
an echo.
because it's not that the side effect or drug reaction,
Yeah.
idiosyncrasy
Yes,
also can take place with
absolutely,
our treatment.
sir. Great point, sir.
So, if I write those things and take the signature of the patient below that, so that he gives his consent that if anything happens to him, dermatologist is not responsible.
So we don't have to practice defensive medicine, but what you brought out is an excellent point. So when the patient gives you history, now let's say you want to prescribe Dapsone, and you take history of sulfa allergy in the patient and the family, and as far as they know, they don't have it, and then you do a G6PD, and you've written it down. If they develop a Dapsone reaction and they go to court, you are going to be exonerated, but you will have to put a arrow there and you will have to write down that to stop drug immediately and inform in case of ABCDE, in case of yellowish discoloration of the eyes and yellowish urine and redness and all these kind of things. So there are some drugs which are more notorious than others. So there, what I generally do is, I have a small seal for steroid, I have a small seal for Dapsone, so that I don't have to keep writing every time. I just put that, and I have a seal obviously for isotretinoin and that pregnancy thing. So I just put that there.
Thank you.
Yeah.
Thank
Thank
you
you,
very
sir.
much.
Thank you so much, ma'am, for the wonderful session. Now I would request our chairperson to call upon our next speaker.
Now I invite Dr. Arvind Singh, Senior Consultant, Joint Director and Joint Director, Provincial Medical and Health Services, UP. Honorary Consultant of Medical Laws, State Law Commission, Uttar Pradesh. Welcome, sir.
So this will be a session without slides. Respected Chairperson, members in the audience, seniors, colleagues and juniors. I don't know, I had prepared something else when I had come here, but in the last 2 sessions, I heard everything that was spoken, and I just want to start my talk from that. And the questions that have arisen because of the questions that have come up because of things that have been spoken. Number 1, what is ethics? Can any one of you tell me what is medical ethics and why is it important? Okay, so medical ethics is important in medicine because you are dealing with a situation of life and death, because you are dealing with a situation of prescribing drugs beyond your reach, because you are dealing with a situation which is so different from others. Therefore, to take these decisions, you need an ethical background. You need an ethical background to take decisions, not for anything else, so that you can convey that the decisions that you have taken is actually based on certain ethical factors. And these ethics have been handed down to us from our teachers. One more thing, sir, I would like to request. I will note my time. Please don't use that bong because I get very disturbed. I don't use a slide. So I just request that I will complete my in 15 minutes. Now the first things first. My session will go off on the questions raised itself. So what is board certified? Most of our youngsters, in their great flamboyance of using American and British terms, have started a new term, board certified. Is there a board in India which certifies dermatologists? No. It's the National Medical Commission which certifies. The board is in America, the American Dermatology Board, the European Dermatology Board, and they certify their practitioners. So this board certified should not get into our head. We are not board certified practitioners. We are registered medical practitioners certified by the then Medical Council of India and now National Medical Commission. My point is clear, no board certification. The second thing that comes to my mind is, what is the responsibility of registered medical practitioners regarding advertisements. Advertisements. So what is advertisement? So in their collective wisdom all over the world, all professionals were barred from advertising. Not only in India, all over the world, all professionals like chartered accountants, advocates, and doctors, they were barred from advertising. Why were they barred from advertising? They were barred from advertising because two people of two different socio-economic status land up in the same college and reach a particular skill and competence. Therefore, merely because one has enough money and finances to advertise himself and the other cannot, this will become a barrier to growth. Therefore, all over the world, it was specifically decided that no professionals will ever advertise their skills. Most of you who are from my generation or even younger will remember there was an actor called Dr. Sriram Lagu. He was an ENT specialist. He worked in Hindi cinema, and his medical council registration was cancelled because he used to advertise Chawanprash. I don't know if you remember or not. So therefore, please understand that advertising in any form, with full authority at my grant, I am telling you, is not allowed in the medical profession, in any form, except thrice on opening a practice, on starting a practice, on shifting your premises, or if you are going out of that premises and you are not available for consultation. Except this, no advertisements of individual doctors. Remember, clinics can advertise, hospitals can advertise because they are trade establishments, but the individual doctor cannot advertise. That is one thing I want to make it very clear on this forum. The second thing is reels, new fashion, reels, procedural reels, advertising products. There are tons and tons of dermatologists on social media advertising products like this: sunscreen, number 1, tung, number 2, tung, taking brand's name. Number 3, tung, another brand. Number 4, tung, another brand. You go see that. That is obnoxious, obnoxious. To say the least, you have missed out the entire severity and sensitivity of the profession. Now you have started advertising drugs, and that too by trade name. This is so very wrong, and it should not be allowed. It is not allowed, in fact, as my previous speaker was telling. As a member of the IADVL Anti-Quackery Ethics and Legal Cell, we had written to a lot of medical councils, and they have taken sufficient action against the erring practitioners. So please let me tell you, if I am your enemy, the first thing that I will do is to take your reel and send it to the medical council, and be sure that you will be punished. So this is about reels and social media advertising. Third thing, there is some people say, some people are of the opinion, all new generations, they are of the opinion that we are doing public service. Why are you doing public service? Because we are educating the people. Because a lot of false education is being done. A lot of propaganda material is there. Therefore, we are educating. We are doing nothing wrong. So if you want to educate, the only education that the Medical Council of India Ethics Regulations 2002 allow is about public health. You can write articles on public health. You can talk to the press on public health. You can speak to people on public health, but not this. Not this, what is being done. This acne and that acne. This psoriasis and that psoriasis. And this is how it is tackled. And now we have dermatologists, let alone any other practitioner, telling you the name of drugs used for psoriasis, how methotrexate is used, etc., etc. So I just want to break that myth. It is not allowed. Third thing, just a question came up about isotretinoin and other drugs which we use as dermatologists as they are not approved for that particular thing for which we are using. Like isotretinoin, it is approved only for noduocystic grade 3 acne. So therefore, if I have a patient who has grade 1 or grade 2 or just PIH, or I am using it for some other thing, including some are using it for tinea, giving it along with antifungal drugs, someone else is giving, all that is all right. But what the regulations say, that it should be clearly mentioned on the prescription that the drug is being used out of approvals, out of the approved list, so that the patient knows that he is being given a drug which is not in the approved list. You got my point, sir, about that question you asked. Now, third thing that question that came up was, in spite of everything, there can be reactions, there can be idiosyncrasies, as you said, there can be so many reactions to drugs. So we are not responsible for that. We are not responsible for that. What we are responsible for is to tell our patients to stop the drug or to report back if he has certain symptoms which we think are symptomative of reactions to the drugs, nothing else. Fifth, a lot of us have been using this terminology at the base of the prescription slip, not valid for medico-legal purpose. So I had as a man of law in the Allahabad High Court, the Honorable Justice Ambawani once asked me, Dr. Saab, do you make two prescriptions, one valid for medico-legal purposes and one not valid for medico-legal purposes? So I said, no. Then he said, then why do you write this prescription is not valid for medico-legal purpose? Anything that you have written is valid for medico-legal purpose. How can it not be valid for medico-legal purpose? That is one thing. As Dr. Rajeta also said, once you are using the terminology, your prescription is very important. I can sue 3/4 of great dermatologists of this country and take them to court and ask them to be penalized by doing some very small things. Number one, your prescription slip. Your prescription slip, your name, and the degree recognized by the Medical Council of India, not any other degree. So, not BSc, MBBS, MD, okay? And neither MBBS, MD, DD, LL, SOTC, IQDP, etc., etc. So once you write the name of the degree that has been recognized by the Medical Council of India, it should be on the second line. It should be on the second line, just beneath your name, suffix to your name. Then all these fellowships, training, etc., that you've done should be mentioned below that, saying special interest in aesthetic surgery, saying special interest in laser surgery or in hair reduction, etc., etc. But there should not be a continuation of the entire degree because it is misleading and people have been fined because of that. Fined means पैसे का फाइन नहीं. Fined means 1 महीना रजिस्टर से नाम काट के कहते हैं घर पे जाके बैठो, प्रैक्टिस मत करना, सीख लेना. ठीक है? That is the fine actually the medical council gives. Actually I was to talk, how many more minutes? 2-3 minutes? कितना हुआ? अरे तुम एकदम गिनती ही बंद कर दी है. Anyway, सब चले गए. So, what I want to say is that I was supposed to talk on ethics, etc., the topic given. But while sitting there, I heard so many things that I could not control except to deactivate the entire process and let you go back into the things. Procedural dermatology. Cosmetology nahi ho sakta hai. There is no cosmetic. Rajita has already said cosmesis means the act of using cosmetics. लिपस्टिक लगाने आता है आपको, कॉस्मेटोलॉजिस्ट हैं आप. काजल इत्यादि इत्यादि लगाना आता है आपको, आप कॉस्मेटोलॉजिस्ट हैं. लेकिन आप कोई प्रोसीजर कर रहे हैं, वो कॉस्मेटोलॉजी नहीं है जनाब. कॉस्मेटोलॉजी इज द एंटायर साइंस विच एक्ट्स विद ब्यूटिफिकेशन ऑफ द फेस यूजिंग कॉस्मेटिक्स. not using your skill and knowledge. And as she said, the MSME very clearly has written that a class 10 certificate is required to be a cosmetologist. अब आप वही बनना चाहते हैं तो भगवान जाने, जगन्नाथ जाने, मैं तो कुछ नहीं कर सकता हूँ उसके लिए. Then surgery, surgical skills, the surgical skills that we have acquired. Now please remember that hair transplant is a very, very tough topic. Very, very tough topic. It's still limbo. It is still in the courts at Mumbai and Chennai, where both the MDS, ortho बोलते हैं ना, हाँ, OMFS, oral maxillofacial surgeons, and the dermatologists and the plastic surgeons are at loggerheads in the court to say that this is not in their field, and one second says this is not in their field, and the third said this is not in their field. So let me just give you one brief idea. The oromaxillofacial surgery curricula specially has teachings of hair transplant. The plastic surgeons curricula and the NMC curricula, you can check it on the web, specifically has a plastic hair transplant curriculum. But the dermatology curricula does not have a hair transplant curriculum. And I have asked the IADVL national president, etc., and Dr. Venkatraman, Mysore, and the other team has been working hard with the National Medical Commission to include it as curricula in the training of dermatology. I end my talk here because it will be a very long thing. I just want, if any questions are there, I will fat answer the one or two questions which come up from the audience or from your side. Anyone from the back? Youngsters? Any questions in your mind? माइक दे दो भाई, थोड़ा सा आगे आ जाइए. नहीं, मैं बुजुर्ग हूं ना, सुनाई कम देता है. बोले. जी, I got your point, sir. वो करने को तो anybody is doing it. I just talked about what is legal and what is right. That the BDS cannot do any aesthetic procedures. But the OMFS have been given permission by the DCI to perform certain aesthetic procedures and hair transplants. The plastic surgeons, of course, can do it. The NMC has issued a circular which mentions dermatologists can do it, but also mentions that they should be adequately trained. And the infrastructure of the operation theater, etc., has been mentioned, for which a hair transplant clinic should run. ठीक है सर? और डेंटिस्ट का इस देश में तो ब्यूटी पार्लर में बोटॉक्स लगता है, सैलिसिलिक पील लगता है, थेरेपिस्ट कुछ भी करती हैं. तो अब क्या इस देश के उस चीज़ के बारे में कमेंट करना ठीक नहीं है, लेकिन लीगली यही है कि वो नहीं कर सकते हैं, और जब वो पकड़े जाते हैं तो उनके ऊपर गंभीर धाराओं में केस दर्ज किया जाता है, जैसे कि तेलंगाना और कर्नाटक में विशेष करके इन दो राज्यों में एक विशेष मुहिम छिड़ी गई हुई है, जिसमें कि ये क्लिनिकल एस्टैब्लिशमेंट एक्ट के अंतर्गत बंद कराए गए हैं. सील और सीजर की कार्रवाइयाँ डिस्ट्रिक्ट कलेक्टर्स वहाँ बोलते हैं, उनके माध्यम से की गई है.
One offline question, sir.
Sir.
As you have told that isotretinoin, it's definitely a toxic molecule, and we are supposed to use it in grade 3 and 4 nervous cystic acne. This is very true. But one thing is cropping up in the recent literature, that if you combine metformin along with this isotretinoin, there is a great improvement in the gut microbiota, and the result of acne recovery is grand well. these things haven't come into the text.
No,
But
I think, sir, your point is well taken, sir.
use these things together?
Your point is well taken, sir. Please understand, I have not stopped you from using isotretinoin, nor have I stopped you from using metformin, nor am I stopping you for mixing a full cocktail of drugs which you or papers are fond of. What I am trying to say is, if you are using drugs as out-of-label drugs, please indicate on the prescription that these drugs are being used out of label. That is all that I am saying. That is all. You use metformin or anything that comes up, use it, but please indicate to the patient that these are off-label usage of drug. Off-label. Most of the people have forgotten what off-label use is. The entire dermatology grew up because of off-label usage of drug. Otherwise, the entire armenium that we used some 20, 30 years back was a few steroids and a few creams and a few drugs. But the entire dermatology proceeded to this level just because we used so many drugs, tried out so many drugs as off-label usage, and we found that they are effective and beneficial to the entire humanity.
Yeah. Thank you, sir.
Thank you, sir. My pleasure.
Excellent presentation.
सर एक और क्वेश्चन. सर एक क्वेश्चन. महादेव सर.
अब चेयरमैन से क्वेश्चन परमिशन ले लीजिए.
Permission is granted.
सर एक सिंपल सा क्वेश्चन है कि अगर मान लीजिए हम लोग कुछ एस्थेटिक प्रोसीड्योर करते हैं और चेहरे पे मान लीजिए हमने लेज़र किया, पिगमेंटेशन होता है और पेशेंट कोर्ट में जाता है, तो क्या हो सकता है सर इसमें?
अच्छा, सबसे पहले झा जी के क्वेश्चन का जवाब झा जी के स्टाइल में देता हूँ. नंबर 1, आपको ये गलतफहमी है जनाब, हम एस्थेटिक प्रोसीजर्स नहीं करते हैं, हम डर्मेटोलॉजी प्रोसीजर्स करते हैं. पहली चीज तो ये, आप क्यों अपने आप को बांट बांट के पान की दुकान की तरह यहाँ चिप्स रखाएगा, यहाँ गुटखा रखाएगा, यहाँ सिगरेट बीड़ी रखाएगा, मत कीजिए. आप जो भी प्रोसीजर्स कर रहे हैं, चाहे वो पीआरपी हो, चाहे पील हो, चाहे बॉटुलिनियम टॉक्सिन हो, चाहे फिलर्स हो, या अब्रेजन हो, डर्मा अब्रेजन हो, एटसेट्रा, ये सब डर्मेटोलॉजी के प्रोसीजर्स हैं. ये एस्थेटिक कहाँ से घुस गया इसमें? आप तो डर्मेटोलॉजी के आपने बांट दिया है अपने मरीजों को देख के, क्योंकि वो सुन रहे हैं एस्थेटिक, कॉस्मेटिक, तो वो आके आपसे पूछेंगे कि क्या आप ये सब करते हैं. ये तो डर्मेटोलॉजिकल प्रोसीजर्स है. दूसरी चीज पीआईएच बोले थे ना अभिषेक? अच्छा, तो वो तो देखिए क्या है कि मेडिसिन में हमेशा कॉम्प्लिकेशंस होते हैं. मेडिसिन जो होती है उसमें, कोई भी मेडिसिन, खाली डर्मेटोलॉजी में नहीं, किसी भी मेडिसिन में हमेशा कॉम्प्लिकेशन होते हैं. तो कॉम्प्लिकेशन इलीगल नहीं है, कॉम्प्लिकेशन पनिशेबल नहीं है. 2 चीज़ें इंपॉर्टेंट हैं. कंसेंट, पहली चीज़ इंपॉर्टेंट है कंसेंट, और दूसरी चीज़ इंपॉर्टेंट है कि जब कॉम्प्लिकेशन हो रहा है तो चिकित्सक उस कॉम्प्लिकेशन को जल्द से जल्द रिकॉग्नाइज करें और उसको रिवर्ट बैक करने की कोशिशें करें. अगर माननीय न्यायालय यह देखता है कि आपने उससे सहमति ली हुई है, नंबर 1, नंबर 2, आपने टाइम से रिकॉग्नाइज किया है उस कॉम्प्लिकेशन को, और नंबर 3, आपने समस्त वो चीज़ें की हैं जिसके द्वारा वो कॉम्प्लिकेशन मिनिमाइज किया जा सकता था, तो यू आर नॉट गिल्टी इन अ कोर्ट ऑफ लॉ. यू आर नॉट गिल्टी इन अ कोर्ट ऑफ लॉ. और एक चीज जस्ट बोलूं, बहुत से लोगों को ये दिमाग में है वो क्रिमिनल नेग्लिजेंस नहीं होता है, क्रिमिनल लॉज नहीं अप्लाई होती हैं मेडिकल नेग्लिजेंस पर. ऑनरेबल सुप्रीम कोर्ट एक लैंडमार्क जजमेंट में, जेकब मैथ्यूज वर्सेस स्टेट ऑफ पंजाब का एक लैंडमार्क जजमेंट था, उसमें उन्होंने कहा कि मेडिकल नेग्लिजेंस में क्रिमिनलिटी तभी आएगी जबकि आप दूसरी आंख पर ऑपरेट कर दिए हों. करना किसी और को है, कर किसी और को दिए हैं. या यू, एंड दिस इज आई एम कोटिंग एड वर्बेटिम, या यू हैव ऑपरेटेड ऑन द रॉन्ग लिम्ब. व्हाई इज देयर नो क्रिमिनल लाइबिलिटी फॉर मेडिकल मैन? देयर इज नो क्रिमिनल लाइबिलिटी फॉर मेडिकल मैन बिकॉज, फॉरेंसिक भूल गए होंगे आप, क्रिमिनलिटी को स्टैब्लिश करने के लिए मेंस रिया की जरूरत होती है. मेंस रिया का मतलब एक लैटिन टर्म है जिसका मतलब होता है इच्छा. तो कोई चिकित्सक इच्छित रूप से अपने मरीज को ट्रीटमेंट करते समय नुकसान नहीं पहुंचाना चाहता है. यही फंडामेंटल बेयरिंग है. तो जब मेंस रिया नहीं है तो क्रिमिनलिटी नहीं हो सकती है। तो ये डराना धमकाने वाले जो लोग कहते हैं ना मुकदमा हो जाएगा, जेल चले जाएंगे, एफआईआर दर्ज जो है, बकवास है। हाँ, कहाँ पर रेमेडी अवेलेबल है? सिविल सूट में रेमेडी अवेलेबल है और कंज्यूमर कोर्ट में रेमेडी अवेलेबल है, और दोनों सिविल प्रोसीजर्स हैं जिसकी एक अपनी प्रोसीजर है। एक वकील कर दीजिएगा, मुकदमा लड़ेगा, वो एफिडेविट फाइल करेंगे, आप काउंटर एफिडेविट फाइल करिएगा, वो घूमते रहेंगे, आप मरीज देखते रहिएगा, वो पैसा का नुकसान करेंगे, आप पैसा कमाते रहिएगा। लेकिन डरिएगा मत, कुछ नहीं होने वाला है, क्योंकि इट इज सिविल लाइबिलिटी। सिविल लाइबिलिटी से क्या डरना? सिविल लाइबिलिटी तो घर घर में 5 भाई मिलकर मुकदमा लड़ रहे हैं 48 साल से, तो उससे क्या डरना?
Sir, I have 2 questions. First thing, you have talked about the advertisement. Many times we have seen that this toothpaste had some Sensodyne or something like that, and one dentist is coming. I'm just quoting a dentist, not a dermatologist. So, what are the parameters where the association can advertise? Sometimes dental association or even Indian Medical Association ad is coming and one stamp of Indian Medical Association is there. So what is the parameter as per the land of law in India? What are the parameters for advertising either hospital or clinic, or you have already cleared that a doctor cannot advertise? So many a times we have seen a big hospital having a big sign.
I got your point. I got your point. Let us not extend it. First question. I'll answer the first question.
Second question.
Please let me answer the first question first.
Okay.
I will take the second. He raised a point. So in Vivek Malpani, Dr. Vivek Malpani from Mumbai, IVF specialist versus State of Maharashtra, the Honorable Supreme Court has laid down certain guidelines. What are the guidelines? Hospitals do not come under the NMC Act. So therefore they are barred from the medical ethics regulations. They have nothing to do. So your individual clinic, जैसे चैतन्य स्किन क्लिनिक, हालांकि मेरा नहीं है लेकिन मैं बोल रहा हूँ, चैतन्य स्किन क्लिनिक अगर नाम है तो आप खूब एडवर्टीजमेंट कीजिए चैतन्य स्किन क्लिनिक के नाम पे, कोई रोक टोक नहीं है। लेकिन जहाँ वहाँ नीचे लिखेंगे डॉक्टर अजय कुमार झा MBBS MD, तो बस खत्म कहानी। समझ गए मेरी बात को? आप क्लिनिक के नाम पर जितना मन करे उतना एडवर्टीजमेंट कीजिए, कोई रोक टोक नहीं है, लेकिन आपका नाम नहीं होना चाहिए वहाँ पे। आपकी फोटो वो सुंदर वाली जो कंप्यूटर से छांट छूट के बनाई जाती है सन 1913 वाली, वो भी नहीं लगी रहनी चाहिए। ठीक है, फर्स्ट क्वेश्चन का आंसर।
Second question, when we do procedures, we have this informed consent form. So what are the point we should take in our informed consent form so that we are in safe position while practicing?
Okay, got your point. So just something missed from the last question. Who can advertise? Associations can advertise, medical associations. Your clinics can advertise, your hospitals can advertise, they all can advertise, but the individual medical practitioner cannot advertise. ठीक है, clear about that. Now next, coming to your next question, that what is the
What is the body should be the body?
हाँ ठीक है, consent. ओके, तो कंसेंट का खट 4 चीजें बता देता हूं। देखिए, इंडियन पीनल कोड में अब तो BNS हो गया है, अगर आप किसी की बॉडी को छूते हैं या उस पर अग्रेसिव होते हैं तो आपको उसकी सहमति की आवश्यकता होती है। यदि यह कार्य किया जाता है बिना सहमति के तो उससे इंजरी कॉज होती है, अतः आप क्रिमिनली लायबल हो जाते हैं। बात को समझ गए? स्ट्रेट फॉरवर्ड चीज। हमने आपको गले लगाया, वहां तक तो ठीक है, और हमने एक घूंसा आपको पेट में मार दिया और सहमति आपने नहीं दी और आप जाके कंप्लेन कर दिए कि हमको ठोड़ी मार के ये सब मारे हैं, ढूंढी पे पक से पेट फूल गया मेरा, तो आप समझ लीजिए कि यू आर क्रिमिनली लायबल। लेकिन आप अगर कह देंगे कि नहीं हमने उससे कहा था एक घूंसा मारो, तो वो नहीं, वो मामला वहीं खत्म हो जाएगा। ठीक वैसे ही है, इंजरी आप कॉज करने जा रहे हैं तो हम लोग जो हम लोगों के जो 4 स्टेप्स थे जब डॉक्टरी पढ़े थे, तो पहला क्या था? इंस्पेक्शन ना। दूसरा बोलिए, भूल गए? इंस्पेक्शन के बाद परकशन, थोड़ा सा सुनाई नहीं दे रहा है। ऑस्कल्टेशन,
पाल्पेशन।
ठीक है, तो पहला, हाँ आप देखिए याद आया कम से कम, नहीं तो डर्मेटोलॉजिस्ट तो भूलते ही जा रहे थे सब चीज। तो पहला है आपका देखना, दूसरा है पैल्पेट करना, तीसरा है ऑस्कल्टेट करना, परकस करना।
परकशन।
तुमड़ी बजाना, और चौथा है ऑस्कल्टेशन। इसमें से ये चारों चीज़ें जो हैं ये कंसेंट में आती हैं, इसके लिए कंसेंट की आवश्यकता नहीं होती है, ठीक है। इसको बोला जाता है इम्प्लाइड कंसेंट। मरीज आया आपके कमरे में, उसने रजिस्ट्रेशन पर 113 रुपए की आपकी पर्ची कटवाई, हालांकि 113 मैं गलत बोल रहा हूं, पर्ची कटवाई, तो वो इम्प्लाइड कंसेंट दे दिया है कि वो अब आपको दिखा के जाएगा। तो इसके लिए कोई कंसेंट की आवश्यकता नहीं होती है। कंसेंट की आवश्यकता कब होगी? जब आप उसके मुंह को डर्माब्रेड करने लगेंगे, जब आप पील लगाने लगेंगे, जब आप सुई लगाने लगेंगे, तब आपको कंसेंट की आवश्यकता होगी। और कंसेंट की 4 बेसिक चीज़ें हैं। एक तो मानसिक रूप से अस्वस्थ नहीं होना चाहिए जो कंसेंट दे रहा है। दूसरा, जिसके ऊपर कार्य किया जाने वाला है वही कंसेंट देगा। हमने देखा है बहुत से लोगों को कि बहू भरती है और सास से कंसेंट लेते हैं, ठीक है, तो वो नहीं होना है। द कंसेंट हैज़ टू बी गिवन बाय द पर्सन ऑन होम द प्रोसीजर इज टू बी डन, नॉट बाय एनी अदर पर्सन। और मानसिक रूप से सुदृढ़ होना चाहिए वो। बिलो 13 ईयर्स ऑफ एज नहीं होना चाहिए। बिलो 13 ईयर्स ऑफ एज को सिर्फ पेरेंट या गार्जियन कंसेंट दे सकते हैं। 13 और 16 के बीच में जो एज है उसमें अगर हम लोग दोनों से कंसेंट ले लें तो अच्छा है, वरना इमरजेंसी कंडीशंस में 13 और 16 के बीच में वो पर्सन खुद भी कंसेंट दे सकता है, ठीक।
Thanks a lot, sir.
जस्ट अ स्मॉल स्टेटमेंट ऑन ऑफ लेबल ड्रग्स है। इतनी ज़्यादा यूसेज है कि हमें खुद को भी कई बार पता नहीं होता है कि हम लेबल है कि ऑफ लेबल है। तो इज इट बेटर टू जस्ट प्रिंट इट अंडरनीथ समवेयर दैट द मेडिकेशन यूज्ड मे बी ऑफ लेबल ड्रग्स?
थोड़ा हाफ चलेगा, अभी तो मैं सोचा नहीं हूँ इस बारे में, लेकिन जो आप कह रहे हैं और मेरी बुद्धि जितनी काम कर रही है, यदि आप लिखते हैं ऐसा तो आपको कुछ प्रोटेक्शन तो मिल जाएगा।
So जैसे एटॉपिक डर्मेटाइटिस सिंपल सा है, उसमें सारी मेडिकेशन ऑफ लेबल है।
आप लिख सकते हैं कि इसमें से कुछ औषधियाँ ऑफ लेबल यूसेज में भी की गई हैं।
हाँ, राइट,
ठीक है,
थैंक यू।
वो कर सकते हैं बस ना।
Thank you very much, sir. You have well explained the intricacies and the legal aspect of donor practice, and we were enlightened a lot. Thank you very much, sir.
Thank you so much, sir, for this wonderful enlightening session. For the next session, I would like to call upon the stage Dr. Ajay Modi and Dr. Abhishek Kumar Jha, sir, to kindly chair the session.
Good evening, everyone. For the next session, I would like to invite Dr. Barunesh, our own Barunesh. I have seen him since PG days. He has been a bright student. He won even the PG quiz of IDVL, and he is doing very well. Leading practitioner in Muzaffarpur. I invite Dr. Barunesh for the next session. Over to you, Barunesh.
Is it showing? Okay. Good afternoon, everyone. It would be a very short topic. Non-melanoma skin cancer, early diagnosis in Indian context. Why do we need to diagnose non-melanoma skin cancer as early as possible? This would be my flow of presentation. I'll show why early diagnosis and late diagnosis, and I will compare both, and I'll show why early diagnosis is required. Then I'll briefly summarize introduction, etiology, diagnosis, and management of non-melanoma skin cancer. Okay, coming to case report 1. I got a call around 1 month back from a dear friend of mine. He's a pediatrician. He showed me, he sent me few pics on WhatsApp. Received few pics from the fellow pediatrician of his mother. Elderly, 70 years, erythematous annular plaque on waistline for 6 months, not associated with pruritus. As all our friends do, they give clotrimazole and beclomethasone was used for past 15 days, and with no response. I asked him to show his mother to my OPD, and after 1 month, she came to my OPD. On examination, on palpation, it was hyperkeratotic plaque. It was a bit hard to feel. Okay, so this was the lesion. The two sites of biopsy, 4 mm punch biopsy, can be appreciated, and biopsy was suggested. 2 active site biopsy, 4 mm was taken. Provisional diagnosis of seborrheic keratosis, Bowen's disease, lichenified tinea, or hyperkeratotic eczema was made. Okay, so this was the histopathology slide which was received. This is again the histopathology slide that which was received. In that, it was seen that there was acanthosis, parakeratosis, high-grade dysplasia. So this was a case of Bowen's, which was treated like tinea by my colleague, pediatrician. So I asked him, because in our SKMCH, there's also Tata Memorial Cancer Hospital. So asked him to get a review in that Tata Memorial Cancer Hospital. Wide local excision with 1 centimeter margin was done, and there was plan of follow-up radiotherapy after 6 months. So early diagnosis here prevented the worst outcome. And again, now coming to my case report second, and why in this late diagnosis led to a very poor prognosis or a fatal outcome. So case report 2. This is a old case. 45 years male, ulcer on frontoparietal region, oval, 14 into 10 centimeter, well marginated, focal hyperpigmentation border. Duration was more than 10 years. Histopathology was done, local anesthesia and incisional biopsy was done. So this was the case. This was a very big, giant case of basal cell carcinoma. Okay, this was the histopathology slide in 40x, and this was the histopathology in 100x. So dermis was infiltrated with basiloid cell nest. There was peripheral palisading was seen. Tumor stroma was sclerosed, and epidermis was edematous as well as necrosed. So prognosis, the patient was lost to follow-up, but the patient party or attendant told that because of repeated infection, there was a case of sepsis, and the patient died. It was not a case of metastasis, because in BCC we all know metastasis rarely occurs. So now coming to introduction, non-melanoma skin cancer, commonest in Caucasian. Basal cell is the most common which we see. It's almost 75% of the cases, with very rare metastasis raised, less than 0.1. Cutaneous squamous cell carcinoma arising from dysplasia. Rate of metastasis is very high, almost 1 to 3%. Etiology, what we see, it's a combination of environmental, genetic, and phenotypic factors. Most important risk factors is environmental exposure to ultraviolet light. So we have seen increased incidence in sunnier climates. Lower risk in dark skin types, majority of tumor arising over sun-exposed skin. BCC has been more associated with intermittent and childhood sun exposure as compared to squamous cell, which is more related to chronic UV exposure. UV light is thought to induce direct DNA mutation, covalent bonding between adjacent pyrimidines, and formation of reactive oxygen species in UVA. So phototherapy, which we very commonly use, we use mostly puvasol as well as narrowband UVB. Puvasol is very highly mutagenic. So puvasol, it's more in Sorlin photochemotherapy, less in case of narrowband UVB. Sporadic BCC develops de novo. SCC, there is always a precursor actinic keratosis or Bowen's disease, and there is multi-step accumulation of genetic damage. Over 72% of SCC have been noted to develop with precursor actinic keratosis or in actinically damaged skin. So what are the genodermatosis associated with non-melanoma skin cancer? BCC, nevoid basal cell carcinoma, xeroderma pigmentosa more in SCC than BCC, and then epidermolysis bullosa more in dystrophica and equisita, less in simplex, and KID syndrome and epidermolysis dysplasia verruciformis. Okay. So diagnosis, how do we diagnose? Mostly clinically, with exception of BCC of superficial subtype, majority of NMC arise over sun-exposed area. SCC tends to present as rapidly growing pink or red nodule, which may be hyperkeratotic or ulcerated. The clinical features of BCC depend on the subtype. Nodular BCC is the most common, more than 60% of the case. Present as pink nodules with rolled edges, surface telangiectasia, ulceration or crusting. Okay. So dermoscopy. Dermoscopy we use, right now we use it very what we find, leaf-like areas, blue-gray blotches, sometimes red blotches are also seen, wheel-like spoke area, arborizing blood vessels. We can see it very clearly on dermoscopy. Skin biopsy, in addition to confirm the diagnosis, allows the stratification of tumors in high risk as well as low risk malignancies. So management of high risk BCC and SCC is mostly is done if we have frozen section in our hospital setup. Otherwise, it's very easy to refer to patient to a higher center. If Mohs is not available, we don't have a histopathology with frozen section. We can excise with predetermined wide margins, and histopathology we should always look for the margin should be clear of any cancerous lesion. So in histopathology, they always see the margin was clear of any cancerous cells. So that is very helpful in histopathology. Topical treatment is usually reserved in patient with low risk BCC. Okay. Okay, BCC, if the tumor size is greater than 2 centimeter, then an anatomical site over central face and recurrent BCC, we can go for excision. In SCC, if the tumor size is greater than 2 centimeter, tumor thickness is greater than 4 millimeter, poor moderate histological difference, then we can go for excision. Standard excision with predetermined margins, we go, and a 5 years cure rate for with predetermined margins for BCC is very high, and also for SCC is very high. Once the tumor has been entirely removed with Mohs, the examination to see that predetermined margin which should be required to completely excise the tumor. 3 millimeter margin has a success rate of 85, and 4 millimeter wide margin in Mohs, 98% of BCC would have very high histological cure. Radiotherapy is effective for selected patient, and it also decreases the chance of recurrence. In efficacy is overall lower than Mohs or standard excision with predetermined margin. Cautery and curettage we do, but cautery we can do with cut mode, and then it should be sent for histopathology. Cryosurgery. Cryosurgery involves the liquid nitrogen freeze and thaw cycle. In even cryosurgery for small BCC as well as small SCC, high cure rates have been reported. PDT we don't generally use, but it's also indicated with 5-amino-levulinic acid and MAL can be used. Imiquimod is a very good drug, and I have used Imiquimod alternate day treatment in small size of BCC. And Imiquimod, the recurrence rate may be high, but the lesions clear. And 5-fluorouracil, both 1 and 5% are available. 5% we mostly use. There is irritation potential, but we have to explain that to the patient. There was a small study published showing 90% histological cure rate at 16 weeks of 5% 5-fluorouracil. Okay, prognosis. Patient with BCC are 10 times risk of developing a further BCC in comparison to general population. Last week only I read Michael Clark, Australian captain of winning 2015 team. He had gone 9 excisions for basal cell carcinoma. So if patient gets a one-time basal cell carcinoma, he should be monitored very closely. Despite the increased risk, no long-term follow-up is required for BCC when the primary tumor has been cured, but still, at least once every 6 months is recommended. 95% of the recurrence of SCC occur within the 5 years, with 70 to 80% of this recurrence occur within the first 2 years. So in SCC, it's very, for first 2 years, the patient should be asked to follow up every 3 months, and after 2 years, every 6 months. Sentinel lymph node biopsy have been reported to identify early microscopic lymph node metastasis. So in sentinel lymph node is always checked, especially in squamous cell carcinoma. There was a case of alveolar carcinoma. He came to me, it was long back. Sentinel lymph node was done, FNAC was done on the sentinel lymph node. It was very normal. Once, the sentinel lymph node, it was just reactive lymphadenitis, there was nothing else. The patient said that, sir, बेटी की शादी करनी है, give me 1 month आप दे दो, उसके बाद फिर आप local excision कर देना. So after 1 month when the patient came, the lymph node was very hard to feel. I asked the patient to get the FNAC repeated. The FNAC, the sentinel lymph node was positive, and the patient had adverse outcome. So even 1 month delay in a case of SCC is very big delay. So in SCC, every day matters, okay? So these are the references for my slide. You can go through them, and I'm open for any questions. Thank you.
Thank you, Dr. Bhavnesh. Any question from the audience? So thank you, Dr. Bhavnesh, for just finishing on time. Wonderful presentation. Thank you so much.
Thanks a lot.
Excuse me, 1 minute, please.
Sure.
Have you gone for CT or PET scan in SSC?
Sir, in SS...
If lymph node is positive then?
If lymph node is positive, if the sentinel lymph node is positive, then I don't think there's any need of CT. But if it's not the sentinel lymph node, if there are other lymph node positive, then there's a case of metastasis. And it's better to go for, refer the patient than go for PET scan.
Because nowadays it's a protocol, oncosurgeon follow, go for the CT and PET scan.
PET scan in the sentinel lymph node itself?
Yeah, everything. It's a protocol.
Sure. Thank you, sir.
Thank you, sir, for such an enlightening session. For chairing the next session, I would like to invite on stage Dr. Dilip Kumar, sir, and Dr. Pankaj Kumar Agrawal, sir. Please come on the stage to chair the next session.
Hello. Good afternoon, everyone. The next speaker is Dr. C.S. Chirka. He is Professor and HOD, AIMS Bhubaneswar. He has a lot of presentations, more than 50, more than 108 publications. He is recipient of Dr. S.C. Mohanty Oration Award, R.N. Datta Memorial Oration Award, Dr. M.A. Wali Oration Award, Rekha Rani Memorial Oration Award. So I would request Dr. Chirka to please give his talk. Thank you.
Thank you, sir. Thank you very much, sir. Good afternoon, everyone. Today I have been given the clinical pulse on the sport diagnosis. I didn't know where to search for this one, so I do have to just recall some of the old teachers whose skill I would like to share some of them, so you may like them. So that is what I did, because Dr. Abhishek Jha and Dr. Vikas, they rang me off and they said that you should speak in something which could be new to the people. This is what I understand over the years, is that you learn from two parts. One is from the book and another is from the veterans, you learn from these people. What is that you learn when you learn from these people? This one just you do have to remember from the book. But when you learn from the veterans, you learn different things. They teach you some different skills, something like what to listen, what to record, what not to listen, what to hear, what to speak, what not to speak. Same time, they teach you the discipline, what is the diagnostic discipline. And the higher skills that you learn in the post-graduation. And they also teach you that how to relate the changes occurring on the disease to the surrounding. This is what they teach you. If you are just simply reading this book that I told, it can teach you. So that is why there is no replacement for a guide. That is why also in the post-graduation, when the student comes in, we try to give them a guide so that he can interact on every patient. Because every patient is a challenge and he has to have new ideas from the guide. For example, if you read in a book, it tells you something different, but if you go to a guide, he will tell you like this. He makes it very simple. He tells that it starts as a papule, the moment it enlarges, it changes its pigmentation, and it looks like this. So that means he makes it very clear. But if you read the book for a lichen planus, it tells that it is a polygonal. I don't see any lesion is a polygonal at all. They say about pruritic, you cannot see a pruritic on a patient unless you ask. That means you do have to really listen to the guide. He will tell you that how to see. So he will tell you the tricks that how to make a diagnosis immediately looking at a lesion. That means a papule of a skin color enlarging and having a scale and having a pigmentary change. That is lichen planus. Similarly, there is another disease. If you look at that, this one is in psoriasis. But how it is psoriasis? He will tell you that your guide will tell you that when you have, they start as a papule, once it enlarges, it becomes a red and scaling. It is just simply different from the previous one, what I told. Only the color difference. Otherwise, that also enlarges and that also scales. Only one thing is here, the red continues to retain where that becomes a black. Similarly, this one, it is an eczema. But how it is an eczema? Only the consultant will teach you that how it is in nebular eczema is all the lesions are of a uniform size. He will tell you that let it be a 30 years, 2 days, 3 days, the grass is always a grass. It will be always a height of around a 10 to 15 centimeters. It cannot be more than that. Similarly, a nebular eczema, it would be a small papules, they will coalesce, they will subside, and they might scale. But it will give a footprint of the lesion that it is a nebular eczema. Similarly, the faculty will tell you some different way. Both the lesions almost look like that, but he will tell you some points which makes it easy for you to differentiate between the eczema and the scabies. Here both the lesions, if you see look at these lesions, they are also papule, here also papule. Only one difference is scabies would be 1 kilometer away from the another, Every time it would be like that. And they will get located over the genitalia and the web space. They will have always a location in that particular area. And if you look at this one, like now there are thousands of lesions. Look at this. There are thousands of lesions, but these areas are spared and there is very less lesions on this area. So there is a very critical things what a faculty will teach you. Similarly, like now, when you look at the erythroderma patients, you are really surprised what to do. Like now, some people could suggest you that like now you can take a biopsy, but a guide will tell you something different. He will tell you that like now, look at the age of the lesion, how they are forming. That would give you an idea. If at the edge of the lesion, if you could see the primary lesion and the primary lesions are papule and they are coalescing, it could be possibly PRP or it could be eczema. But if the primary, like no, sometime you might get this kind of a lesion in psoriasis too. But only one thing he will tell you that like no, he will teach you the mathematics also. He will tell you that if the thousands of lesions are there, for example, this area, not a single lesion is larger. Had it been in psoriasis, all the lesions will not appear at the same time. There would be some lesions which will enlarge self and they will continue to retain that one. That means the faculty will teach you all the things and that is why in post-graduation, we always give a guide. The moment you walk into the department, they will give you a guide. Coming to this one, this is like, no, some people would say that like, it could be an hyperkeratotic eczema or could be a psoriasis. Only one thing is psoriasis is a papulosquamous disease. You do have a papule followed by a scale. But if you look at this lesion, there is a pigmentation up to this much and portion of the lesion is having a scale, indicating that it is not a papule and that too the entire lesion is not scaling on a portion of that. This is hyperkeratotic eczema. Had it been a psoriasis, it would be a papule and it will have a start scaling from one end to another. If you look at these lesions too, there are a portion of the lesion like now this area is spared, almost looking normal, but it is hard. But this one is in pigmented and scaling. So it will have that kind of an end-to-end lesion will not be there. In psoriasis, from one end to another, you will have this kind of an changes. Sometime recently we found like there is something like we are having a really difficulty in treating lichen planus of the oral cavity. So we wanted to do something like what it could be. Like the faculty will teach you something different. If you put it in the night mode, it would look like this. That means you could able to see the multiple circular erosions are multiple are there and they are not visible obviously on a normal mode. But if you are putting on the night mode, it will show you that the tongue is having multiple herpetic ulcer. And when there is a herpetic ulcer over the lichen planus, it will have both the way. The lichen planus will get into a cognarization and it will become more severe, and this lichen planus is an abnormal skin that will also trigger the dormant herpes from the dorsal root ganglion. It will come back again. So that is why these people continue to have a disease for a prolonged period of a time. When you see this kind of lesions, you must put them on a night mode and try to see that whether there is a coexistence of an HSV and you can treat them both simultaneously. At least you can retain, suppress the disease to a certain extent. We also saw some interesting finding. Now these days you will be seeing these changes more. The genital eczema is more in there and they are not responding most of the time. And if you put them in the night mode, you see that it does also have the similar kind of changes. So you should be careful that if the genital eczema is not improving, it could be a coexistence of an herpes along with that one. Now these days also I am seeing coming across this kind of lesions on the genitalia. It looks like a vitiligo to me, but why these patients keep coming to me that I was worrying? So I wanted to put that same technique. When we found something interesting. There is an episodes of an erythema. The same patients having an episodes of erythema coming over here. It is a deep-seated hemorrhage induced by HSV-induced vasculitis is causing this kind of changes. If you ask these patients, they do say, I do have a certain pain, episodically it is coming to them, and it is more obvious when they are having sexual contact. So you have to be careful about in this one, otherwise you will be just treating them just like an vitiligo, but actually they are different. There is a post-traumatic depigmentation induced by HSV. This is a new lesion we show. Suddenly we applied the same technique. We could able to see there is, you see that like, these lesions are there, and precisely the red is here on this one. And there is also the red which is over here. This is also in HSV. When you treat them, you may not be able to cure them fully, but you would be able to control them and give them a long duration of remission, or the severity of the recurrence would be less. Now, why this one? You must be worried that, like, why this so many thoughts have not come along back and why it is coming. Now the theory of exposome has come. Now we believe that somebody is exposed to the surrounding and the surrounding is going to have a change on him. The changes could be like this. That's what I saw is that, like, people lived in village, they had a cow shed, and now they live like this. They live in a modernized world, and even like, they change the environment surrounding them. Now, if you do this kind of changes surrounding you, then what you are going to see? You are going to see this one. You are going to have a more expression of an atopic diathesis to atopic dermatitis. And if you have an HSV sometime, if you acquire it, it is going to remain a lifelong within your body. And it can get triggered when this atopic dermatitis will reactivate. And if you are using an artificial intelligence, then you might tend to have a self-medication, and sometime if you are using a drugs like in topical steroid, you are going to have this thing. So that means in the modern age, these are the commonest risk factors that you are going to have. Atopic dermatitis, and if you're unlucky, you can have an HSV infection, and sometime you might tend to use this one. Then what will happen? It will cause something different. Like, for example, I can talk more about an tinea. So what you can do is that, like, you can have this. If you have an atopic dermatitis, you can induce a post-traumatic eczema. The eczematous changes precisely occurring on the lesion. And if you wear a tight jeans, then you might cause an injury over that area. You might have a tinea, and the tinea can induce a post-traumatic eczema over there, and it can continue to remain for a pretty long time. And if you have an HSV, you can have HSV-induced immunological vasculitis, and within that and tinea lesions, you might have vasculitic changes. And if you use an topical steroid, possibly it will get absorbed into the abnormal skin, and this absorbed skin, the cumulative dose, could induce episodes of erythema because of the vasodilation. It might come, and once it subsides, it will subside with a scale, and that can confuse you for a tinea. So this is what you can have. Now, it needs some kind of a, clinical discipline, because I told, clinical discipline, only the faculty will teach you. This is what we learn. You have a history and this one, but now they will tell you that, since so many factors are playing, they will tell you something different. They will tell you that you got to acquire so many skills for making a clinical diagnosis. That means you do have to verify the information, what the patient is telling. If the patient is telling that my lesions is increasing, you do have to verify whether he is telling the truth or he is telling you the lie. So now we do is that, we mark the border of the lesion and try to watch them for years. We found that the tinea lesions are actually not spreading. And once you are on the clinical diagnosis, then only it will pave the way for a test and this clinical diagnosis and treatment. This is indiscipline. If you are not doing this one, if you are not verifying and everything, then it is indiscipline. And if you are doing a reverse way, if you are doing a test and trying to make a diagnosis, that means it is a blunder. So you have to be very careful about that one. So otherwise, you are always thinking that I have done a test and this is correct. So that is why the history is more important. Otherwise, you might get into a blunder. Let me give you one example. For everyone, this is tinea. If you do a test without making a diagnosis, then it can become like this. You see this. So you might get this one. So that means you must have a clinical diagnosis so that you can interpret the finding. If you don't have a clinical diagnosis, you cannot interpret the finding. So that is what is more important. This is what we did. When you follow up, what you get. If you admit and mark the border and follow up, you see this one. What you see is that the lesions are not spreading. They are within that. And they are having a diverse changes during the course of time. So now what does it mean? They are contrary to the features of a tinea. the episodes of recurrence are contrary to the pharmacokinetics of the drug, because a drug like itraconazole, if you give, it should stay on the skin for around 4 weeks, but this recurrence is occurring again and again. So that means if you have a look at that one, whatever we are thinking it to be the tinea are actually not tinea. So now you do have to make a diagnosis, what is it? So this is the scale that the people use, the Bloom's taxonomy. This is MBBS scale. The lowest scale is an MBBS scale. Just you do have to remember what is written in the book or what is written in the photograph. And there are some rules and regulations are given. But if you are doing a post-graduation, you do this one, you create a new, that means you break the information, give a value to that one, and give a combination and give an idea. This is what, that is why you are supposed to make a new diagnosis when there is a difficulty. Thank you very much.
Thank you, Dr. Sekia Sahib. Any question from the audience, please? He gave us a very wonderful talk. Any questions, please? Thank you. Thank you.
Thank you, sir, for such an enlightening session. For the next session is going to be a very interactive one. I would like to invite our speaker, Dr. Nilay Kanti Das, sir, on the stage for our session on hands-on workshop on statistical analysis for our PG students present here. Dr. Nilay Kanti Das, sir, please come forward on the stage. Dr. Nilay, sir.
Just a minute. स्लाइड चेंजर लगा दूं? हाँ, स्लाइड चेंजर लगाइए. नहीं आ रहा है. Sorry people for keeping you waiting. How many of you are PGs out here? I want to see raise of hands. Have you got laptop? You have got? Okay. So it will be kind of mix, ma'am. So the thing is, I'll be taking you through a different kind of a session. I intended to make it a kind of workshop where I'll be giving you some data sheet. I sent you a data sheet. Have you got the data sheet? Okay, so we'll be playing with the data actually. Means with every workshop, in every lecture, you used to say, like how to calculate sample size. I wanted to give you the flavor of how to really calculate the sample size. Name some statistical software you have heard of. Yes? SPSS, have you worked with it? Yes. So working with SPSS is really tough. Means importing the data itself is a large task. I can give you one name of a software. It's MedCalc. When I was undergraduate, my teacher gave me that software. It's one of the most user-friendly software. So I'll be giving a glimpse of it. And of course, we'll be starting with statistics. My intention was that everybody over here will be having a laptop and everybody will be importing the data and will be doing it. But since it's not like that, so we'll be making some change. I'll be giving some intro with the statistics and give you some idea how to do that if you get that software in your hand. Is that good? I don't want to be a monologue. I want to hear your voice. Is that okay? Wonderful. So what is statistics? What is statistics? Means I understand. So tell me, what is lie? Types of lie? Lie, damn lie, and statistics. So statistics is actually named to be condemned. So somebody said, if you need statistics for your research, you should do the research once again. But it's not that. Means you need statistics because PGs out there, you have to submit your thesis. You have to get it published. And what the people, journal people, they ask you, give me statistically relevant results, isn't it? Statistically valid results. So I want to hear from you, what are the hiccup areas you have faced in calculating, dealing with statistics? Anybody? Sample size calculation? Yes? Do you understand how to calculate sample size? I don't go into the details of it. I'll give you some, should I say, tips. When you calculate sample size, why do we do it? We do it because of two things. So that we don't waste our resource. Suppose your results could be valid if you do a study on 50 individuals. If you do it on 60 individuals, that means you are wasting your resource on 10. If you do it on 40, that means your study will not be having the statistical validity. So when you go for a sample size calculation, this is important that you do it a priori. This is the first step of statistics. Statistics is not about p-value. P-value comes much later. When you start writing your hypothesis, start writing your research proposal, there's one thing like sample size calculation, isn't it? So over there, what we want that you should have some data from previous study. I'll give you an example. So this is the interface of MedCalc. No. So when you open MedCalc, the interface will be like this. Over there, there'll be portion. Can you just lower down the projection? It's not all coming inside. It will narrow, do it a bit narrow. Please narrow it. The entire screen is not coming. So there'll be one portion where they'll be having sampling, comparison of two means. So when you open this, you'll find that there's something like alpha error and something like beta error. For your purpose, keep the alpha error at 0.05. These are errors. When you calculate the sample size, that means you are taking a sample from the population. When we'll do the study on the population, you have to extrapolate the result to the population. So your result will be having some error from the population's results, isn't it? There is a population of 1 lakh. You have taken 20. So when you are taking 20, obviously the result is not going to match the population. So that is something that you always expect. So over there, that is alpha error. That means, okay, I'm not going to the details. Keep this alpha error at 5% and beta error at 20%. And then you have to put the inputs. I'll give you an example with the paper. This was our study where we have calculated the mean. So there was a previous study which showed that the difference in mean, there was 2 arm of a study where the difference of mean was 3.5. So this is what will be required when you put in that input in calculation of a sample size and the standard deviation. So what we do, you remember the the values. So difference of mean is 3.5 and the standard deviation is 4.5 and 5 in each. So let's go to that software. So difference of mean was how much? 3.5. 3.5. And standard deviation was 4.5 and 5. So when you calculate, you get that the sample size is 29. The study was, you have to do a clinical trial with 2 arms. There are 2 arms which was previously done by a researcher where they have found that the improvement in a particular score had a difference in the 2 arm of the mean was different by 3.5. And the standard deviation of the 2 arm was 4.5 and 5. So you have to put it like that. When you put it like that, you get a value. So that is the sample size for each arm. But when you do the calculations, you add 10% dropout. Because when you do a trial, always there will be a dropout. So 29 in each arm with 10% dropout becomes 32 in each arm. So this is how you are going to calculate the sample size. Now let's go back to what we have begun. So statistics is not about just colorful graphs or averages. Statistics is collecting data, organize them, summarize them, analyze them, and draw meaningful conclusion. So in statistics, these are the things we really do. What we do? We describe a data. Now we'll be coming to data then. We compare the data. We try to find out whether there is a relationship, this one or that one. Suppose you want to find out whether the psoriasis increases and the arthropathy score also increases. That means you want to establish a relation. So that is one form of a statistical analysis. And the third is, and the most important, testing and hypothesis. And what is hypothesis? Hypothesis is an educated guess. You say that this treatment is going to have a results which is this much more effective than other. You are guessing. When you start a study, you are guessing. And then you have to establish that guess. In statistics, one thing you have to remember, we cannot establish something. We can refute something. So we have a null hypothesis. Suppose you say that treatment A is better than treatment B in a particular condition, condition C, then you say that the null hypothesis is there is no difference. With statistics, you are going to prove that there is a difference. You are going to refute your null hypothesis. So let's see what's happening. So statistics has got 2 major branch. One is descriptive statistics. Another is analytical or inferential statistics. In descriptive statistics, we describe some parameters. These parameters are known as known as variables. These variables can be either a categorical variable. You know categorical variable. Name some categorical variable. I want to hear the PGs. Name some categorical variable. Yes, grading of cancers. Males, females. Means where there is a category. And numerical, where there is a numerical value. Okay. Because this will be utilized later on. In categorical variable, you represent the data with under 3 parameters. One is ratio. Male and female, what is that? Ratio. Then is proportion. What is the difference between ratio and proportion? Absolutely. So, proportions of male in a population. One way is male to female ratio or proportion of male in a population. And what is this percentage? So, it is the proportion when you express in 100. The proportion of male was 0.3%. Then the percentage is 30%. Got it? So whenever in your thesis, in your study, you have to represent your categorical data, you have to describe the data under 3 parameters. Ratio, proportions or percentage. Now regarding numerical data. A numerical data has got 2 characteristics. One is central tendency. Absolutely right. Central tendency means mean, median or mode. What is the most common this central tendency that we use? Mean, obviously mean. So mean is something in our literature we do use. So we have our central tendency. Why do we need something like a dispersion, measure of dispersion? Do we need it or not? But why? So I just skip them. They are more of a theoretical. I give you an example. So these are 3 shops. These are 3 shops and they have made shoes. And the shopkeeper learned that the mean is 7. Those 7 size shoe is the most common shoe size that people wear. So this shopkeeper was very smart. He made all the shoes of 7. Do you think all the people, they will come to the shop, will be of size 7? No. So his shoes were not selling. But this guy, they made a bit different. So what is that difference? If you know beforehand that what is that range, isn't it? What is that range? Then you will be able to decide whether I should be going from 8 to 6 or 2 to 13. If you don't know the range, then it will be no use. So that's the reason that a numerical data has to be represented under 2 categories. One is central tendency, another is dispersion. So what are the forms of dispersion we'll see? So dispersion can be expressed as range, 2 to 13, 8 to 6, or 8 to 7, whatever. Variance and standard deviation. Have you heard the word standard deviation? Mean plus minus. What do you say? SD. That SD is standard deviation. SD is root mean square deviation. We are not statistician. We are end users. We are not computer engineers. We use a computer. You need not to know how to calculate a standard deviation. I can show you some formula. You had done it in class 12th. Need not to, because we are end users. So what you are going to do is we are going to find the standard deviation so that when you are in the field, you know how to implement the result of the data. And that is the usefulness of your study. When you publish that study, people will get to know this is how you have to go about. So that is why when you represent your data in any of the situation, you have to represent it as either mean and plus minus standard deviation. But if you try to express as median, then usually we give the measure of dispersion as interquartile range. And what is that interquartile range? If you have a range from 0 to 100, you split it into 4 parts. One is 0 to 25, 25 to 50, 50 to 75, 75 to 100. You take between 25 to 75, that is interquartile range. So method of expression will be median with interquartile range. Now we come to very interesting part. So when I was, I'm a teacher, means my students come to me and say, sir, एक p value निकाल दीजिए. आप बोलते हो जाके? हाँ? P value? Yes. P value syndrome. So p value, what is that p value? We have to find out what is this p value all about. We have told you about hypothesis. And hypothesis is an educated guess. So a hypothesis has got null hypothesis, means there is no difference, and an alternate hypothesis. If you prove your null hypothesis is wrong, then your alternate hypothesis has been proven. So our idea always to prove that the null hypothesis is wrong. We always say there is no difference. But when we find a difference, can it happen by chance? It can happen by chance, isn't it? You have all gone through MCQs in your entrance. When you can narrow it down to two options, don't you make an educated guess? Tell me, when you narrow down to 2 options among 4, what are the chances of making a wrong guess? 50%. So making a right guess is 50%. When you don't know any of the 4, what is the chance of making a right guess? 25%. If I give you 20 such alternative and you don't know the answer, what is the chance of getting the right answer? 5%. You convert it into fraction, it's 0.05. And this is the magic figure. In statistics, we accept that if you have got 20 options, making, rather more than 20 options, picking up a right thing without knowing is not possible. So that is p-value. So when the p is less than 0.025, 0.025 means 5%. Then means that there is a significant difference. It has not occurred by chance. So it has not occurred by chance. So let's do some test of statistical significance. If you use statistics, we use statistics to find difference between groups. Suppose you do a study with, suppose, 2 treatment, MMR and BCG in the treatment of viral wart. Then you have to prove that your null hypothesis was, there is no difference. Your alternative hypothesis was, MMR was better than BCG. So you do the study and you prove that your null hypothesis was false. So your alternate hypothesis will stand. And suppose you have to prove an association, psoriasis and metabolic syndrome. We'll be having different statistical method for that. Diagnostic assessment. Suppose you use dermoscopy for various disease. In all the disease, it's not effective, that we all know. So for which disease this dermoscopy is effective, that can be also found out by statistics. The sensitivity, specificity, and what else? positive predictive value. So this is a different kind of a test. And survival trend, I'm not going into it. This is a complex one. So test for difference between groups. Me and Jaidev sir is there. I think I've seen Jaidev sir. So we had published a paper on this p-value once. We have got this logical approach of 3+1 approach. I'll give you just idea and you can implement it. You can take pictures of this while I'm telling, and you can also find it in our article. So 3+1 approach is, first you ask yourself whether the data is numerical or categorical. I think I've told you what is numerical and what is categorical. Because you have to choose which test you have to apply in that instance. After that, if it is numerical, then you ask whether it's parametric or non-parametric. Have you got any idea about parametric or non-parametric? In plain words, if a parameter matches, or the sample parameter matches the population parameter, then it is parametric. Suppose you take the age of a study group. The parameter will match the population parameter, and population parameter is always having a bell-shaped curve. When the bell-shaped curve is skewed, I've shown in the picture before, I've just rushed through them. If it is skewed, that means it's not parametric. If it is not parametric, you cannot use certain tests. So first question you ask yourself is whether it's categorical or numerical. If it is categorical, leave it as such. Then you ask yourself, is numerical, parametric or a non-parametric. Then you ask whether it's paired or unpaired. What do you mean by paired or unpaired? Technically, paired means when one data can influence another data. Suppose a patient of melasma has come to you and you have started treating. So if a person was having a higher grade of melasma in the first baseline session, the improvement will be different if a person was having lower grade of melasma? Yes or no? If a person is having higher grade of urticaria, if you treat it with one medicine and a person having lower grade of urticaria, there will be difference in outcome. So here it's paired data. When you are taking samples, rather value or rather measurement of the same individual at baseline, at say 2 weeks follow-up, 3 weeks follow-up, 4 weeks follow-up. So that becomes a paired data. Understood? Suppose there are two groups. In one group, you are using say belastin. In another group, you are using fexofenadine. You are comparing the groups. This data is not going to be influenced by the other data. They are two different persons. So that is unpaired. And next thing, if it's a group, obviously there will be group. If there are two groups or more than two groups. So let's go with the algorithm. So first ask yourself, is it numerical or categorical? If it comes to be categorical, then what to ask? Paired or unpaired? So if it is unpaired, then ask about whether two groups or more than two groups. Suppose a person having arthropathy. So I'll come to the examples later on. So if there are two groups, you can do two forms of test. One is chi-square test, another is Fisher's test. If there are more than two groups, you have only the option of doing a chi-square test. If it is a paired data, then for two groups you need McNemar's test, and for more than two groups, Cochrane Q test. Isn't it complicated? Yes or no? Yes. You can click picture because it is impossible to remember all these things. But if you have got this thing in your mind, not in your mind, in your, in your phone, you can just check which algorithm you need to follow. I'll give you some examples to it. Suppose we have got a data of of two types of psoriasis, palmoplantar psoriasis and psoriasis vulgaris, and we are measuring arthropathy. So we find a data like this. In palmoplantar psoriasis, the arthropathy is present in 12 and here in 18. In case of psoriasis vulgaris, it's absent in 22. Do you think the ratio is same or different? It is only like 8:22, and here it's 12 into 18. So what is your gut sense says? The arthropathy is more in palmoplantar psoriasis or psoriasis vulgaris? In case of palmoplantar psoriasis. So you feel that it is more in palmoplantar psoriasis. But has it happened by chance? Sir, has it happened by chance? We don't know. Then the statistics will help us to find out whether this difference, that palmoplantar psoriasis having more arthropathy, has happened by chance or not. So let's go back to another thing. Palmoplantar psoriasis, psoriatic arthropathy and gutter psoriasis. There are three groups over here. And with the three groups, we find there is a difference. With gutter psoriasis, it's very less. And it also happened by chance. So this is what we are going to do. Which test we are going to do to find out the p-value. Let's follow this. So arthropathy present or absent? Is it numerical data or categorical data? Categorical data. Is it unpaired or paired? Sir, one person is having psoriasis vulgaris, one person is having palmoplantar psoriasis. So they are not influencing each other. Please speak out. So do you think this is unpaired or paired? Paired means when you do a trial, in simple language, when you do a trial, you calculate from baseline to the second, the follow-up visit. That is paired. And here it's two unrelated groups. So it's unpaired. In the first instance, there was two groups. In the first instance, there were two groups. So you are going to do chi-square test. Or in the next session, or Fisher's test obviously, and the next instance, chi-square test. Should I show you how to do it? Are you interested in MedCalc? Just to give you an example. You remember the values, okay? So in MedCalc, there is one option of tests. There you go for Fisher's exact test. Have you remembered the value? 1218, sir? And 822. 12, 8, or rather 1218, and 8 and 22. Let's test it. The p-value comes to 0.41. So it's not significant. Though we see that there is a difference in the instance of arthropathy between palmoplantar psoriasis and chronic plaque psoriasis, but it is not statistically significant. Got it? So it is not statistically significant. So we go back. So here we are going to do a Fisher's test and here chi-square test. Let's go to another set of situation. You are giving methotrexate in case of psoriatic arthropathy. And you are measuring whether the arthropathy improves or not. So at baseline, suppose the 8 patients were having arthropathy, and after treatment, only 4 are having arthropathy. What do you think? It has improved or not? Yes or no? Before giving treatment, before giving treatment, 8 were having arthropathy, 22 were not having arthropathy, and after giving treatment, 4 are having arthropathy. So there is definite improvement. But is that statistically significant? P-value nikalna hai, sir. So which test you have to use for calculating the p-value? This is the crux of the problem. Because, statistical software, make it your slave. Don't make it your master. So you are going to dictate which test you need and let it find out by yourself. And now you people are going to say, I'll ask ChatGPT. Yes or no? Yes. But with ChatGPT, if you don't buy the ChatGPT, there'll be clouding. Have you heard of that in AI? So sometimes ChatGPT ka bhi dimag ghum jata hai. So it can give you erroneous results unless you know at least the basics of statistics. Got it? So over here, what is the type of data? Categorical data. Yes. And is it paired data or not? Paired data. And here we have to do a McNippers test. So it's the same way. In MedCalc, you put in the data, you'll find the results. So move forward. So here we do McNippers test, and here, since there are more than 2 groups, after 2 months, after 3 months, you have to go for Cochrane Q test. You have got the option with the statistical software. You have the option with SPSS and Jamovi software, and there are many such software there. So let's come to another instance. We are talking about categorical data, and what's the time now? How much time do I have now, from now? 7 minutes. Okay. Suppose there's a numerical data. So first thing you have to ask yourself is, whether it's parametric or a non-parametric. Suppose it's parametric. I think this is some sort of test that you have heard. So if it is parametric, then you ask yourself, it is unpaired or paired? If it is unpaired, I think this is the term you have heard before. T-test, isn't it? Student's T-test. So student T-test is performed if you have a numerical data which is parametric, which is unpaired, and having 2 groups. If it is having more than 2 groups, you go for ANOVA test, analysis of variance. Suppose you have got a paired data. If you have a paired data, here also there will be 2 groups and more than 2 groups. If it is 2 groups, it's paired T-test. I'll give you some examples. And similarly with non-parametric data, we follow the same parameter. The non-parametric parameters, this counterpart of student T-test is Mann-Whitney. And this Kruskal-Wallis we rarely use. Wilcoxon test is this paired T-test, and Friedman's ANOVA. How do you know that it's parametric or not? Your statistical software will tell you. Your statistical software will ask you which test you are going to test for normal distribution. So these are the usual tests. Kolmorov-Smirnov test, Shapiro-Wilks test. So this gives the idea of skewedness. When you ask your software, give me an idea about the normal distribution. So he will give you the idea of the normal distribution. Suppose there is an instance, you are doing peels and lasers in case of, say, melasma, and you are finding out the Marcy's score. So Marcy's score is what form of data? Categorical or numerical? Numerical. This is number. Always remember, all the scores are non-parametric data. Always remember, any scores you find in your study is going to be a non-parametric. It is not going to match the population parameter. So, here what we do, Marcy's score, say about after 6 months, you find some figures. Your null hypothesis was, there was no difference. You have to prove it wrong. So if you have to prove it wrong, so this is the kind of a table that we'll get. So masses score with group A and group B with two different figures. You have to find whether this difference, we find that the masses score at 6 months, it is more at Peel. So do you think Peel is going to have a better results than IPL? Yes, it seems so. But is this statistically significant? Then you have to test it. Then you test it with, we follow the algorithm. Jaidev sir, I was talking about this paper we had published together. So you follow the, the protocol. So this is non-parametric data, unpaired data, because there are two groups. Only two groups are, so you are going to do man-witness test. So you do man-witness test to find out whether this difference is statistically significant or not. I skip this one. So masses score change over 6 months. So you have taken the MASI at baseline and you are judging at 6 months. Does it become paired or unpaired? Paired data, because one data set is going to influence the another one. So here we are dealing with paired data. We have found that from baseline there is an improvement. From the mean has improved from 32 to 24. Your hypothesis was there was no difference. And here we find a difference. So how to prove that the difference is significant? We follow this algorithm. So non-parametric data, paired data, there are two groups. Why? You have assessed only at baseline and at 6 months. Had you assessed at 4 points or 3 points, at baseline, at 3 months, at 4 months, and 6 months, it will become more than two groups. Then you have to go for a different sets of data and different analysis. So in this set, you are going to do a Wilcoxon's test. So with this algorithm, you have to go for Wilcoxon's. And I was referring to this. If there are more than two groups, and this is the most common situation I tell you, you'll find in your study setting. You are going to do a clinical trial. You'll be following the patient up, maybe after 1 month, 2 months, 3 months, and you'll be giving different data. So there'll be non-parametric data, more than two groups, and paired data. And there we are going to do Friedman's ANOVA. So Friedman's ANOVA is something that we do in this situation. I skipped this because we have got 4 minutes left. Okay, mean. Suppose you are doing a study now, tinea is all over, so you are doing a study on with some medicine like group A with medicine A and group B with medicine C and group C with another medicine. So you have got 3 groups and these are number of tinea lesions. So this is what sort of data? No ma'am, it's number. It's not yes or no, it's number. So it's numerical data. It's numerical data and it's parametric or non-parametric. You have to judge by your parametric test and we take it for consider as non-parametric data. With the non-parametric data, there are 3 groups and you have to go for, if it is parametric data, you have to go for ANOVA test. I skip this because we have to, yes. Suppose you have got a research question. Previously we had got COVID and there were like vascular lesion. It can happen with you also, with any of your research question if you find out. So you make this table. We call this table a contingency table. 2 by 2 contingency table. There are 2 rows and 2 columns. When you get 2 by 2 contingency table, there will be one condition like any skin disease present, any skin disease absent, and any of the parameter is raised or not. So here So I told you before, diagnostic test, you have got specificity and sensitivity. So here we have to have the sensitivity and specificity. This is about correlation. Correlation, can you think of a situation of correlation? Any situation in your study, in your thesis? Suppose you have a situation like the arthropathy you measure with a scale, and the severity of psoriasis you measure with a scale. So if you think the arthropathy scale increases with the severity scale of the psoriasis, then you have to correlate. And that correlation has to be done by correlation coefficient. When we review the articles submitted in journal, one of the most common mistake that usually people do, in case of a correlation coefficient, they give a p-value. Please don't give p-value in correlation coefficient. There we need a R value. R value of 1 means this is very strong correlation. That means when the severity increases of psoriasis, the arthropathy increases. R value of -1 means the strong negative correlation. With 1 increase, it decreases. Survival trend, I skip. And diagnostic test we have. I told you before something about sample size calculation. There are 2 types of error, type 1 error and type 2 error. Have you been able to understand and remember type 2 error and type 1 error? Means myself get confused. So I'll show you one picture. Please remember this picture. The doctor is committing an error, isn't it? So when it's positive, obviously, and doctor is saying you're pregnant, it cannot be. So this is false positive. So diagnostic tests saying that you are positive, but it is not, that is type 1 error. A drug says that it improves when in actual it is not able to improve. This is type 1 error. Do you want a drug in the market which claims statistically that it improves, but in reality don't? Do you want the drug in the market? No. So that's why we cut down the type 1 error at 5%. That's why the type 1 error is kept at 5%. On the contrary, this lady at term is diagnosed by a doctor as not pregnant. It's false negative. Means the drug has some benefit, but your study does not yield that results. Okay, it can happen. Maybe the next study will yield results. So you keep that beta error at 20%. You get my point? Why we are so stringent on alpha error of 5% and beta error as 20%. And I think you have heard another term while calculating sample size, it's power. Have you heard the word power? Power is nothing but 1 minus beta. That means if beta is 20%, then power is 80%. I'm skipping, means I'm overshooting my time, so I think I have given you that idea about the sample size calculations. You have to work with this tool. You please work with this tool, and if you have time, maybe we can sit together if you have laptop. So thank you so much. I'd always want that you should spread your wings and embrace the magic of statistics, and you can create some magic by yourselves. Thank you so much.
Thank you, sir. It was really an enticing session on such a difficult topic. So, proceeding to our next session, I would like to invite Dr. P.C. Rath sir and Dr. Raj Kishore sir to please chair the next session. Dr. P.C. Rath sir and Dr. Raj Kishore sir, please come on the stage.
I would request all the faculties to kindly collect their memento just outside the hall after the session. Thank you.
Hello. I will introduce Dr. Yash Upendra sir, who is Associate Professor in HOD, Associate Professor Chandulal Chandrakar Memorial Government Medical College, Durg. He has present 10 papers and 5 publications. And brief of bioskills are MD Gold Medalist, received Global Education Award from International Society of Dermatology, MRCP Skin Fellowship in Trichology from IDVL, and received a scholarship at WBC in 2023.
Thank you, sir. Thank you, sir, for such a lovely introduction. My topic is exosome in aesthetic practice. Exosome was introduced far back in 2008 as a diagnosis and treatment of cancers, but now it is profoundly being used amongst the dermatologists and even the non-dermatologists in the aesthetic practice. Why profoundly used? Because exosomes are powerful molecules and they act as biological messengers. They contain proteins, lipids, genetic material, which they traffic from one cell to other recipient cell. And why are they important? Because they can stimulate collagen, reduce inflammation, improve pigmentation, and boost hair growth. Now the mode of action. These cells are now used in aesthetic practice because they have effect on wound healing as they stimulate the fibroblast cell. They can reduce the free radicals in the cells, delay the senescence of the cells, and also reduce the matrix metalloproteinases, thereby used as an anti-aging agent. Now they also have influence on some immune-mediated disorders because their Th2 and Th1 response mediation. So they are also used in atopic dermatitis and some connective tissue disorders also. They can reduce the melanin production, therefore used in hyperpigmentary disorders. Now how are the exosomes formed? They are basically bilayered molecules, and once they, to start with, endosomes are formed, early endosomes, then late endosomes, then multivesicular bodies, then intraluminal vesicles, and these intraluminal vesicles fuse with the cell membrane and discharge their contents as exosomes. Now the most important part of this slide, of this presentation is, because there are so many manufacturers of exosomes in the market and everyone comes and say to buy theirs, we need to know what to see before buying these exosomes. Most important is exosome sources, because there's some sort of scam in the market going on in which the manufacturers are just selling plant-based exosomes at low prices, and we are also getting attracted by those and we are also buying it. But to be very honest, plant-based exosomes, except the wheat-derived nanoparticles, they don't work because they don't have those CD molecules which can help in the cell penetration. Animal exosomes like those derived from the testis of salmon, they do work but with moderate regenerative effect. What actually works is the human exosomes. Human exosomes are working like mesenchymal stem cells, derived exosomes, fibroblast derived, dermal papilla derived, then adipocyte derived, but at the same time, they are pretty expensive. So if you're ready to buy such expensive products, in that case, only exosomes are actually working. So just a slide showing how the exosomes are formed in stem cell culture and also from plants. Now, other factors which we need to see while buying these exosomes is the country of origin and certification. The GMP certification, certificate of analysis, is very important because if it is not having the certificate of analysis, that means it is not having CD63 and CD81, which are required for the penetration inside the cells. Then the use, its licensing for the aesthetic use is very important. Other factors which are important are the exosome size, because exosome of 30 to 150 nanometer is only working. If the exosome is very small in size or it is very big in size, then they are not working. The sterility and endotoxin free, which has to be. The proper storage conditions are again important, because freeze-dried exosomes are best to use and they need to be stored at -20 or -80 degrees centigrade. The purity of standards, of course, important, like it should be having less than 1% extracellular vesicle contamination. Again, the important thing is the content, the concentration of exosomes, which is like 1 to the power 10 to 6 to the power 10 to the 12, which should be present for them to be active. Indications, as already mentioned, they can be used as an anti-aging agent. The exosomes which are mainly used are amniotic fluid-derived exosomes, they are mesenchymal cell exosomes, then the acne scar revision, which is nowadays quite used. They are also mesenchymal cell-derived exosomes, amniotic fluid-derived exosomes, hair growth stimulation, dermal papilla cell-derived exosomes, adipocyte-derived exosomes, and the mesenchymal cell-derived exosomes. These three work best for hair growth stimulation, whereas there are other also in the market like fibroblast-derived, keratinocyte-derived, but they have limited efficacy. In pigmentation management, the one which works best is the adipocyte mesenchymal cell exosomes and the keratinocyte-derived exosomes. Amongst the animal one, the milk colostrum-derived exosomes, bovine milk-derived exosome, and animal exosome, but it works well as it is having some lightening effect and also hydration. Now this is a chart which is showing which are the exosomes working where. For the wound healing, the endothelial progenital cell exosome and mesenchymal stem cell exosomes work best. For hyperpigmentation, keratinocyte-derived exosomes and those derived from the amniotic stem cells are working well. And for the hair, as already said, dermal papilla cell-derived work well. Now, again, the mode of administration. We don't have any consensus, any recommendation regarding how to use exosomes because the clinical trials are still on. So, how to use it? If you are using it, the safest technique to use exosome is to apply it topically after doing microneedling for derma roller or derma pen or radiofrequency device or a fractional CO2 laser. This can be used in both acne scars, melasma. For hair loss, some people are documenting scalp injections, although not recommended much, and after administration after microneedling. In this, sorry. Here I'm showing, here there's a picture of administration of exosomes after fractional CO2. We have done a case in our center in which we have done half phase with full phase was fractional CO2 was done on full phase, and on half phase application of exosome was done. On the half phase just a placebo effect, nothing was done there. But we saw that redness was less on the side on which exosome was applied, and patient satisfaction level was higher where exosome had been applied, but the difference was not statistically significant. Now, exosome administration protocol, as the previous case series have shown, exosome dosage is for face, it is 1 to 2 ml per session. For scalp, 2.5 to 5 ml per session. Under eye, it is 0.2 to 0.4. Neck, 1 ml. And for scar, 0.2 to 0.3 ml per scar area, or 2 ml for both the cheeks and acne scars. The frequency in intense protocols, we can use it weekly for 4 sessions or initial treatment, although it sounds really absurd to use like that. We normally go for fortnightly treatment. Maintenance therapy can be done like once in 4 to 6 weeks. Scalp AGA, monthly sessions are given, followed by quaternary maintenance sessions. Here, the most important thing is the clinical safety note. An energy device should never be applied after an application of exosomes on any area of the body, because exosomes are heat-sensitive molecules and they get damaged by heat. So avoid energy devices after application. You can go first, you have to maintain the cold chain, because cold chain again very important for exosomes. When thawed, it has to be used within 30 to 45 minutes. Avoid infections, use sterile techniques. Now, in the study done by Park et al., they showed that at a non-aesthetic or non-dermatology center, intradermal face injection of exosomes were given to a patient, and she developed redness, erythema, redness and nodules over whole of her face, and that did not go even on corticosteroid injections and lasers. This could be because of unauthorized lack of standardization in the administration of exosomes. So using intradermal injection should normally be avoided, because it could be causing severe inflammation in the patients. Now it's a $1 million question that which one to use, exosome versus PRP, GFC, PDRN. When cost is seen, the economic verdict says that PRP is much, much cheaper than a good exosome. Because when you're considering a good exosome, you're actually taking it from the human stem cell derived exosome, which are pretty expensive. And moreover, when you are going for the evidence verdict, PRP, GFC have more studies to validate them rather exosomes. Exosome is still in its infancy, and we need more and more clinical trials to validate the use of exosomes in humans. Exosome creams and facial, are they effective or just a trend? To be honest, they are just a trend, because exosomes, creams and facials, normally topical application without making any channels for without creating channels for it entry in the cell, it doesn't work much. These salon facials and exosome creams are not working, they are just marketing gimmicks. And what actually works is a medical grade exosome. What you can see in exosome facials, if milk colostrum derived exosome had been used, then some sort of hydration and lightening can be seen, but they are also very expensive. Now the limitation is that lack of standardization, lack of recommendation, any FDA recommendation makes exosome in its infancy, because we don't have any standardized recommendation regarding its production, its preparation, its delivery. There are multiple manufacturers in the market, there are multiple sources, and there is no medical guideline on use. Thank you.
Thank you, Dr. Upendra, for your elaborate discussion on exosomes in aesthetic practice. But can you tell that what type of exosome cream is available?
Sorry, sir?
Exosome creams are available in the market?
So they say, some Korean brands say, like a Korean skin cream. Those exosomes creams are there in the market. They are very expensive also, like 2K, 3K. But actually with the studies, when I went through the studies, they say that it doesn't work much.
Okay, thank you.
Thank you, sir.
Thank you, ma'am, for such an enlightening session. I would request our speakers and chairpersons to please collect their memento near the registration counter. For the next session, I would like to invite Dr. Shashank Shekhar sir and Dr. Shwetalina Pradhan ma'am to please come up on the stage and chair the session.
So it's my proud privilege to invite Dr. Samanta Barua sir, Professor and Head Department of Dermatology, Assam Medical College and Hospital, Dibrugarh. Sir has a lot of accolades. If I read, there are many. So he's a recipient of Dr. P.N. Behel Oration, his IM Excellence Award, and he's been awarded by Economic Times Inspiring Dermatologist in 2020. During our postgraduate days, sir was the Honorary General Secretary of IADBL National. So he's a very known face. Over to you, sir.
Thank you, Dr. Svetlana, for that very flattering introduction. And respected chairpersons and dear delegates, it's indeed a pleasure to be here at Puri for the CUTICON Bihar 2025. And after very lucid talks on clinical research and aesthetic dermatology, my brief is to take you back to clinical dermatology. And these are certain lessons that I have learned from the clinical cases that have sharpened my clinical insight. Of course, for the sake of time constraints, I had to pick and choose, and I have made an effort to only include a few of them for this presentation. So as clinicians, our early training is shaped by neatly structured chapters, clear algorithms, well-defined syndromes. But the travesty is that patients do not follow these textbooks. And over the years, certain encounters have challenged those textbook certainties, exposed those blind spots, and forced us to re-examine how we arrive at clinical decisions. This talk is basically going to touch those patients. And every patient was ordinary in appearance, but these became memorable because it changed in some way or the other how we arrive at clinical decisions. And the aim of sharing this with you is not only to revisit the diagnosis, but to actually reflect on how these cases can actually sharpen our clinical acumen and therefore reduce errors. When it's not just white spots. This was a 10-year-old girl who presented with asymptomatic, discrete to coalescing macules and few papules, which started appearing about 6 months back. First appeared over the back and then involved the lower abdomen and chest within about a month, and then a few were seen scattered over her cheeks as well as the limbs. The macules were hypopigmented to depigmented, most of which were tiny round to oval shape with a maximum size of 2 to 3 centimeter. And on closer examination, we could notice some atrophy, variable of course, and mild erythema at places. Now, she had already been consulted and treated by a dermatologist as a case of vitiligo and started on topical therapy. Now, during this period of 6 months, she started developing depigmented macules with areas of atrophy over the vulva with no vascular changes. Itching and burning was prominent and led to serious disturbance of daily activity, but thankfully there were no urinary symptoms and no history of any other autoimmune disorders. Differentials we kept were lichen sclerosis and vitiligo. Now these are again the clinical pictures in toto. So then comes dermoscopy. Now here you could see these white structureless areas that you could see denoted by the red stars, and the blue arrows where you see the comedo-like openings against a background of erythema. On histopathology, we could see thickened and sclerotic upper dermis with hyalinized collagen, with lymphocytic infiltrate that was scattered around the interstitium. The epidermis was flat with a small subepidermal cleft, and the features were suggestive of lichen sclerosis. So the definitive diagnosis was extragenital and vulval lichen sclerosis. She was started on potent topical steroids and tacrolimus, and then we initiated the oral mini pulse of corticosteroids. In 4 weeks, most of the lesions had shown improvement, and Most importantly, there was significant improvement in symptoms. So lichen sclerosis is a chronic inflammatory dermatosis of unknown etiology, which has a predilection for the genital area and is more often seen in females than males, with incidence in the pediatric population about 7 to 15%. Extragenital LS have, of course, been reported in about 15 to 20% of all cases, but it is not so common in children, where the incidence is much lower, of 6%. Children may not always report symptoms of the genital area, especially in that peripubertal area, age group, and therefore it becomes essential for us dermatologists to examine the genital area even when confronted with seemingly banal diagnosis of vitiligo. And vitiligo and gut atmorphia are the close differentiates to be considered, and we need to be aware that both these are among the autoimmune disorders that are or that can be associated with lichen sclerosis. And there is, of course, an entity called vitiligoid lichen sclerosis, almost similar to what we have encountered in the back, where there are less symptoms and less textural changes. Dermoscopy came to our aid in differentiating LS from the other conditions, and these are the patterns diagnostic of LS: white structureless areas, comedo-like openings, and the red-purple globules, blue-gray dots. Of course, some of these would be also seen in other conditions, but sufficiently diagnostic patterns are observed to confirm a dermoscopic diagnosis of LS. So lichen sclerosis, especially involving the genital area, should be diagnosed correctly early in the disease course and managed actively for two reasons. Number one, so that we can prevent the scarring and or loss of genital architecture, and number two, to mitigate the risk of progression to malignancy, however small that could be in a pediatric population. And active counseling and lifelong observation should be the cornerstone of management. That is the active takeaway. Then let's go to the next case, from scars to eyes, a charade of Mortimer's malady. This was a 28-year-old male who presented with an asymptomatic nodule over a 12-year-old tattooed area over the left forearm. The onset was around 6 months back. Within about a week or two, he also noticed mild erythematous plaque over an area of the scar in the same forearm. Then subsequently, in the following months, he developed new lesions. All were asymptomatic and were of two types mainly: papillonodular lesions over the chin, upper limbs, and the trunk, and there were plaques noted over the right preauricular area and the right knee. Now, 5 months after the onset of these cutaneous lesions, he developed redness, pain, watering of the eyes with photophobia, and diminished vision, which affected the right side more. There was no history of local trauma, and he was diagnosed as a case of acute anterior uveitis and treated with topical atropine and steroids. There was still no history of any systemic complaints except for an on and off backache. So provisional diagnosis of sarcoidosis was made. These are the clinical photographs. You could see the lesions over the tattooed forearm, and then lesions over his face. And you could also appreciate in the lower photograph the symptoms that he developed later on in his disease course. Skin biopsies were taken from both the scar as well as the face. Histopathology of the facial lesions, they revealed small and medium-sized rounded to oval sarcoidal granulomas, and the features were consistent with sarcoidosis. So these were the histological photographs that confirmed the sarcoidal granuloma. Subsequently, his serum AC levels were found to be high. However, chest X-ray findings were within normal limits, so were the hematological parameters, but the biochemical tests revealed a mildly deranged LFT. A definitive diagnosis of sarcoidosis was made. Patients started on oral steroids. So sarcoidosis, as we are aware, is an idiopathic multi-system granulomatous disease that can affect various organs, particularly the lungs, lymph nodes, eyes, and the skin. And this regulated type 1 helper T cell response following exposure to an extrinsic antigen is thought to result in the formation of the classical sarcoidal granuloma. Cutaneous involvement is only seen in about 2/4 of the cases, 2/4 to 20 to 40%, and only 1/3 of these cases can present at the disease onset, whereas it can, as was in our case, there was a gradual progression of involvement of not only the skin but also the eyes during the course of the disease. So our patient developed scarce sarcoidosis to begin with, and then developed papulonodular and plaque type of lesions, then developed symptoms in the eye, uveitis. Scar and plaque forms are associated with chronic forms of sarcoidosis and systemic involvement and carry great prognostic significance. Therefore, screening and long-term follow-up are quite imperative, and a procedure as simple as a biopsy can provide a definitive clue to the diagnosis. Next, of course, I'm sure we have seen a lot of these cases, especially in this part of the world, where leprosy unleashes its necrotic fury. This first patient, I'll just rush through the slides because I think I'm short of time. So this is a 44-year-old female who had erythematous plaques and then developed these ulcerative lesions on the fingers, toes, and chest. Another patient who was on his her sixth blister pack and then developed these painful nodules with ulcerations. Another case of diagnosed leprosy who developed suddenly crops of lesions on the limbs and forearms which ulcerated. Another young patient, a 16-year-old boy with similar infiltrative nodules, and then he had ulcerative lesions over his extremities. And this was a very recent case. In fact, she is presently still under management in the hospital. So she is a 21-year-old young woman who developed with these sort of crusted plaques and ulcerative lesions, not only on the extremities, but also over her face and her trunk. And she also turned out to be a necrotic ENL. We managed her, and this is how she looks now at this moment in time. These were taken today morning and sent by my resident. So erythema nodosum necroticans can mimic several conditions like pyoderma gangrenosum, vasculitis, deep fungal infections. And we need to have a high index of suspicion, and of course management leads to very gratifying and rewarding results. It is reported about 8% of ENL patients, and timely management can prevent further complications. I'll rush through so that we can complete this set. So this is the next set of infective deep fungal frontiers, the invisible invaders. So this young boy presented with fever, fatigue, expectoration, and umbilicated papules over the body for the past 4 months. His sputum had acid-fast bacilli, and he turned out to be seropositive. The biopsy of the lesions did not show much remarkable features. It was non-specific, sort of. But the fungal culture of the sputum, it had presence of Talaromyces. So these are the close-up lesions, molluscum-like lesions of Talaromycosis, formerly known as penicilliosis. The anti-tubercular and antiretroviral therapy was started, and injection liposomal amphotericin B was given for 2 weeks, and topical imiquimod was applied over the lesions. And then he was discharged following the definitive diagnosis of Talaromycosis on itraconazole 200 milligram, followed up at 8 weeks, and this is post-treatment at 8 weeks follow-up. Another patient who presented to the casualty, actually, to the medicine ward with fever, fatigue, and expectoration. He developed papulonodular lesions with central ulceration over the face with cervical lymphadenopathy, again seropositive. Skin biopsy here showed features consistent with histoplasma or histoplasmosis. Here you could see the histoplasma capsulatum sort of there in the tissue. Antitubercular and antiretroviral therapy was started, and again itraconazole 400 milligram followed up at 8 weeks, and this is his post-therapy photograph. So deep invasive fungal infections pose a diagnostic challenge, also difficult to treat, and the population at risk continues to expand with 97% mortality if you leave it untreated. Tularomycosis estimated to occur in about 1.4% of newly presenting advanced HIV disease in Northeast India. And histoplasmosis, of course, has regional variation, where Assam features prominently as a major contributor. So this patient stories, they remind us that clinical acumen emerges not from the protocols that we read in our textbooks or journals, but from the humility to question them when faced with the unpredictable, to go beyond the the box, and to sharpen our clinical acumen, our pattern recognition, and reinforce the irreplaceability of decision making. This was our last slide anyway. I'm happy that you were following this. I thought it's okay. So I won't take up time. That was the last slide. So I would just like to leave you with a photograph of the place I work in, the place where all these patients had been managed. And this is the postal stamp that was released by the India Post to celebrate the Platinum Jubilee of our institute. That's it. Fine. Thank you for your patient hearing. Yes, the last patient, right? Last patient, but yes, she had that astiariform pattern, but the lesions, she didn't have diffuse leprosy. She had the, she had the recurrent bouts of this kind of ulcerative lesions. So histopathology, of course, the Lucio would be slightly different than the vasculitis that you see in ENL. But we had also considered that. We will follow it up. Thank you.
Thank you so much, sir, for this very informative and wonderful session. For the next session, I would like to call upon the stage Dr. Ramavtar Singh, sir, and Dr. Mandeep Bhuker, sir, to kindly chair the next two sessions.
Good evening, everyone. It's my pleasure to welcome Dr. Professor Kaushal Verma, who's a professor, head of department, AIIMS, New Delhi. He's one of the most renowned dermatologists in not only in India, outside also. He's been international speaker in many conferences. Important achievement of his are the advisory Government of India to Nepal, Dean Research, and the Dean Examination of AIIMS. He has more than 180 research publication and 25 chapters, and more than 200 lectures at various meetings. These are the few of them. He is also as a FRCP Edinburgh 2017. He is also achiever of Professor L.K. Bhutani Award, past president of Contact and Occupational Dermatosis Forum of India, and many more. Let's hear from the sir. Thank you so much, sir, for coming.
Thank you, Mr. Chairman, distinguished delegates, ladies and gentlemen. It's truly an honor and pleasure to be part of this academic celebration of Bihar Dermatology Group. I thank the organizing committee and specifically Abhishek and Vikas for having invited me to this important event, but asking me to speak on something which is much less talked about in dermatology circle, which is the impact of skin diseases on the mind. And in my considered opinion, I think every disease, whether it is acute or chronic, say small or large, it has an impact on the mind. For example, if you get fever and if it doesn't go in the next 7 to 10 days, you get worried. You tell your partner, you tell your family, they are also worried. But if you get herpes, you're very worried. You don't tell this to your partner. And if you tell this to your partner, there is a potential risk of you being killed or maybe you burned alive. But if you have a supporting partner and you tell her, she will start thinking, how did you get this? Where did you get it from? You travel to conferences very often. Last time you went to Bangkok alone. So many questions will come into the minds. So let's see what impact the skin diseases can have on the mind. Obviously, I have no conflict of interest to declare. Now, it's happening that the mental issues are getting increasingly recognized as important concerns, even in the conservative, faith-driven societies like ours. Because there is a complex bi-directional relationship between the skin and mind. And it's because of the very obvious reason that skin and the brain, they are derived from the same ectodermal tissue. So the psychological stresses can cause the skin diseases, increase, or maybe sometime, in fact, perpetuate also. The global estimate says that as much as up to 70% people can have the mental health diseases, mental health issues associated with the skin diseases. And in Indian context also, these studies have shown that as much as 3/4 of the people who have skin diseases, they can have the mental health issues also. And the reason is that skin diseases show on the surface of the skin. So not only you can see, the other people around you can also see, but if you have it on the exposed sites, even the strangers, your relatives, and the other people get to know. So that's why now it is gaining importance, and people have started thinking that, yes, we should look at this aspect also. The spectrum of mental diseases affecting associated with the skin diseases, they're quite wide, but the common one which have been found to be associated are the depression and anxiety disorders. But you also know that the stigma is associated, like leprosy, HIV, which is also leading to discrimination. So the impact of skin diseases on the mental health is bigger than the internal diseases. Now, why does it happen? That there is a nice system which is operating, which is neuroimmunocutaneous system. And this system is complex in the sense that they share the common neurotransmitters, cytokines, hormones, and they share the common receptors. So what is working on the skin can work on the mind also. So the skin can act as a perceiver or a target of the stress response. And if you look at this, it looks rather complex, the stress and skin, and it adds nice to the psychological component also. On the top, you see the brain, which is, of course, the central control organ. And there you have the hypothalamus, you have pituitary, then you have the adrenal, which are secreting the different hormones, which when you start thinking, they get activated. And these hormones, they act on the skin. And every skin cell can have the impact of these hormones. So even in the normal situation also, if you start thinking, there can be the impact of the thought process on the skin. But if you have the skin disease, the manifestations can be even more severe. and the perceived symptoms can be bigger or maybe more significant than what they would be otherwise. These are certain examples of the diseases which get aggravated or significantly affected by the mental disorders, and also they can cause the impact on the mental health. For example, psoriasis. There is an increased nerve density, altered neuropeptides, and there is an amplified T cell response. So it is said that psoriasis gets aggravated when the person is in its distress. So the stress increases psoriasis. Same thing happens in the atopic dermatitis also because of the same reasons. Urticaria is a well-known example. The stress can induce urticaria. It can aggravate urticaria also. Even acne. The sebaceous gland can become overactive in response to stress. And so the people, if you ask closely somebody who has got acne and you tell them that, do you feel that the disease increases during the period of stress? They would say most likely yes. Now, this is the classification which is proposed by the Ku and Lee long time back, but this has been revised twice. But the crux or the central points in the classification, they still remain the same, like psychophysiological disorders which are exacerbated by the stress, and then the psychiatric disorders with dermatological symptoms. Then you can have the dermatological disorders with psychiatric symptoms. And then, of course, there is a miscellaneous group which clubs different disorders which have the medicational effect or the cultural factors. The psychophysiological disorders, these are the diseases which are increased or aggravated by the stress, are like hyperhidrosis. When the person is anxious, the sweating increases. Rosacea is increased. Psoriasis we have already talked about. Atopic dermatitis, there is a significant impact, and so is in the urticaria. Now, if we look at the psychiatric disorders with dermatological symptoms, and we are all aware of this, delusional parasitosis, body dysmorphic disorders, dermatitis artifacta, obsessive compulsive neurosis, which is leading to trichotillomania, excoriation disorders, somatic symptoms, substance-induced dermatosis, and there are many. These are some examples. Then the dermatological disorders with psychiatric symptoms. Again, the psychological distress can occur because of the vitiligo, alopecia, psoriasis, acne, chronic eczema. And one study showed that 8% get worsening of the psychiatric condition due to concomitant skin diseases. This is a study which is published by the British Association of Dermatologists, where about 20% of their dermatology patients needed psychiatric support. So it is estimated that at least 1/3 of the patients require psychological assistance. But in my considered opinion, I think every patient requires the psychological assistance. So the psychological interventions are emerging as important adjuvant to the therapeutic interventions for the better patient's outcome and better disease control. However, there is significant gap in the integrated care. We advise and prescribe medicine because we don't have that much of time. We don't even talk to the patient for sufficient length of time. So there is a need that we should have a joint collaboration or maybe a joint program with the psychologist or maybe the psychiatry team who can look after this aspect also because of the better therapeutic outcomes. Now, how do we do this? I mean, we are busy clinicians, so is there a way that we can use this also? So there are clinical interviews which are available. Mini is one of them. This is Mini International Neuropsychiatric Interview, which just takes about 10 to 15 minutes. And you can give this is available free of cost. So you can give it to the patient, they can fill it up, bring it back. Then the behavioral patterns are there, perceived stress scale is there to screen. And then there are other tests. And there are different kind of psychological interventions are also available. I think we might not be able to do all this, but if we have a team, if we have a psychologist on board, it may be easier, but there are few that we can advise ourselves to these patients. So how much is the impact of this psychological intervention? The impact on the disease is limited, but the impact on the psychological outcome is profound. It's significant. It has significant impact on the itching also. So these are the parameters which have been shown to improve. It might not improve the disease as such. For that, you're giving the treatment anyway. But if you can improve the other two components, I think it is of significant help. So we did this small study where we looked at the pattern of mental health disorders in patients with chronic skin diseases and the outcome of psychoeducation and relaxation therapy on the treatment outcomes. And we took two sets of patients. One, patients who already had the psychiatric disorders and skin disease, and the other ones who did not have the psychiatric disorders and had the skin disease, because we wanted to compare these two groups. And we found that the patients with connective tissue disease, immunobullous disorders, and eczematous disorders, they more often had the mental health disorders compared to the other group. And this is showing almost the same data. You see more immunobullous diseases are associated with mental health disorders, connective tissue diseases, eczematous diseases, because they are more bothering, they are more troublesome to the patients. We looked at also as to which diseases are associated, and we found that the depression was the most common one. Now, this is the scale which is also easily available, and this can be easily administered to assess the stress in the patients. So we use this scale which has a maximum score of 40. And this is what we found. The maximum stress again was in patients who had immunobullous disorders, connective tissue diseases, and the eczematous disorders. But the other group of disorders also had this. And why did we take this? Because these were the patients who were easily available in our clinic. Psychointervention was planned, and this is a very simple technique. Relaxation exercises were taught to the patients, the deep and shallow diaphragmatic breathing, 2 sessions, each lasting for 20 minutes, 4 days a week, and for 3 months. Initially, we taught them 2 sessions, and then we were evaluating them every month just to see that, yes, yeah, they're doing exactly or maybe more or less similar to the one that they have been taught. And this is what we found. There is significant decrease in the stress score, so it did help in these patients. And there was, when we looked at the change in the severity of the disease, there is not a very significant difference between the control group and the people who were given this relaxation therapy. But what changed was the improvement in the stress level. So when the stress level goes down, the disease also tends to improve. So what we concluded that psychiatric comorbidities are high in the patients with chronic skin diseases that we have shown in our study, and I think otherwise also. They can be easily screened by using a simple screening questionnaire, which is mini. It's available on net. It's free of cost. The psychological intervention can be easily done, which are simple, effective, and can be taught by the dermatologist also. They are helpful in reducing stress and leading to better therapeutic outcomes. Stress reduction, even if there is no improvement in the skin disease, it does help. So what we recommend that psycho-intervention should be the part of therapeutic intervention package. And if we can't do this, there are many techniques, are the many ways that we can incorporate in our day-to-day practice in our clinic also. But if you can't do it, maybe you can collaborate with your psychiatric friends. You can collaborate with the psychologists who may be there in your town for the better patients management. Yoga helps. This is also one of them. And it doesn't help only human, it can help the animals also. Before I conclude, I'd like to thank the institution where I am working. This is All Indian Institute of Medical Sciences. I think you might have already seen. And the team which was working on the project, Aisha, Prashad, Nand Kumar, we have taken some inputs from the Hanish Babu from Dubai also, because he is one of the experts in the psycho-intervention area, and then one of our faculty, Rajat. And before I close, I like to thank you all once again for having stayed for the last session of the day. I think after this we probably have we have a presentation. I think it's a free paper presentation. Thank you very much.
Thank you, sir, for excellent talk. Sir, I want to ask few questions regarding the talk. Sir, how often do you give a psychological counseling or a psychiatric consultation on first visit of the patient if we suspect a psychological involvement in a chronic skin disorders?
If we suspect, we send them in the first visit itself to our psychiatry team. We have a psychologist team also who are collaborating with us, and we have identified the people that yes, they are the person, because AIMS is a huge hospital. It's a township. They will get lost. If we just tell them that go there, they probably will never reach. And if they can reach also, they might not be able to come back. So we send them specifically with the name.
Sir, most of the time, like in Indian society, they consider as a mental taboo if we send someone to a psychiatrist. How do you counsel the patient so that they can go for the follow-up? Because personally, from my perspective, I always feel take the patient in confidence. Maybe during the second visit, we can talk and we can tell him ki, haan, this is the fact, and you need to see other doctor to involve over the treatment part.
You're right. It is a challenge. Sometimes people don't even accept. They say कि मैं वहाँ psychiatry department में क्यों जाऊँगा? मेरे कोई दिमाग में कोई परेशानी थोड़ी है. मैं कोई पागल थोड़ी हूँ या मुझे मेरा कोई दिमाग खराब नहीं है. So, but if you tell them that it is going to be helpful because it is associated with your disease and probably it will help improving your disease also better.
Sir, and how to handle this in private practice? Because you are in institute, so you have a option of sending or having a psychology in your department.
I am sure you have the psychiatrist also practicing in your town. So you can, in fact, you can collaborate with them. But there are many things which you can do even without them also. If you just go on the net and look at the stress scales, or maybe just look at as to how to assess the the psychological, the mental health issues, it's possible.
Thank you, sir.
Thank you.
Any other questions? Thank you, sir.
Thank you.
Now I invite to Dr. Raghunath Reddy. His talk is on the role of nifedipine in the management of dermatophytosis. Sir, please.
Yeah, good evening. Sir was saying that was the last talk. I think there are some more talks. Now, this is a sponsored session by Zydus. So that is what is the conflict of interest. Initially, they had asked me to speak about scar revision, but then for some reasons, I have given this topic. But anyway, everything is important. You know that great Indian epidemic of superficial dermatophytosis, and according to data, it depicts that it is very high in north and is very less. I don't agree with this. There is no such difference, maybe slightly higher. It's a pan-India phenomenon. Now it is also becoming pan-Asia, and now we heard that it is catching up. What they call it is Indotinia. Is seen in Europe, seen in US, everywhere. So slowly, as like how Indians are all over the world, our organisms also will be there all over the world, and then only we will get some importance. Now, this dermatophytosis, you know that its prevalence is rising. Most important is chronic dermatophytosis is increasing. It's because of injudicious use of corticosteroids. Now we see entire family getting affected. We know that there is resistance, so many studies say that it is not resistance, it is only increase in the MIC, but definitely I can see that there is resistance, and there is a rising burden of relapse cases. What is the need of the hour is some new molecules and some new technologies, drug delivery systems, because we don't have too many medicines in pipeline systemically. So whatever is there, we should be able to utilize the best. So this nifedipine is a primary topical allylamine. It's the first topical antifungal agent in its class that has helped promise for treatment of superficial fungal infections. It is topically, allylamine may be preferred to topical azoles because they short duration of therapy, suitable fungicidal activity. I will not go into too much of theoretical things because finally the message will be same. If you look at an overview, naftifin, it has a best reservoir in stratum corneum, and you need to apply only once daily. It also has antimicrobial activity, and it has fungicidal, and it has anti-inflammatory effect, and it can be pregnancy category B, wherein you can use it with caution, and it is an allylamine. These are the advantages. And an ideal antifungal, topical antifungal, if you call any of these molecule, it should have all these things, at least reservoir effect, once daily application, anti-inflammatory effect, fungicidal. So looks like we have an ideal anti-fungal topical application. How does it work? It inhibits squalene to become squalene epoxidase and cell wall, and that is the strongest effect it can have. Various topical antifungals have different mode of action. Now, and as I said, we will not go into the various studies they have done, because a lot of studies, again, it will all say. So multiple anti-inflammatory actions noted with naftifin include targeting of formation, release or effect of prostaglandins and 5-lipoxygenase synthesis pathway, and the action of polymorphonuclear leukocytes. It has both antihistamine and corticosteroid effect. So this is why there will be anti-inflammatory effect. So the findings from the tape strip analysis, more specifically, drug level detected in stratum corneum up to 4 weeks post-treatment. That is what is called reservoir effect. And this is very, very important because you know that, just clinical cure is not the cure in mycosis, it is the microbial cure. So the presence of drug for longer duration post-cessation of treatment is also important. There are plenty of studies related to naftifin, including both in India and phase 3 randomized clinical trials and comparative studies, retrospective studies are there. A phase 3 randomized clinical trial evaluating the efficacy safety of naftifin 2% cream versus terbinafine is being studied, and patients of either gender of 18 to 65 years of age, both patients with acute symptomatic tinea corporis, tinea cruris limited to single body region with limited involvement have been included in this study, and mycological diagnosis with KOH was established. Patients with total clinical score of at least 5 were selected. Patients willing to provide written informed consent like any other test. Though clinical improve-wise almost scores the same, even the side effect profile is not much different between these two. But no patient experienced clinical or mycological relapse, while one patient in the reference group, that is terbinafine group, experienced a clinical relapse. Tolerability was slightly better with naftifin compared to terbinafine, whereas if you compare the study of naftifin to luliconazole, the findings are slightly different. Definitely naftifin scores better with efficacy, therapeutic point, and most importantly the side effects. This personally I can tell you that several times my practice is I use 2 different class of topical antifungals with the fear of developing resistance or already having developed resistance. But when I see commonly these allergic contact dermatitis, irritant contact dermatitis is not very uncommon. But when I have given 2 antifungals, I doubt which one is causing. So I stop both of them. I'll ask them to use one by one later, and I feel definitely the luliconazole is more often causing these topical side effects like burning sensation, vesiculation, oozing, suggestive of allergic contact dermatitis and irritant contact dermatitis compared to naftifin. Even the clinical results, you can see pre and post treatment clinical photographs of patient with dermatophytosis in naftifin, 2% cream in the left side, and that of liliconazole. It takes longer duration and it heals with pigmentation. So this comparative study concludes that naftifin 2% cream offers rapid resolution of clinical severity from week 1 of treatment onwards, with a significant improvement in quality of life without an increase in adverse effects, unlike liliconazole, which tends to cause burning, itching, and irritation. Although it cannot be stated that naftifin is significantly superior to liliconazole, it can be considered as an alternative in patients who have already received multiple topical drugs and those who have applied topical steroids also. As liliconazole may cause cutaneous irritation, naftifin can be safely used in the treatment of steroid-modified dermatophytosis, because there you can expect the thinning out of stratum corneum, and also the skin is unhealthy, the possibility of irritation is more, so that can be preferred. Real-world data of naftifin in Indian patients is a real-world observation study to evaluate the safety and effectiveness of naftifin 2% cream in patients with superficial fungal infection. Says it's once daily application and twice daily and thrice daily application, mean duration, all this. So it has efficacy of 82.07% in patients achieve the clinical cure at visit 3 compared to the baseline, and 94.6% of mycological cure. So the tolerability study recorded a lower incidence of adverse effects. Again, almost the same thing what we are repeating. So topical naftifin 2% cream was safe and effective in Indian patients with tinea cruris and tinea corporis as well. This is the patient demographic and comparison of mean clinical scores at different follow-ups. So this retrospective study suggests that naftifin 2% cream is safe, effective in patients with superficial fungal infection. Same. Now, the number of patients studied in various studies, which involves study of naftifin in all types of RTCs, real-world evidence, prospective control studies. So prospective real-world evidence, the number of patients studied were 463. A phase 3 RTC number of patients 268. Naftifin versus liliconazole comparative study in 96. Retrospective real-world 1,258. Totally 2,000 plus patients have been studied, which is a good number to assess its safety, efficacy, and compare it to other topical antifungals. A systematic meta-analysis review showed there are 3 RTCs in this study, including 2,400 patients, and 4 RTCs including 276 patients of tinea corporis and tinea cruris. Primary outcome was complete cure rate, clinical cure rate, and mycological cure rate. Secondary outcomes were any adverse events, clinical improvement or clinical success, and treatment effectiveness. So in tinea PDs, so this is the result. Drug regimens and efficacy measured, mycological cure, global improvement, effective treatment with KOH marked good relief, treatment success. Outcomes were this. Compared. Now, to summarize, I think whatever we say, the data, the tables, everything finally speaks about what we are going to speak in this slide. First, it's a first topical allylamine class which is being used. It's highly lipophilic, keratinophilic, efficient penetration and high concentration in stratum corneum and hair. This is very, very important. Now, it is fungicidal and fungistatic. Again, this is important. Even if when I said I will be using 2 different class of topical antifungals, one will be fungicidal, one will be fungistatic at least. So additional anti-inflammatory property is a boon because it reduces itching and thus complications related to scratching. It has antihistamine and corticosteroid-like activity. It has additional antibiotic bacterial property. Suppose if you have tinea with eczematization and some amount of secondary bacterial colonization, again naftifin will be the drug of choice compared to other antifungals. And it works synergistically with oral azole antifungals. It is proven safety, low adverse effects, and pregnancy category B. and once daily application and short duration of treatment. Even at 3 weeks, it has shown both clinical and mycological cure. So, with this, I conclude the talk well in advance in the evening with a message being given. Thank you.
Thank you, sir, for your nice talk. Is there any question? Yes.
Any practical question? See, as I said, to be frankly, I always give 2 classes of antifungals. I usually don't use. I'm little scared of treating tinea. I'm little skeptical. I overtreat tinea. I don't undertreat tinea. Even if it is systemic antifungal, even if it is duration, even if it's topical applications, I use. See, if I have to use, those studies says that once daily application, I don't trust. I always use 2 daily applications. So once daily application of fungicidal and all. But definitely one thing I have seen, efficacy is good and side effect profile topical application compared to luliconazole is less. Thank you.
Thank you, sir. Thank you.
Thank you, sir, for such a wonderful session. I would request our speakers and chairpersons to please collect their memento near the registration counter outside. I'm sorry, there is a 2-minute delay. We are waiting for our next chairpersons. So proceeding with the next session, we are commencing our hair session. For the next session, I would like to invite Dr. Anupam Sinha sir and Dr. Vikas Shankar sir to please chair the session.
I would like. I would like to call Dr. Shubhanshu Shekhar Patnaik, CMD Skin and BD, is a Chief Consultant Dermatologist, Arogyam Clinic, Cuttack, Odisha. On his name there are 4 publications, 51 presentation, authorizations 2 chapters. He has an award in his name. Review of articles in dermatological therapy, organizing sessions, one IDVL CUTICON 2018. He was a joint organizing secretary.
In one sentence, Shubhanshu Patnaik is heart of Odisha dermatology. So I think he no need any introduction. He himself is an institute. Welcome, Dr. Shubhanshu Patnaik.
Thank you very much, Vikas Bhai, for the nice introduction, and I welcome all of you to our divine soil of Puri, Odisha, and thank you for giving me an opportunity to be here. And the topic of today's presentation, procedural management in male and female androgenetic alopecia, a very common and burning topic of recent times. So hair loss is a global problem, no doubt about it. Around 63% of Indian men aged 21 to 61 suffer from hair loss. As we can see, like this part of the country, we have around 60%. So this is the basic pattern. We know it from the PG days that basically the 2 scales, as the Norwood scale and the Ludwig scale for the male and female alopecia, we keep on classifying our patients on based on this. So targets and action plan, basically there are 2 arms. Like we have one is abnormal androgenic milieu, hyperactive receptors in the frontovertical area of the scalp, and also the anagen is relatively low. So basically the modalities are various, like topicals, orals, intrascalp, like intralegional therapies in both of the things. Now we have multiple modalities coming up in different work that has been done. So basically if we put it simplified, it looks something like this. If we took it into an analogy, like we think that the scalp is a tree. So how kind of thing that we are going to think about it? So raising hairs is similar to raising a harvest. So how does it look? If we put an analogy, it looks exactly like this. Like the parts of the hair and scalp, you can just put on. Like in the blue, we can see hairs resembles leaves, hair follicles resembles the roots, scalp skin resembles the soil. Hormones are like soil toxins, that aberrant hormones. And low proteins minerals are poor soil quality. Minoxidil serums can be compared to water. And the different interventions that we do, like roller microneedling, can be compared to a sewing tool that we do for the soil. Scalp vasculature is the nutritional channels, and threads now coming up, like polydioxanone threads that are absorbable threads, can be compared to setting up new water pipelines into the tree and soil, like we do. Low-level laser therapy is again gaining traction, so that it can be compared to sunlight. Regenerative therapies act as a fertilizer kind of thing. And finally, patient is like the gardener, and we doctors are like the gardener maker. So this analogy fits in to when we manage the androgenetic alopecia. So now we have multiple of us in the hall. We might be having excellent results with only minoxidil and only oral finasteride, because we are already addressing the 2 arms. So we are extending the anagen by giving minoxidil, and we are decreasing the androgen by giving the finasteride. So many of us here may be getting good results. Like this was a case when we got in September 2020. This was a case during COVID, and this patient was an online consultation from New Delhi. And patient was, of course, having grade 6 of AGA, history of 3 years of progressive hair loss, and had been utilizing OTC minoxidil. And no other therapies was taken by the patient. Patient was losing hope and was planning a hair transplant, of course, because it's a high-grade alopecia. And we got the hair loss improved within 3 to 4 months. Now, what was the treatment given here? We gave home microneedling. I asked the patient to microneedle the scalp with 1.5 of the derma roller, and we give topical minoxidil with finasteride combination and give dutasteride 0.5 daily. Now, some of the members over here might have given patients and got excellent results with this. Can I have a hand raise that we can get results by doing this? Anyone in the hall have got such results with this? Some of us have got. So why we do procedures? If we are doing only this and getting results, so why procedures required at the first place? Are they? Are topicals and orals not enough? They are doing enough? So the answers to this is like limitations to topicals. Now topicals when we give, they are patient dependent. Their application and consistency also is important. Now patient may not be applying properly despite we tell them to. Variability, now penetration and bioavailability into scalp skin will be different for different patients. And formulation issues, like there may be non-compliance to application because the minoxidil will be causing dryness, alcoholic preparations will be irritating to the patient, so they may not be applying it properly. Now also there will be limitations to orals because they're again patient dependent. Patient may not be taking it daily or skipping up the doses. Also local bioavailability of the drugs in site of action will be different. Everyone have a different guts. So the absorption and relative availability to the site of action will be completely different for different patients. And chances of adverse effects and phobias. Now patient may be an idiot syndrome or reading a lot of internet. So might be avoiding any finasteride or dutasteride that we have prescribed them. So there are variability, there are side effects, and there are variations in results. So advantages of procedures, what we have is, it is dermatologist controlled. Now when we do a procedure, then we are controlling it by our hand. So the chances of results are much better, not patient dependent. Also we can optimize our therapy and direct therapeutic access to the site of pathology. So we have direct access to that. Results are boosted, results are hastened and also sustained. And inter-patient variability of results is minimal because we are directly accessing the site. So the logic and science behind the different trichological procedures that we do is basically this basic diagram that we see. This is a hair follicle. As we can see, that the hair bulge section, that is where the stimulus is given, where there lies the stem cells, are in the depth of around 1.5 to 2 mm. This is the basis behind why we are using the penetration enhancer tool like a derma roller, because we are using that 1.5, and this is the concept. So we are encouraging the use of derma rolling like at home. So the stem cell bulge stimulation happens at this place. And we also do like derma pen, we are using it monthly while we are giving the PRP or GFC to the patient. So regenerative injectable therapies like we give PRP, GFC, now the next generation IPRF or TET, that is thread embedding therapies, or also exosomes. Now this is basically the dermal area where we are doing this intervention. Also antifibrotic intervention like we do a thread therapy or dutasteride mesotherapy. Now it is important to note that dutasteride acts at the dermal papillae. Now that is very deep down, that is around 3 to 4 mm. So when we are injecting, we have to inject around 4 mm needle. Now needle should be in the direction of the hair and should be penetrating around 4 mm deep. So that is the anti-androgenic therapy that we have to take care, because the dermal papilla here are the receptors. The androgen receptors lie there. So there lies the dutasteride mesotherapy. Now when we are writing a prescriptions, so this should be having a logic. Now this is the logic, the different 3 levels of therapy with 3 different color codes that we can see here. The blue one resembles the above the skin. In the level of the dermis, we have the green codes, and in the bottom, we have the red codes. So oral, intralesional, and topical. So these are the 3 different levels of actions for a holistic way of how we manage the hair loss. Now coming to another case scenario, this was a case just came to me around 4-5 months back. Grade 6 AGA, no hope, planning for hair transplant. So this was a very challenging case for us, and the patient told us that I am not quite affordable for hair transplant, so do me anything, whatever you do, but give me some hair back. So this was quite a challenging case, and we prescribed a plan. Now, this was the plan that we did. We maximized the topical, like we gave 10% minoxidil. We did clobendazole and salicylic acid lotion combination, considering there is a micro-inflammation that is going up because endogenetic alopecia is a micro-inflammation. Also, ketoconazole salicylic acid shampoo, considering the pityriaspidum oval population needs to be also controlled. That might be leading to also the inflammation. Orally, we also escalated the oral minoxidil gradually from 2.5 to 5 milligram daily. Now, oral and topical, we combine minoxidil so that the optimized minoxidil might be given to the patient. Also, protein diet, because as we know, the hair is made up of keratin, which is 95% keratin. So, patient needs a good protein supplements as well. And finally, we gave also dutasteride orally. Now, what we did procedurally is, we inserted threads, that is the absorbable thread, which is polydioxanone lactic acid caprolactone threads with GFC infiltration in the same session. And also the next session, we give the anti-androgenic dutasteride mesotherapy in the patient. And there are some reports which are now coming up, like cetirizine is also, will act on the androgenetic alopecia. Now, this was the results after 3 months. Just 3 months. Can you imagine? Like every month we monitored the patient. After 3 months, patient got quite a substantial growth in the frontovertical zone. Now this is the back of the patient. Like you can see, the back is getting around 30-40% coverage, and still we are not done. And patient is continuing the treatment till now also. So these are the 3-month results of the patient. You can see just comparison. And a similar case which also got the results in 6 months. And these are the sequential pictures of the patient. Is another patient. So threads therapy, if we can see, like there has been coming many recent studies which say that if we combine polydioxanone, which are absorbable threads, with platelet-rich fibrin in the same session, we can stimulate the anagen phase of the hair. So this is a video of pedio thread. Now, initially what we do, we give a cryo cap. Now, this is a cryoanalgesia. This is a very cold, chilled cap that is given, and this act in the theory of gate theory of pain. So, when we mechanically or thermo regulatory wise, we give a topical cryo cap. You wearing a cap for around 20 to 30 minutes, it decreases the pain threshold. It increases the pain threshold and also leads to less painful sensation. Now, this is how the cryo cap is. You are just asking the patient to use it for around 20 to 30 minutes before the procedure. Now, how we insert the threads? Now, you can see here, the one of the hand is just inserting the thread just in the direction of the hair. So, as acute as possible to the scalp. Now, the contralateral thumb is trying to stretch the skin so that it's stabilized and it is inserted at an acute angle in the direction of the hair. Now, this is how we do, very simple, and anyone can do it very easily with a little bit of practice. Now, how we do it? Like initially the scalp, the front line is given a lot of threads because that area is more visible to the patient. So GFC infiltration, now in the same session what we do, through the hub, we are trying to give the GFC, that is growth factor infiltrate, and here it goes little bit deeper. So the results are quite good because the nourishment is optimal. Now when we are injecting and giving a little bit through every end, taking it out. So the threads as well as the GFC stay inside. So this is one by one, we did that. And threads, about the thread, it is bioabsorbable, it is well proven in phase, done for around quarter of a decade till now, and the safety profile is quite good. And we use PLACL. Now we can see in the right corner is the PCL. Now that lies for around 24 months and keep on stimulating the scalp. Now the absorption takes a lot of time. So the blood flow continuously goes to the scalp for this much time to dissolve the thread. Now in the process of dissolving, what happens? More and more neovascularization, collagenization happens, and the scalp is nourished with oxygen and all the nutrients that we are providing to the patient. So this is what, and this advantage is it only requires one session every 8 to 12 months. So around for 1 year, the patient is safe and does not require any more regenerative procedures in the meanwhile. Now, this is the recent evidence, what we are having, recent literature, what says that it leads to improvement and regeneration of the connective tissue. It improves the energen by inducing the growth factor like fibroblast growth factor 7, and also leads to cell proliferation, improved blood circulation, and also collagen stimulation. So these are some of the postulates that hypothesized, and yet larger studies are of course required. We are in the process, but we should do it more and more to get real results of this. Now, growth factor concentrate, it is the preparation protocol that we see around 20 ml blood is taken. It has to be activated by rotation, by upside down movement, allowed to stand vertically for around 30 minutes, centrifuged at 3500 RPM for 10 minutes, the supernatant taken, and around 8 ml yield we get from 4 tubes. Again, platelet-rich plasma, now our IADVL PRP task force and the Journal of Drugs in Dermatology have came up with their respective protocols, and we are now following the recent recommendations, which say that manual double spin method of PRP is quite better than what the kits that we are having. And the preferred anticoagulant is ACDA, acid cytrodextrose A, and we get around 3 to 5 PRP monthly sessions are usually recommended, and per session we should have a yield of around 5 to 7 ml. Concentration around 10 to 15 lakhs per microliter should be there, and this we have to standardize the machine. If you are not standardizing your machine of centrifuge, because we all have different machines, and we should always check our baseline blood level and the PRP concentrate in the PRP that we are getting. So the platelet concentration has to be compared, and when we are getting around 10 times, so that means we are having the correct standardized protocol of the centrifuge rotations. So this is what we need to do. Pre-activation was earlier recommended, but now our IADVL task force says that pre-activation with any chloride is not required. So PRP protocol is manual double spin, first soft spin and then the second hard spin. So this is the spin that for my machine, but not yours. It might be different, so you should always standardize. So this is the standardization that is required, and the spin is required. So PRP and GFC, there are many different ways of thoughts and different school of thoughts which say that GFC is better and PRP is better. But in my opinion, I have found GFC doing very well in comparison to PRP. It is all patient feedback. GFC has got some very important advantages, like it is prepared in a closed system of tubes, no contamination, and also purification is ensured, better concentration of growth factors, pain during injection of GFC is very, very low, and satisfaction score is of course higher. Now this is what, like every 1.5 months we have to do it, 6 sessions, not mandatory, don't tell the patient that you have to do it, but keep it optional, give it, let the patient decide it, but again, it will boost results. You have to tell the patient that if you are really keen to get results, you should add it to get around 30% boost to your results. Along with microneedling and LLLT, now low-level light therapy we do along with this, and along with doing the microneedling, we do a spray of minoxidil and also serum. Now many studies are coming that also we have injectable minoxidil now coming up. So that is a matter of time that we are evolving to inject also minoxidil. Now IPRF is the next generation of PRP. Now it is more concentrated, and it uses a very simple technique. You have to take the blood in a conical bottom tube, which does not require any anticoagulant. You have to do it in a very low RPM, like around 800 RPM for around 3 to 4 minutes. And then the upper supernatant is the IPRF. And it becomes gel-like in around 15 minutes, so you have to inject very early. As soon as you take out from the centrifuge, you have to inject it. It ensures a very good scaffold and a very good concentration of sustained growth factor release happens over time. So the results are quite good with IPRF. So injecting IPRF, how we do it, like this is a small video, like we use a major needle that is around 32 gauge and 4 mm, and we do it with a vibratory device, that is a VAD, and this is one important one, and you can do it from the fronto vertical, because we are using it from the proximal to distal. You can see how we hold the VAD. It is hold in the front, and we are injecting in the behind. So that leads to a little bit less pain to the patient. Now the three-way approach, now coming to discussion, now I have already mentioned it. Now the 3 questions that we should ask when we are writing the prescription is, am I treating the 3 levels? Am I combining the different levels of treatment? Am I addressing the key aspects of the pathology? Am I trying to optimize the drug delivery to the target? areas. Now, these are some of the important things. Medical therapy optimization, of course, we can escalate our concentration of minoxidil sometimes when we are getting a refractory case of managing androgenetic alopecia. Also, sometimes we also add RCP-based regimen, that is Redensil, Capicil, and Procapil. Sometimes that may be added in the morning, and at night you can give the minoxidil. We encourage the use of home use of derma roller and dutasteride scores over the finasteride. Always encourage high protein and low carb based diet, because androgenetic milieu can be restored if we decrease the body weight, also work on the metabolic aspects. So procedural therapy, now these are like microneedling, autologous therapies, dutasteride mesotherapy. Exosomes I'm a bit skeptical about. There's a lot of hype surrounding exosomes these days, but in my personal practice, I usually don't prefer injecting a lot of exosomes. And thread embedding therapy, of course, it's very prospective. Now, dutasteride mesotherapy for AGA, it is the standardized protocol we don't have yet, and no head-to-head comparison with oral dutasteride for efficacy has been done. However, mesotherapy is gaining grounds. And this is how we inject a dutasteride mesotherapy. It is available in 2.5 strength. We dilute it with GFC. What we do, we combine with GFC like 1:2 ratio to make it around 0.8%. Inject with the same 32 gauge 4 mm needle, because as we have already discussed, around 4 mm depth is required. And we inject it 1 ml max per session. And this is how we inject. We initially give a ring block in the frontal aspect, and then we inject. This is a Lenny-Wand vibrator that we are using. It is a chilled tip along with a vibration tip. So chilled along with the vibration give a combined effect of gate theory of pain. So this is what, when the patient is not preferring any oral dutasteride or finasteride, you can easily give an intralesional one, so that can be given. And one more thing is that dutasteride has got a longer half-life. So you can space the sessions around 2 to 3 months in between. And also sometimes we give weekends of dutasteride and we give it along with that. And this is how we are doing the microneedling. You can see some micro bleeds on the scalp that is very easily that is coming. You have to be very vertical, precise, so that the microneedling gives a very good pinpoint bleed. This is the low-level laser therapy that we usually give to the patient. This is US FDA recommended, and the red light or the near infrared light gives a stimulation to the hair follicle. This mitochondrial stimulation, more ATP generated, and also lead to more of cell proliferation, and can also, this is a combined therapy that we give to the patient in the single session. We give PRP, we may give a combination of GFC and dutasteride. Along with that, we can do a microneedling and combine that with LLLT. So in a single session, patient is getting all the combinations. Now, exosomes, though I do not prefer, sometimes I did some experiments with exosomes, but it is, remember, we cannot inject it. Till now, there are legal implications, not yet approved, so we can only just microneedle if required. But I'm not convinced yet. We can just spread it over the scalp and just do some microneedling. The nanopore needle tool that I'm using here is very precise, very less pain, and they ensure the precise microbleeds. This is how you can just rub it up and just, you can microneedle. Just you can see how precisely the needling is happening and the bleeds are coming very easily with a very less pain to the patient. So we are using at a depth of around 1 to 1.5 mm here. So derma rollers, we advocate home use to the patient. We ask the patient not to buy from internet because there is a lot of variability. So quality variability is also affecting, because sometimes the needle breaks also. So you have to have a very good quality roller in your clinic. You can dispose it, you can dispense it to the patient, and we use it 1 mm for females and 1.5 for male. And males are asked to use it in plus and cross directions, where females are asked to use it in the stamp mode from front to back. Now, alternative days, some patients are sensitive, so we can initially do it weekends or do it alternative days and make it daily. And cleaning instructions has to be also properly explained, and needles to be checked regularly. Microbleed can happen, and that has to be counseled to the patient and encouraged that microbleeds are not bad, rather they are good for the therapy. Now, very, very important, this is a very small thing, but I've learned it from Chandrasekhar sir, B.S. Chandrasekhar sir of CUTIS Bangalore, and this was a very key and very small game changer, I can say very important game changer, that we have to keep the scalp of males trimmed to around 1 FTU, 1 fingertip unit, to get very good results. Now, how does it help? There are many small things happen, but these are very, very important. You can easily assess the degree of alopecia. Now what happens if, when you are camouflaging the hair with some, you may not have hair here, you can camouflage it on the other side. Now when you cut the hair short, you can actually know what is the grade of alopecia. Now this is what better assessment of the degree of alopecia happens. It also decreases the chances of hair fall due to the traction. Now what happens when you are pulling it off with a comb or pulling it like a lot of scratching? Then there is a chance that you are losing it by traction in addition to the androgenetic alopecia. Also easy massaging of topicals, because when you have short hair, you can easily massage it on the scalp. And the decreases the wastage of topicals also. Now most of the patient we tell 1 ml you apply, but half ml is already applied on the hairs strand and less is going to the scalp. Now when you are having a small trimmed scalp, small short hairs, you are applying everything on the scalp. So that is what enables easy rolling of the derma roller also. Also accurate monitoring of the improvement happens. Now this is what we do in our clinic, just trim it and just we can take the photograph in different angles, like bitemporal angles and the frontal angle. Now the comparison is so good. Now we can see just the comparison, just the same angles with trimmed hair. You can easily tell the patient that yes, you are getting a real improvement, not a pseudo improvement. So this is what, like, you can just compare another case, like you can see a trimmed hair ensure that a patient is losing hair, and over 5 months he has gained the hairs over that area. Now this is a frank case of loss in this area, and you can see some baby hairs coming up in the front and the coverage of the central area. Same case, different angles are addressed, and these are some before after. So and along with that, it is very, very important to counsel the patient on what to expect and when to expect. Now this is the timeline, this is the road, you can say, the roadmap to improvement. Now initially the first 2 months, we have to counsel about transient shedding, how the dandruff is improved. Then at 4 months, the hair loss is stabilized. At 6 months, the baby hair sprouts. At 8 months, it would turn thicker. And gradually for every indefinite time period, till the patient wants hair, you can continue the therapy. Now you have to tell the patient on day 1 that this is going to be your timeline and you have to stick to the plan, as we say. So FPHL, now coming to ladies, now usually androgenetic milieu may be affected in PCOS cases that we often see these days because of the Western style of living. So scalp visibility is very common. We can see a Ludwig stage 2 turning to 3 in this case. And she was a known case of PCO for 5 years. Body weight is around 90 kgs, BMI is more. And aberrant sleep and dietary patterns, which is very common post-COVID because of the web series watches and everything, unresponsive to only topical minoxidil. So we gave a prescription plan in such cases, grossly this one. We gave an androgenetic-based OC pill, cyprotenol acetate, cyclical one. We added metformin along with the MIDCI, myoinositol and dechiroinositol, which is in the physiological ratio of 40:1. Now most of the combinations are now coming. We are having metformin along with MI and DCI. Resveratrol is a very growing supplement which also ensure a proper androgenetic milieu in the patient. Vitamin D3 is very, very important for hair follicle growth. Protein and iron supplements, of course, is required for a lady. Now minoxidil can be escalated very gradual. It has to be like very low, like we can start with 0.6 and also can give to 1.5 to around 2.5 max. Now topically we give max of minoxidil 5% and along with that the regular treatments. Procedural plan, what we did is this one, like IPRF along with the Dutamezo. Dutastride meso, along with this we combined, and like you can see in a matter of around 4 to 5 months, they say around 3 sessions, 4 sessions, the coverage of the frontovertical area, the Ludwig 3 has been constricted. Now very, very important, the central part, you can see it is constricted. So that shows an improvement. The quality of hair is more thicker and the hair mass index is more. So another case here, you can see how the density of the hairs are gradually decreasing in this lady, and this over time has improved a similar kind of plant structure. So this also very, very important that the female also should be asked that as short as hairs as possible is very, very important. Now this also helps in properly managing, easy managing of the scalp, and when they apply, they have to part the hairs and then apply, not on the top of just the hairs. Now managing the FPHL also incurs like topical, oral and procedural way of management. Now these are different options. We can just make permutations and combinations and we can work on it. Biglutamide meso is little bit less work I have done, but it's still progressive. Like we have seen some reports where biglutamide meso is giving result. So this is a very key diagram. Remember, when we are working on FPHL cases, we need to remember that hyperinsulinemia and hyperandrogenemia are co-interlinked and are a feedback kind of a loop option. So when we are giving a hyperinsulinemia and hyperandrogenemia, we have to have a proper control of diet, exercise, lifestyle, along with metformin is a very key molecule because that takes care of the hyperinsulinemia part. Also hyperandrogenemia by giving the androgenic-based OC pills. Now, these are the different sites of action of metformin, inositols, combined OC pills, and spironolactone. Now, spironolactone from day one is a strict no-no. Now, this leads to the breakthrough bleeding in between. So, when we are adding spironolactone, ensure you give a OC pill along with that, or spironolactone may be added after 3 to 4 months when OC pill is not doing the job. These are from the gynecological recommendations. Now, this is a very, very important table that will guide you what to give when. So when different age groups are there, you can see below 20, 20 to 40, more than 40, and post-menopausal. Now these are different ages and to choose the OC pills, because we know we cannot give estrogenic-based OC pill above 40 years, because that can lead to hypercoagulability and deep vein thrombosis. So there you have to choose fourth generation, the progesterone, like drospirenone-based OC pill, like Yasmin Ellis, and post-menopausal we can give dutasteride. Now the below 20, we should not give any hormonal-based OC pills because that may lead to bone changes. Now they may pre-epiphyseal closures and also the pubertal changes which are on the way of developing at that time. We can only give metabolic therapies like metformin, minoxidil. Now it is very, very important to point out that metformin is now recommended above 10 years. So just in pediatric age group also, you can give metformin with due consultation with the pediatrician. Now prescription of AG and FPHL, the mechanisms, the modalities, and the management can be logically planned as you can see here. So to conclude, we have to know about the big 8 strikes here, like the imbalance of androgens, imbalance of prostaglandins, sebum, bacterial and fungal overgrowth, microinflammation, microscarring, and collagen that we are addressing with the thread therapy, inefficient circulation metabolism, and nutrient deficiency, of course. So key take-homes are procedural therapy is a key management, 3-way therapy should always be emphasized, optimization is of course required, we have to target various pathology genetic mechanisms, and regenerative therapies among all threads and GFC are scoring high over IPRF and PRP in my personal experiences. Dutasteride mesotherapy is a promising tool to handle the phobia of patients and deliver results. So keeping the patient in loop is very, very important for maintenance of results, and counseling always remains the key. Thank you very much.
Thank you, Dr. Shubham. So wonderful session. We had almost touched all the things. Only one thing, this LLLT, you have shown the cap, this helmet thing. So how do you use this? Just for a general thing.
Yeah, actually cryo cap that was shown here is a form of contact, kind of cryo contact. So basically what we keep it in deep freezer. So that here's a gel inside. Like we see there a gel of phase that is given by many phase gel. So a gel, contact gel cryocoolant is given. So you can keep it in the deep freezer, and when the patient session is there, you can just apply it. It is very snugly fit, that can be easily fitted to the scalp. So the contact time is around 30 to 40 minutes. So what we do, we first apply the EMLA. First we apply the topical EMLA, we occlude it with the paper that is given, sheet along with that, and on top of that, we give the cryo cap. So there is a 3-way of giving the anesthesia. We are also applying the EMLA along with the cryoanesthesia. So this is actually given for chemotherapy-induced hair loss. Now what happens is cryo induces vasoconstriction. So what does the vasoconstriction? Does not allow the chemotherapy to reach the hair follicle. So because of that, most of the Western countries, people use this cryo cap. This is actually imported from US actually.
Second thing, you have shown this mesotherapy of this dutasteride. So it's off level, I think, so it's not approved in India. But what is your say in this mesotherapy dutasteride?
Yes, so this has to be kept reserved. Now, not like rampantly we can start with all the patients. Now we have to keep it reserved for those refractory cases and the phobic cases. Now we can give an option to the patient that if you are not feeling like taking dutasteride because of sexual adverse effect that is mentioned in the internet. So we have an option of every 2 months of taking an mesotherapy. Now this is very safe, except for one thing I want to mention here, that dutasteride mesotherapy sometimes lead to a frontal swelling. After around 2 to 3 days, patient may complain and get back to you with a swelling in the forehead on the frontal aspect. So that happens because of the dutasteride as well as the lignocaine that is used as diluent. So in that case, just massaging, asking the patient to massage it properly from the center of the scalp to the above, that avoids this complication. This is a very minor complication. Other than that, it is very safe. I have been giving to around 100 to 200 patients around. So I don't think that has got any complications whatsoever.
Thank you so much. I think I must congratulate over a wonderful session. Thank you so much, Dr. Small.
Thank you very much.
Now our next session, our next speaker, Dr. Mona Sharma, I would like to invite on stage. He has done MBBS MD from PGI MS Rohtak. He's a director, Dermawave chain of skin, laser and hair transplant clinic. He's a consultant dermatologist at Dermawave Panipat. She was a past secretary IDVL Haryana State Branch 2022 and 23. Key interests are hair transplant and laser. Please conclude.
Thank you, esteemed chairpersons. A very good evening to one and all present here. I'll be discussing the clinical approach to the female pattern hair loss, which is a very common yet highly under-recognized condition with a great burden of psychosocial impact. So let me begin with the simple clinical example. A woman in her 30s presents in her clinic with widening of the midline parting for the last 1 year, and there is no itching or no scarring of the scalp, and her parameters are normal. So this is a typical case of female pattern hair loss. It is a non-scarring progressive miniaturization of hair follicles in the genetically predisposed women, and it has associated with significant morbidity leading to anxiety, low self-esteem, and reduced quality of life. So there is central thinning over the mid-scalp and the crown. The frontal hairline is preserved, which is a characteristic feature in this. There is Christmas tree-like widening of the midline part with the widened base at the front and tapering towards the vertex. The thick hairs, they become fine short hairs. The shedding phase may precede the initial visible thinning. Complete baldness is rare. There are different scales to grade this female pattern hair loss, like the Ludwig classification and the Sinclair grades, depending on the mild, moderate, or severe thinning. So understanding the pathophysiology of this disease helps us to tailor the therapy. There is androgen sensitivity. The follicular DHT binding initiates the miniaturization cascade. The terminal hairs progressively become thin, becoming vellus. There is polygenic inheritance, and the hair cycle is disrupted. The anagen is shortened, and there is premature catagen. The normal hair follicles are terminal and have larger diameter, extended anagen phase, active beta-catenin signaling, and balanced DHT metabolism. Whereas in affected follicles, the size is miniaturized with reduced diameter, the anagen is shortened, the beta-catenin signaling is inhibited, and there is increased DHT and 5-alpha reductase activity. So coming on to the diagnostic approach to the female pattern hair loss. So comprehensive history taking and physical examination are very important in this. We should ask for the onset and progression of the disease, look for the pattern, there is central thinning, frontal recession, ask for the family history, detailed reproductive history, look for the medical history, any thyroid disorders or PCOS, iron deficiency or any metabolic syndrome. Ask if the patient is on any medications like anticoagulants or hormonal therapies, beta blockers or retinoids. On physical examination, do the hair assessment, grade on Ludwig or Sinclair scale. More than 20% diversity in the hair shaft thickness is characteristic of this condition. Hair pull test is usually negative. On scalp assessment, there is no scarring, erythema, or scaling, and the frontal hairline is preserved. Look for the signs of hyperandrogenism like acne, hirsutism, androgenic alopecia, and acanthosis nigricans. On trichoscopy, there is anisotrichosis, that is more than 20% variation in hair shaft thickness in a unit area. Yellow dots, which are dilated follicular openings with the sebum, they can be seen. Brown peripilar halo can be seen. The number of villous hairs is increased, and there is reduction in hair per follicular unit. Trichoscopy has advantages like it is non-invasive and painless and gives immediate results. It helps to differentiate with other alopecias and helps in monitoring the treatment response also. It can detect the changes early before disease is clinically apparent. So on trichoscopy, in FPHL, I have already told the findings. In alopecia areata, we can see the yellow dots, black dots, or the exclamation mark hairs. In telogen effluvium, the follicles are empty and the hair diameter is normal. In scarring alopecia, we can see follicular dropout and the loss of follicular openings. Laboratory evaluation can be done and should be done if indicated. Do the complete blood counts, thyroid tests, ferritin levels, fasting glucose to rule out any metabolic syndrome. If hyperandrogenism is suspected, go for total and free testosterone, DHEAs, and sex hormone binding globulin. Certain conditions may require additional testing like androstenedione, prolactin, FSH-LH ratio, 17-hydroxyprogesterone, vitamin D status, and lipid profile. Scalp biopsy is indicated in certain conditions. There are indications like clinically atypical presentations, or when scarring alopecia is suspected, or to differentiate between the chronic telogen effluvium and the early FPHL, or treatment-resistant cases. On histopathology, we can see the decreased terminal to vellus ratio, increased telogen anagen ratio, miniaturized follicles. The follicle count is, however, preserved. There's perifollicular fibrosis and mild perivascular inflammation. A 4 mm punch biopsy is taken from the mid-scalp or frontal area, and horizontal sectioning is preferred over vertical for the follicular quantification. Multiple levels like infundibulum, isthmus, and suprabulbar regions are seen. So the differential diagnosis of female pattern loss are chronic telogen effluvium, in which there is diffuse thinning without any pattern loss. The hair shaft diameter is uniform, pull test is positive, and this has acute onset, often with a trigger. Diffuse alopecia areata is also sudden in onset, showing numerous yellow dots, black dots, broken hairs. There's more diffuse shedding rather than the pattern loss. In central centrifugal cicatricial alopecia, it's a scarring type of alopecia with peripilar white halo, loss of follicular openings, and usually affects the central scalp. In frontal fibrosing alopecia, it's a type of scarring alopecia. There is frontal hairline recession, perifollicular erythema, and loss of eyebrows is common in this. So trichoscopy is invaluable for differentiation among these conditions. Biopsy can be considered if scarring is suspected. So coming on to just the overview of the therapy, many new treatments and the ongoing procedures have already been discussed in the masterclass. So topical minoxidil is the gold standard and is the only FDA-approved indication for the female pattern hair loss. 2% solution and 5% foam have been approved by FDA in female pattern hair loss. 2% solution is to be applied twice daily and 5% foam once daily. 5% solution is used once daily as an off-label indication. So the mechanism of topical minoxidil is, it acts as a potassium channel opener, causing hyperpolarization of the vascular smooth muscle cells, promoting the vasodilation. So this prolongs the anagen phase and converts a miniaturized follicle to the terminal hairs. It also has antifibrotic effects via the vascular endothelial growth factor pathways. Various studies have shown good results, increased efficacy with the minoxidil as compared to placebo. With minoxidil, first results are seen at 3 to 4 months, and optimal results are seen at 6 to 12 months. Then is the low-dose oral minoxidil. A trial was conducted in 30 women, which were randomized to 0.25 mg versus 1 mg minoxidil. So 1 mg group showed significant increase in hair density, increase of 27 hair per centimeter square as compared to the 0.25 mg group. But both the groups showed reduced hair shedding, improved quality of life scores, though there was no statistically significant difference between the groups in global photography assessment. Both the doses were well tolerated, with mild facial hypertrichosis in 2 patients in 1 mg group, and transient increased hair loss in 1 patient in 1 mg group at 8 weeks, that resolved by 24 weeks. There were no withdrawals. 1 mg provides superior efficacy as compared to 0.25 mg of oral minoxidil. So this is a patient showing results after 6 months of monotherapy with the low-dose oral minoxidil 1 milligram. These are the trichoscan images showing the hair density before and after 3 months of oral minoxidil. Before it was 98 per centimeter square, and after 3 months it was 140 per centimeter square. There are certain considerations which should be taken into account while using minoxidil, like initial shedding, contact dermatitis that is caused by propylene glycol, facial hypertrichosis. Proper application technique should be explained to the patient. The less common side effects are headache, dizziness, fluid retention. With oral minoxidil, there is dose-dependent hypertrichosis, lower limb edema, palpitations, headache, dizziness. So BP monitoring should be done at baseline, at 1 week, at 1 month, and then quarterly. Also do the ECG if there is any cardiac history. Baseline CBC, LFTs, electrolytes should be done. Then is the finasteride. It inhibits the conversion of testosterone to DHT, as it is a type 2 5-alpha reductase blocker. So the dosage is in post-menopausal women, we can give 2.5 to 5 mg daily, and in pre-menopausal or in reproductive age group, we can give 1 to 2.5 mg with the reliable contraception, as finasteride is teratogenic and causes male genital abnormalities. So pregnancy test should be done before the initiation of the therapy. Usually well tolerated, rare side effects are breast tenderness and mood changes. Liver function should be monitored periodically. This is showing the results after 7 months of 1.25 mg finasteride. Dutasteride is a more complete blocker of DHT, as it blocks both type 1 and type 2. And studies have shown higher efficacy than finasteride. The dosage is 0.5 mg daily, and the warnings are same like finasteride, as it is also teratogenic. Then is the spironolactone. It is a potent androgen receptor antagonist, blocks the DHT binding at follicular level, and the starting dose is 50 to 100 mg daily, and we can go up to 100 to 200 milligram daily, and response should be assessed after 6 months of therapy. It can cause menstrual irregularities, breast tenderness, hyperkalemia, hypotension, dizziness, fatigue. So baseline potassium, creatinine, and blood pressure should be monitored, which should be rechecked at 4 weeks and then every 6 months. Contraception is required, as it can cause feminization of the male fetus. There are other anti-androgen therapies. I won't go into the details, like cyproterone acetate, bicalutamide. Flutamide is not preferred, as it is hepatotoxic. OC pills can be considered with anti-androgenic progestins like drospirenone, cyproterone, or chlormedinon in premenopausal women. Then there are adjunct therapies like PRP or platelet-rich plasma therapy. It has already been discussed. I won't go into this the procedure. There are various growth factors released in PRP, like platelet-derived growth factor, transforming growth factor beta, vascular endothelial growth factor, epithelial growth factor, and insulin-like growth factor, which activate the beta-catenin and the AKT signaling, leading to energen prolongation, DPC proliferation, angiogenesis, and reduced apoptosis. So this has already been discussed, the single spin and double spin method. Then is the low-level laser therapy. It has also been approved by FDA. Various instruments like helmet, cap, and comb are improved by FDA for use in female pattern hair loss. The optimal parameters are 630 to 660 nanometer wavelength. 5 to 20 minute session are given at 3 to 4 times weekly, and optimal results are seen at 12 to 16 weeks. Higher compliance is seen with home-use devices rather than the office-based treatment. Then there are microneedling and microinfusion. These are can be combined with topical minoxidil or PRP. Microneedling induces controlled microtrauma, stimulating the growth factor release and enhances the drug penetration. Microinfusion we can give improves the bioavailability of the drugs as compared to topical application like of minoxidil, dutasteride. Pain management should be done, asepsis should be maintained, and caution should be taken with anticoagulants. Nutritional support lacks strong evidence, but we should combine if deficiency is there, like of iron, vitamin D, zinc, or biotin. Emerging therapies are exosomes, JAK inhibitors. They have no role in female pattern loss. They have shown results in the alopecia areata. Topical cetirizine and botulinum toxin. So in mild FPHL, after initial assessment, we can start with either topical minoxidil or oral minoxidil. Adjunct therapies like PRP therapy or LLLT or nutritional support can be combined, and follow-up done at 3 or 6 months. Stabilization and prevention of the progression should be the treatment goal, and the patient should be counseled properly for the initial temporary shedding in the first 2 to 8 weeks. For moderate to severe FPHL, we should go with the combination therapy with minoxidil and combined with some anti-androgen. Adjunct therapies can be considered later on, and monitoring should be done at 6 and 12 months. If the patient responds, continue the therapy indefinitely. Otherwise, intensify the therapy. And in elderly, we should monitor for the orthostatic hypotension with the LDOM. So minoxidil is basically the first line of therapy, oral or topical, and combination therapy is usually superior to the monotherapy. Correct the nutritional deficiencies, if any, and continuous therapy is required to avoid the relapse. Thank you.
Thank you so much, ma'am. You have covered almost every point for female pattern hair loss. But one question is how you select this dutasteride and finasteride, and which you consider better?
Frankly speaking, I haven't used finasteride or dutasteride in female patients. I am using a topical minoxidil along with the oral minoxidil, along with some nutritional supplements or PRP, lower level laser light therapy. Haven't used oral finasteride in the females.
Thank you so much, ma'am.
Thank you.
That was a wonderful start to our hair session. Thanks to sir and ma'am. I would like to request our chairpersons and our speakers to kindly collect their memento near the registration counter outside. Moving forward, for the next session of hair, I would like to invite Dr. Ajay Kumar Jaina sir and Dr. R.P. Singh sir to please chair the session.
Good evening. So, coming to the next session, I would like to invite Dr. Sumit Sama, who is presently working as Director, Denmark Wave Clinics. Brief capacity is Consultant Dermatologist and Hair Transplant Surgeon. Project Director, IDWL Flagship Programs. Observation Lasers and Hair Restoration. Fellowship in Hair Restoration. Past President, IDWL HSB 2022. Organizing Chairperson, CUTICON Haryana 22 and 23. Key interest area, hair transplant, lasers and aesthetics. Dr. Sharma, please start.
Thank you, esteemed chairpersons, and very good evening to all of you. Today I will be presenting a comprehensive overview of regenerative therapies, its scientific understanding and clinical practical outcomes. So, as we know, regenerative therapy is an evolving field in trichology, and that aim to restore the hair growth by activating or replenishing the body's own system, regenerative mechanism, rather than relying merely on the conventional pharmacological or surgical approaches. It leverages stem cells, growth factors, and tissue repair to rejuvenate hair and improve scalp microenvironment. So this is the outline. This is the roadmap for today's session. And understanding the fundamental of hair biology is essential before applying hair restoration solutions. So, fundamental principle of regenerative therapy in hair restoration, it focuses on repairing and replacing damaged tissue or organ, that is by decreasing inflammation. It upregulates natural regenerative process by cellular regeneration or by activating the dormant follicle to enter hair regrowth. It also aims to restore function rather than merely treating the symptoms. So, alopecia is just not a cosmetic concern. It deeply affects the psychological, social confidence as well as overall quality of life. So, why there is a critical need for regenerative therapy? Because conventional therapy, only symptoms are managed. They do not address the underlying pathology of the hair loss, and there is an absence of regenerative benefit for follicular biology. They do not restore or revive the follicular biology, and there is a necessity for treatment which address molecular pathway for follicular health and long-term restoration. So this is the structure of hair follicle. Upper part remains constant and lower part undergoes a repeated cycles of hair growth and regression. And hair cycle is governed by complex cellular mechanism and microvascular influences. So this is the hair follicle budget stem cells. It houses multipotent stem cells, and proliferation and degeneration of these stem cells is closely linked with the hair growth. Also here reside the neural crest cells, which help in follicular repair as well as pigmentation. There are multiple stem cells present in the interfollicular epidermis as well as in skin mesenchymal cells. So, epithelial and mesenchymal interaction, this is a dynamic and reciprocal communication that orchestrate hair follicle formation, cycling, and regeneration. It involves a multiple signaling pathways and cellular responses, making it a key focus in understanding of hair biology as well as pathologies like alopecia, and disruption in this EMI is linked to the follicular miniaturization in AGA. So pathophysiology of androgenetic alopecia, key molecular changes is decreased Wnt and beta-catenin signaling, increased DHT binding to androgen receptor, and there is the upregulation of TGF, beta, and DKK. Key techniques which are involved in regenerative trichology, they are stem cell therapy, growth factor application, platelet-derived growth factor, and exosome-based treatment. So now coming on to the core regenerative modalities, their mechanism of action and clinical evidence, adipose-derived therapies and cell-free approaches. Adipose-derived therapy is an advanced hair restoration option, and as we know, adipose tissue is a rich source of regenerative cells and biofactors required for hair restoration. Key therapeutic modality include adipose-derived stem cells. These are the homogeneous multipotent mesenchymal cell isolated from adipose tissue, which have regenerative potential. And stromal vascular fraction is a heterogeneous cell population obtained via enzymatic digestion of lipoaspirate. Nanofat is is obtained by mechanical emulsification of fat aspirate without enzymatic processing. Mechanism of action is primarily by paracrine signaling through growth factors, cytokines, and extracellular vesicles that stimulate dermal papilla cell proliferation, hair follicle cells, stem cell activation, angiogenesis around follicular structure, as well as extracellular matrix modulation. So these processes are accessible and clinically practical as abundant adipose tissue is available and it's easily harvested. And there is a minimum processing requirement as compared to other cellular therapies. So now this slide is demonstrating how to prepare SVF and culture media. So first we collect the fat, then purification. After purification, enzyme is added, and we incubate it at 37 degree for 30 minutes, and then centrifuge it. SVF is collected at the bottom of the tube. On the top is the oil and the mature adipocytes. SVF contain a progenitor cells like endothelial cells, ADSC cells, pericytes, and immune cells. Later on, this SVF is placed in the culture media, where the mesenchymal stem cells adhere to the bottom of this plate. They proliferate and form undifferentiated ADSCs. Under the specific condition, these can be transformed to more specialized states depending on our goals. So this is the nanofat. First there is a collection of fat, and then it is purification and washing is done. This is the second step. Third is the mechanical shearing of the fat. Fat being pushed back and forth in the syringes, and then ultrafiltration done to obtain a cell-potent rich biological active agent. Nanofat contain SVF, ADSCs, growth factors. And now this slide is demonstrating the mechanism of action of adipocyte-derived therapies. So adipocytes, ADSC support hair follicular regeneration primarily through primary paracrine mechanism rather than the differentiation. By activating key signaling pathways, they secrete paracrine factor, which enhance angiogenesis, causes proliferation of dermal papilla cells, and through beta-catenin activation, it helps in hair follicle regeneration. So comparing these three therapies and its clinical application in trichology, ADSC is optimized for research and for specific signaling pathway in which stem cells are required. SVF is directly injected in scalp for hair loss, and nanofat by microneedling therapy or in combination with PRP. So many studies have been conducted using these adipose-derived therapy, and they have found safe and effective. So this is the cellular therapy in which Regeneractiva is a micrograph technology in which we process the micrograft to yield high concentration suspension of progenitor cells, growth factors, and cytokines, which it means that we utilize our own body tissue mechanism to stimulate the growth of the follicle and strengthen miniaturized hair. This is a study showing human adipose tissue-derived follicular stem cell. It's injected in 43-year-old male, and it has showed marked increase in density at 44 weeks. So cell-free therapy is the new frontier for hair restorations, and first we have MSC controlled condition media. Here we collect the secretome released by the mesenchymal stem cell. Its key benefit is we capture the regenerative potential without requiring live cell transplantation. And next are exosomes. These are the small membrane-bound vesicles released by these cells. They contain biological active cargo such as protein, lipids, mRNA, and microRNA. ADSC-derived and DPC-derived exosome have shown promising results. And these are the advantage of cell-free therapy over the cellular therapies. They have reduced risk of immunogenicity and tumorigenicity. There is no risk of graft versus host disease, improved stability and storage capability, easier production, standardization, and ensuring consistent quality control. So this slide is showing the mechanism of action of exosomes by paracrine signaling and molecular communication. mesenchymal cell release exosome containing microRNA and growth factors. These exosomes interact with the dermal papilla cell, activating the beta-catenin signaling, thereby increasing the key growth factor like KGF, VEGF, promoting hair follicular regeneration. This is a slide showing when the exosome is given in the hair loss. This exosome activates the DP cell through beta-catenin pathway, resulting in cell proliferation, tissue regeneration, and by growing hair in anagen phase. So clinical application of these exosomes they are used in various hair loss conditions like AGAs, chronic telogen, cicatricial alopecia, and administration method is microneedling and topical application. We can give it by direct intradermal injection, but it's yet not approved by any FDA, and we can give it with in combination with PRP as a dual treatment. Optimal treatment protocol is 3 to 4 sessions at 3 to 4 intervals, and we can see the first visible result at 6 to 8 weeks, peak improvement at 12 to 16 weeks. So this is the randomized double-blind study using adipose-derived stem cell in androgenetic alopecia. We can see the marked increase in hair diameter, density, as well as more coverage of the scalp over the period of 16 weeks. So another study using ADSC, CM, and minoxidil at baseline and after 6 weeks, we can see the increase in the hair density as well as hair growth. So now coming on to the advanced regenerative strategies. These are the cutting edge approaches, and they are trending the future trends in regenerative therapies. And these strategies is driven by molecular and cellular signaling. We are targeting the molecular pathways like IGF-1 and Wnt. These are the two pathways which results in hair follicle formation, cycling, survival, growth, and restoration. So modulation strategies, either we need their pathway activators like Wnt agonist, tocotrienol, valproic acid, IGF-1 enhancer, and recombinant protein, and GSK3 beta inhibitor to prevent beta-catenin degradation. Or we need pathway inhibitor blocker, that is DKK antagonist, SP RPI neutralizers. So nanotechnologies and optimized delivery. These are the advanced system for targeted follicular drug delivery. So for the controlled, these are the system for the targeted follicular drug delivery. Its advantages are they allow easy penetration of growth factors, drugs, and cytokines into the scalp. It reduces the systemic side effect and improve the patient compliance, as well as increase the potency. So there are different kind of the nanoparticle delivery system available, that is lipid-based nanocarrier, polymeric nanoparticles, exosomic, mimetic nanoparticle. All these improve solubility, some controlled release of drug, as well as enhanced targeting of the dermal papilla. So this is the example of nanotechnology VDPHL01. This is the novel formulation being developed by Veradermics. Veradermics is a dermatological founded biotech focused on innovative dermatology and aesthetic therapy. So what is VDPHL01? It's an extended release formulation of minoxidil. It releases the minoxidil in a slow and steady way that maintains therapeutic level around the hair follicle, reduces the systemic peaks and side effects, stimulate hair follicle for thicker and denser growth. Clinical data highlights suggested 47.3% hair per centimeter after 4 months in phase 2 trial. 90% of the participants reported visible improvement, no cardiac or systemic adverse effect observed. This drug is currently in phase 3. So key takeaway, regenerative therapy show promising clinical potential, multimodal therapeutic approaches, ADSCs SVF nanofat stimulate growth via paracrine. Cell-free approaches often advantages in safety and logistics. Safety profile is favorable with low immunogenicity and reduced risk of complication, particularly with cell-free therapy. Standardization remains a challenge for isolation protocol, characterization method, optimal dosing and delivery system. Future direction require large-scale control trial and personalized treatment algorithm based on patient-specific factor and disease stage. Thank you.
Any questions from the audience? Okay. Thank you, Dr. Sumit, for a nice presentation.
Now, we invite Dr. Devraj as the next speaker. You can see his achievements and very difficult to read out as such, and everybody knows him very well. So welcome and
thank you, sir.
Initiate.
We will start the talk. I'll start my talk. Thank you very much, respected chairpersons, and a very good evening to all. It's wonderful to be a part of Team Bihar and CUTICON Bihar. So I'll be talking about androgenetic alopecia in children and adults. Now, androgenetic alopecia before the age of 18 is known as pediatric androgenetic alopecia. So, as we know, AGA is nothing but replacement of the terminal hair by vellus hair. So, why does this matter? This matters mainly because this is a very, very under-recognized condition, swept under the carpet or not given much importance. There is a lot of prevalence of this, and there's a lot of psychosocial impact on this, on the kids especially. We talk about people not being able to get married or find jobs because of androgenetic alopecia, but the important growing years in the teenage years, this is when the maximum psychological impact happens. So that is when the kids get affected. So there is a loss of self-esteem, and this can lead to depression also. So hence we need to know about this condition and know how to tackle this condition. Nearly 13% of the pediatric cases can present as pediatric androgenetic alopecia, and of this which it can be 42% of adolescent cases. And in this study, almost 14.1% of the males in the age group of 15 to 17 showed very early signs of androgenetic alopecia. So the youngest reported case is around 5 years in literature. As early as 7 years also people are noticing it, but most of them they present around 14 to 16 years of age. In my practice, I've seen kids as early as 8-9 years, both boys and girls presenting with typical features of androgenetic alopecia. As usual, the boys dominate than the girls in this pediatric androgenetic alopecia. 83% have a positive family history, and 75% have one parent affected, and 25% have both parents affected. It's a double whammy. People with both parents affected do generally show more aggressive forms and much earlier onset. So we all know that testosterone gets converted into dihydrotestosterone by 5-alpha reductase, and there is shortening of the follicular hair cycle and also miniaturization of follicles due to this effect of the dihydrotestosterone on the receptors. Now, genetic factors play an important role, but this is more of a polygenic inheritance. If you look at the key loci, it is on the X chromosomes. So there is a good thing I always tell my parents, it's like if your maternal grandfather was bald, there's a very high chances that you also could probably end up being bald. So this is something we need to identify and probably take a good history, which side of the family is affected, so that you can initiate treatment much earlier on. So there can be variation in the androgen receptors also. One of the important points again which is not really talked about or recognized is the metabolic syndrome factor. The effect of the environment and also the lifestyle changes in the current generation, where people are having much earlier onset of puberty. So you find girls and boys hitting puberty much earlier, and the signs of puberty also. This is to be blamed by the lifestyle, people having more processed food, late night sleep, lack of physical activity. So this also is one of the major contributory factors for pediatric androgenetic alopecia. Just a brief anagen growth phase to 5 years generally. People with knee length hair generally have 7 to 8 years. Catagen is the transition phase, and then you have the telogen, the resting phase, or the phase the hair is the hairy shade of. So in androgenic alopecia, just a brief again run through, we have shortened anagen and increased telogen and miniaturization of the hair follicles. In females in pediatric androgenic alopecia, we find more of the Christmas tree pattern and also the diffuse frontal thinning. And in males, we see both the male and the female pattern. One of the increasing occurrences is the occurrence of female pattern in males, and generally if you see this is more of a, related to the lifestyle, and that is triggered on by the lifestyle or the metabolic syndrome and other things. So it is no wonder that the kids also have more of a female pattern hair loss in boys who are suffering from this. So vitamin D deficiency is the most commonly seen association in pediatric androgenic alopecia, along with obesity, which again leads to insulin resistance and high fasting glucose levels. They also could have other dermatological conditions which can be indicative of the metabolic syndrome or underlying insulin resistance, like acne, seborrheic dermatitis, and also atopic dermatitis was seen in a few percentage of the kids. So how do we approach? First is recognize, identify the hair loss pattern, and most important is identify there is a good family history. This family history taking is very, very important. Most of the time we talk about the fathers and the maternal grandfathers, but please ask about the paternal. We ask, please ask about the maternal grandparents also. They also play a very big role. Additional tests like hair pull test is needed, and also trichoscopy. Scalp biopsy only in certain doubtful cases, not a regular thing. Hormonal testing is important here, unlike in adults, because basically we are looking at precocious puberty, or sometimes we are also looking at a hormonal imbalance. So for boys with early onset of androgenic alopecia, precocious puberty is to be ruled out. As I said, precocious puberty of late is because more of lifestyle and food related changes and lack of physical activity, but sometimes there could be some underlying major causes in the endocrine system itself. So trichoscopy is the gold standard. It's a non-invasive tool for hair analysis, and you can identify certain specific patterns which are unique to androgenic alopecia. These helps us to kind of rule out other hair loss conditions, because they can be other hair loss conditions in kids also, like hypotrichosis and other things, loose anagen syndrome, etc., which can mimic androgenic alopecia. So trichoscopy is a important tool here. So hair shaft variability, which is seen in almost all cases of pediatric androgenic alopecia, is the important one. Anisotrichosis, that's more than 20% variation in thickness. Then presence of vellus hair, single hair units, that is instead of seeing 2-3 follicular units from hair from a single follicle, you end up seeing just single hair, and wavy hair. These are the key trichoscopic findings. The additional trichoscopic findings is you can find perifollicular pigmentation, that is discoloration around the hair follicles, yellow dots, and also vascular changes. Some of the kids also show perifollicular dilatation also. This could be one of the early signs for the pediatric androgenic alopecia. So based on trichoscopy, based on the stage of pediatric androgenic alopecia, the trichoscopic changes also changes. In early stages, we can just notice the hair shaft thickness variation and also perifollicular pigmentation. In the intermediate stages, where you lose the hair, you start seeing the single hair units and also the wavy hair appearance. And in the late advanced stage, which is very clear, yellow dots and focal atrachia can be seen. Hair pull test, important tool, underestimated. Always do it, because before you're initiating therapy, the hair pull test is always positive, and then once you initiate therapy, it becomes negative. So slowly the patient also becomes confident in the treatment, helps in aligning the patient and getting more compliance from the patient. So most of the time it is negative in the active phase, and only in the affected areas, that is in the frontal area and the vertex in androgenic alopecia, whereas if you're looking at diffuse positive hair pull test, it can happen in telogen effluent. Scalp biopsy, unless there is few doubts, there is no need to really go for a scalp biopsy, but nevertheless it's important to know that less than 3:1 ratio of the anagen to the telogen hair can be a key diagnostic marker, and also perifollicular inflammation. Androgenetic alopecia is a micro-inflammatory disorder, so there is a definite role of inflammation. So again, when you're treating, this has to be kept in mind. The differentials are diffuse alopecia areata, telogen effluvium, and also we need to consider hypertrichosis simplex, monolithics, and also rare conditions like loose anagen syndrome and short anagen syndrome. So how does it differ from androgenetic alopecia? It is less, it's under-recognized, it's less discussed in literature, not much of literature, and also there's lack of awareness both among the patients and also the dermatologists themselves. It's of milder presentation generally, and in males you see the female patterns more often. Hormones cannot always, is not really associated, and there is a very strong link to metabolic syndrome and also PCOS in girls. Now, treatment is a big challenge because none of the treatment therapies are FDA approved for the pediatric population specifically, and also there is a concern of the safety in a growing child, and research is very much limited in the pediatric age group population. Topical minoxidil remains the first line of therapy. There have been case reports that topical minoxidil has been used as early as 5-6 years also, and it is proven to be safe in these case reports, but there is no large studies which prove the safety of the topical minoxidil. But considering the clinical practice, it is the safest of all the options, and 94% of the children show improved coverage and slowed thinning. 1 ml as usual, like what you do in for adults, that is the thing to be applied, and you can use the foam form because there is decreased systemic absorption compared to a solution. The only drawback is foam is less efficacious compared to a solution.
Hypotrichosis and itching are the common side effects which we see. The local side effects. Systemic, kids can have postural hypotension, palpitation, dizziness, headache. In the blood test, you can find minor variations in liver enzymes. The biggest problem is oral ingestion, that is to be watched out in kids. Low-dose minoxidil also has been studied in few case reports, and it is shown to be well tolerated in adolescents. But again, do not use it in late adolescents. Do not really try to initiate early therapy with oral minoxidil in kids. 5-alpha reductase, there have been few reports of its usage, though FDA approves only after the age of 18 years is finished, right? As you know, dutasteride is still not FDA approved. So it is better we keep this away from the ambit. Anti-androgen therapy can be used in girls who show hormonal imbalances. Spironolactone, cyprotenone acetate, and also oral contraceptives can be tried. As Subhranshu was talking about low-level laser therapy, this is something which wouldn't have any side effect profile. So this is something, again, we can try out in kids. It is safe. The only thing is ensuring the compliance. Again, PRPs, again, if the kid is compliant and cooperative, we can go with platelet-rich plasma, and studies have shown that it is safe in kids as young as 10 years of age. Psychosocial support, this is the most important factor in treatment of pediatric androgenetic alopecia, and this has to be initiated. Hair transplant, it's not a viable option. The psychosocial support is very, very important because this has a lot of impact on the kids' confidence and the social interactions and the self-image. So we have to really talk them about it, but at the same time give a realistic expectation on how this is going to be a lifelong issue. Try to make them more brave and aligned with the condition in the long duration and the improvement of the condition. This needs to be done. Safety profiles have to be studied, and also the dose has to be optimized. It is a unrecognized condition, the pediatric androgenetic alopecia. Early diagnosis is very crucial. Metabolic screening is very, very important in kids. Treatment is limited, but that shouldn't bind us down. We should be willing to treat the kids, take up it, but at the same time try not to overreach and cross our limits. So thank you very much once again for the kind invitation, and I thank the chairpersons for the opportunity. Thank you.
Thank you. Thank you, Dr. Dinesh. Any questions? He was speaking so fast. No, keep. Just have your water. No questions. Thank you very much, Dinesh.
Thank you so much, sir, for such an enlightening session. I would like our speaker and chairpersons to please collect their memento near the registration counter outside. For the next session, we are having a panel. I would like to invite Dr. Devajit Kar, sir, as the moderator of this panel. He is consultant medical, surgical and aesthetic dermatologist practicing presently at Rourkela. He is a member of IADVL SIG Dermoscopy, treasurer of Indian Society of Pediatric Dermatology. He is reviewer of prestigious journals such as IJDVL, IDOJ and IJPD. There are several publications and authorships to his name. So in short, I should stop now and invite him for his panel. Dr. Devajit Kar, sir.
Good evening, everyone. So we heard a lot about alopecia. So if few hairs are still left to be raised, I feel our panel discussion will do the job. So good evening. When Vikas called me about this session, I was praying that I should get a topic on non-cicatricial alopecia. So he told me, you speak on alopecia. So with all hopes I asked him, so is it non-cicatricial? He told, no, it is cicatricial. So I would like to invite our esteemed panelists, Dr. Rajiv Ranjan Jha, Dr. M.K. Sinha, Dr. Manas Puhan, Dr. Ravi Vikram Singh, and Dr. Yogesh. So what is the basic difference between both these? Please switch on this laptop. तो उसमें लगा लो, ले लो, दिक्कत नहीं होगा, चलेगा, नहीं करना पड़ेगा, मैं कर देता हूँ, मेरा PDF में ही है, कन्वर्ट नहीं करना पड़ेगा। मानस भाई, फुल स्क्रीन के लिए रखो लगे देख लो Thank you very much. Manas bhai is always there around. Because of him, I am standing here today. So we'll begin our discussion today. With a simple question: what are the common cases you encounter in your practice, irrespective of the statistical data? What are the common cases you encounter in your practice? Anyone can take up.
Basically, first, good evening to everybody and welcome to this our CUTICON. Being the scientific advisor, I thought it was my duty also, and great having you, Dr. Kar, here for this. So normally, cicatricial alopecia, what I encounter my clinical practice is chronic DLE and frontal fibrosing alopecia, lichen planopilaris, folliculitis decalvans, and pseudopelade of Brook. And sometimes acne keloidalis. These are the most common ones that I get.
Any difference, anyone like?
I think out of this, acne keloidalis, which is the most common one we see in day-to-day practice, but definitely DLE is always there. Lichen planopilaris is little lesser, but acne keloidalis is a very common one in day-to-day practice.
According to the statistical data, earlier lichen planopilaris was the most common earlier. Now that has been superseded by frontal fibrosing alopecia. So the message here is that we might be getting such cases in the early stage which we may not sometimes in our practice are unable to identify because it doesn't present like lichen planopilaris at all. So that could be a scenario, but acne keloidalis nuki is very common, and as also DLE. Central cicatricial alopecia, centrifugal cicatricial alopecia is not common in this part of the world, and others are definitely rare. So on examining a patient, then how you a patient presents to you, so what is your clinical algorithm with which you move ahead? Sinha sir.
Since cicatricial alopecia is divided into two groups, primary and secondary, and you have already mentioned the causes of primary lymphocytic, neutrophilic and mixed. So if someone comes with symptoms of hair loss, itching, redness and pustular eruptions on the scalp, okay? So we go for testing. Clinical examination is a must, and early detection with dermatoscope, since you are expert on that. So to differentiate it with cicatricial and non-cicatricial alopecia, okay. Then early stage dermoscopy is a must, okay. And further we go for other histopathology and so many other investigations to determine the, so that's what we proceed for that.
So as sir rightly pointed out, that definitely first a minute of observation and talking with the patient, and a very important point here is to ask the patient whether there is pain or pruritus, because that will differentiate between lymphocytic and neutrophilic, because neutrophilic ones will be painful. So this is a very simple way, but it could be a trichodynic kind of pain also, which is not neutrophilic, but this is just from history. And another thing is just by observing the patient, we can know whether there is any metabolic syndrome or not, because nowadays it is associated with every disease. Now, another important history could be allergies and perfumes. They are like the etiology of frontal fibrosing alopecia is unknown. So among the various causes, these are also considered the causes: allergies, perfumes, even sunscreen use. I hadn't mentioned sunscreen because like we can't survive as a dermatologist without prescribing sunscreen, followed by seeing and touching, and identifying early erythema or discoloration and hyperkeratosis. So touching will also, like the early hyperkeratosis, it won't be very planar kind of thing like we get in non-cicatricial alopecia. There has to be a surface change. So clinically these things are important. So what we'll be observing is the first one, if we are seeing something like that, obviously I have made the color coding, so it is lichen planopilaris. The second one, if we are having pale atrophic area with thinning or loss of eyebrows, then it could be the frontal fibrosing alopecia, only with clinical diagnosis. And erythematous scaly plug with follicular plugging, definitely DLE. And another important thing is not to forget to examine the axilla and pubis, because there is an entity called Graham-Little-Picardy syndrome.
We should differentiate, we should go for that's what syndrome that is called Graham-Little-Picardy syndrome.
Yes.
Okay. It's a type of, lichen planopilaris.
Yes, sir, exactly.
That's a triad, cicatricial alopecia of the scalp, non-cicatricial alopecia of the axilla, and subpustular and papular lesions on the groins.
So sometimes the pathology may be somewhere else than where we are looking for. So what else do you look for in your patients after scalp examination? Anything else? Basically, I am talking about comorbidities. Sir, you haven't answered till now, please.
Sorry, sir?
What are the other comorbidities, both dermatological and metabolic or systemic?
Sir, most of some cases, especially female patients, though are associated with the thyroid dysfunction and hyperlipidemia or lipid profile dysfunction are mostly associated. Sometimes the obese female patients are associated with such kind of cicatricial alopecia.
Manas bhai?
So this is the thing, only depends on the what type of disease we are looking for. So already you have mentioned all these things. So definitely when it is a follicular variant, then you see more of the comorbidity, the lymphocytic variant, then not in the neutrophilic variant. And one more thing, we have to, there is something called, though it is not well accepted, senescent and alopecia, which occurs in the old age, where the basic difference is the miniaturization will not be there. It looks like androgenetic because it happens at the age of 50 or 60. There will be loss of hair. So it is a type of scarring alopecia or maybe non-scarring, but there will be no miniaturization, but loss of hair follicles will be there. Nowadays, many patients are coming with that one. Here, we don't need a 5-alpha reductase inhibitor. Rather, we need something, the treatment line should change to cicatricial alopecia. So these cases are now coming in.
So age-related atrophy, like something like that. So basically, when we are getting a case of any autoimmune disease, because lichen planopilaris is considered to be the most common. So one thing which we have to look for is SLE. We can do a CBC, ANA, etc. And atopic we have to exclude. And as these patients, especially in Western countries, they are prone to develop some melanoma or cancer, then these things should be also kept in mind. Not necessarily you will investigate, but these things can be kept in mind. Metabolic diseases are associated, but most weren't found to be statistically significant. So it's up to you. Frontal fibrosing alopecia has strong association with rheumatoid arthritis, dyslipidemia, and hypothyroidism. One test which is common to all of these could be also hypothyroidism, which we can check, and central centrifugal is associated with SLE, dyslipidemia, etc. So as I said, SLE is quite common. And I think most of us, even I don't look into this angle, so we can do. And peroxisome proliferative activated receptor gamma is involved in all of these. That is the common connecting chain between them. So that may be playing some role. So after this, how to proceed still further? So basically, next, as sir said, dermoscopy. Now we have, those who are not into dermoscopy, we have been able to diagnose most of the cases by very good clinical pointers which we have. But it is these cases where dermoscopy will come into play. It has a role. Very early lesion. Even there is no patch of alopecia at all. It may not be cicatricial, even non-cicatricial, like tinea capitis. Very early stage. You hardly have anything, minor scaling, but when you put, you see corkscrew hair. So they're very early. Very late, so you get only structureless area. So there also some residue might be there, like more of erythema, some blue-gray dots. So those things will help us. So as rightly pointed out, clinical examination is now followed by dermoscopy examination. Now it has become quite indispensable for trichoscopy, basically. So in very early cases, features of inflammation clinically may not be evident. That is where you go below the skin and handheld dermoscope is good enough to diagnose most of the cases, if not all.
And in the dermoscope, video dermoscope, because of the higher magnification, gives better result for trichoscopy than the handheld dermoscopy.
Exactly. Always better if you have both of them, the patient can also see and appreciate what you are seeing. You can also explain. So these are some of the findings you get in, I have just made it into a table so that it will be easier for everyone. So basically, what you see is in the late stage you get only white structureless area, but before that what happens is you have arborizing vessels in DLE. So DLE is like red, LPP is like clinically it is more like blue, violet. So first there is a order in which you have to go. You start with the scalp, followed by perifollicular area, follicle, then the shaft. So this is how you need to see in a scope. So these are some of the common findings which you may get. So in androgenetic alopecia, you are expected to get a perifollicular brownish ring, which is a sign of late stage of androgenetic alopecia. But here you get a perifollicular white or grey halo. And scaling is common to most of them. Type of scales varies. Tufted hair, very classical for folliculitis decalvans, even clinically without a dermoscope. But in late stage, you get LOFA and WSA. What is LOFA? It is basically loss of the follicular architecture or the loss of the appendage from the follicle, and WSA is white structureless area. So white structureless area is something like clinically pseudopelade of Brock. So that is the counterpart in dermoscopy. In any cicatricial alopecia, the end stage is white structureless area. So once that comes to this stage, we will be hardly able to know what has happened earlier. So dermoscopy will help us in earlier diagnosis. Any other blood test, sir, which you will go for? Sinha, sir.
It's very controversial. So blood test for what? So we have already diagnosed the case of cicatricial alopecia, and we must look for comorbidities.
Because the patients always ask.
Yeah.
Doctor साहब कुछ test नहीं कराएंगे आप?
It is for patient satisfaction. You go for some blood testing. Otherwise, I don't think it's very necessary, unless we see the patient is anemic, or hypothyroidism is suspected, or diabetes is suspected. Then we go for
Ravi sir,
blood testing.
Basically, tests will be more required once we start the treatment, so that whether the patient will be able to tolerate corticosteroid or some other immunosuppressant, treatment will be more, the test will be more suited for that aspect as well. But histopathology is again the gold standard, which
how frequently do we do histopath? Because I rarely do it for obvious reasons. So is it same with all my panelists today, or?
Not many times, I suppose. Only in confusing cases only.
Yeah, because that is again a valid point for dermoscopy, that with dermoscopy we are able to elucidate further the diagnosis. So hardly there are any cases until and unless it's an overlapping case or confusing case, as sir said. But nonetheless, so basically what we are expected to see is destruction of the follicular stem cell in the bulge region. There will be fibrosis, and that mirrors in the molecular level also.
Most important catch here is you will have perifollicular inflammatory cells in non-psychiatrical alopecia. In psychiatrical, you will get the inflammatory cells around the bulge area. This is the most basic difference, which is a great clue.
So as we discussed, this could be some of the tests which may be done theoretically, but the final word is the need for investigation is controversial, as sir said, unless the patient is very much symptomatic and for other reasons. What are the promising treatment which have given you result till now? What is the best treatment which has worked till now for you?
Corticosteroids. That is the best treatment till now, because whatever we give, that gives the initial fast result, which needs, in case of all these type of diseases, psychological impact is a lot of things. Then once we start with, there is actually to kickstart, corticosteroid is the best one. Then after that, any form of immunosuppressive. But for the hair, I think many people use azathioprine or cyclosporine. But initial days corticosteroids. Then nowadays we are having other therapies like metformin and pioglitazone and all that can be tried.
So there is no US FDA approved treatment. So the best treatment is early treatment, whatever be the etiology. Then, sir, yes, sir, please.
JAK inhibitors seem
Sir,
to be
we'll come
promising.
to it. We'll come to it. So my simple question is, when you see a case of cicatricial alopecia, so you go from neutral to 6th gear, or you go from 6th gear to neutral, or you add everything, mixture treatment, or you put a reverse gear, you refer it to someone, maybe in an advanced case. What is your approach?
Initially, start with the first line treatment, then slowly growing on the second and third stage. It's a beneficiary for both, with the confidence and the especially cost wise, because it's the no any definitive treatment of the cicatricial alopecia. Patient have patience and cost is the big challenge. So it's slowly growing in the from 1 to or the higher level.
Manas bhai, you start with super potent steroid.
Definitely, I'll start with super potent, then only gradually decrease. Even I will go for a oral steroid, topical steroid, everything. Then once for 2 to 3 weeks, then I'll change to something else. But normally when I see cicatricial alopecia, they are never the early cases, always late cases they come to us. So in that case, examolite helps a lot in reducing early inflammation. If you combine examolite with oral steroid, that gives a very good result initially. Then you can continue any safest other immunosuppressants.
We normally follow a 10% rule in dermatology in quite a few diseases like vitiligo. If it is less than 10%, it is topical. If it is more than 10% systemic. Is this valid in cicatricial alopecia?
Yes, you are right. So unnecessary less than 10% of involvement, we avoid systemic steroids. Moreover, we have to keep reserve these systemic steroids because, you know, we have to see other comorbidities of the patient is having or not, like diabetes, hypertension and other. So better to avoid systemic steroids less than 10% of the cases. We have other so many options, calcineurin inhibitors and JAK inhibitors also, and intralesional steroid also, that may be a good option also. So you must keep these systemic steroid.
Though I agree with Dr. Sinha's version, but our main purpose is to arrest the damage.
And which is very important in cicatricial alopecia.
Right.
Other diseases may not be as aggressive or as destructive. So in cicatricial alopecia, what is recommended is we should start with the potent ones first, not like going from 1, 2, 3, 4, rather 6, 5, 4, 3, 2, 1 is what is recommended.
And because of the fibrosis, the absorption is also less from the cicatricial alopecia area.
And it is sometimes not reversible after a certain time.
Normally in vitiligo patients, there will be
always
absorption.
advisable here to go from like high to low is better. But obviously there are no evidence for it, like that is what is recommended considering the nature of the disease. So coming to tofacitinib, how has it changed your treatment protocols over last 2-3 years? Your experience, basically
So
we are talking about
tofacitinib is
lymphocytic,
now
not neutrophilic. Yeah.
synonymous with dapsone, which was 10 years back. So you can give in each and every conditions. So that's why because of the safety profile, and it is also working well. I think tofa has been introduced for psoriasis. So except psoriasis, it is working everywhere. So it's a good one, but normally in psychiatric alopecia, I don't give. Somehow I have not given.
Any good experience with tofacitinib, or in what case, which case you got?
Like there is, I have given a lot of pemphigus patients I have kept on tofacitinib and they are doing very well. So normally, which is not, but there are few reports only, no such good articles, but it works well with pemphigus also.
Nowadays it is being given in urticaria also.
I find it specifically working well in lichen planopilaris or lichen planus associated scarring. There I find it working better than in DLE and other conditions. That's my experience.
Sir, vis-a-vis steroids, oral steroids?
No, of course. Oral steroids are if you need the most aggressive treatment, it is something that I will start with. That is oral corticosteroid. But once you taper it, yeah, in milder cases, as the 10% rule is there, so for 1-2 months you can try whether it is increasing or not. If it is not increasing on to 500, you might even avoid oral corticosteroid. But where you really need aggressive treatment, oral corticosteroid, if not contraindicated, is a drug of choice.
Sir, have you tried pioglitazone in LPP?
No, pioglitazone, metformin, these things I haven't tried, but topical tacrolimus works well, topical steroid, topical tacrolimus, these things work well.
Anyone who has tried pioglitazone experience?
There is no much data published about this, pioglitazone, because...
Anyone in the audience with experience with pioglitazone? Pioglitazone is a PPAR gamma agonist basically, but the thing is that is not the only factor which is causing that, not the only pathogenetic factor behind LPP. So it does help, but again, as sir said, there is limited data, but if people want to try, the dose is 15 to 30 milligram per day, and it is definitely only an adjunctive therapy. Like there was an article which said that whatever is present in your hair does not necessarily mean you have to eat that. So that is how I can put this. So any new treatment of late you have tried, as Manas sir said, Excimer, you start simultaneously with the...
Simultaneously.
In which cases?
Like in mostly lichen planopilaris as the difficult one, and I have used in DLE also.
Anyone else, any new treatment which you have been trying of late or something beyond this which we have discussed?
Topical cyclosporin has been used, and you can use the oral cyclosporin one, the lipophilic one, cyclosporin, that can be put on the scalp, that also works.
Metformin, again it is a drug which is now given in a lot of diseases beyond diabetes. So what is the experience of our panelist regarding this? I don't think we have topical one available here. That is one on which a study was done, and the dose was 0.5 to 2% as an adjunct therapy. But anyone trying metformin for LPP basically? Not much. So basically metformin is being explored for its anti-fibrotic and anti-inflammatory property. So this anti-fibrotic is which is supposed to work, especially maybe it may be useful in people who are already diabetic, who are having already metabolic syndrome, may not be frank.
For patient, it is the best drug to add
So
on.
that may that will help in that, and along with that it may help in this. So I think that is one area in which we can find a clear indication now that people who are having metabolic syndrome with LPP but yet to develop frank diabetes, just like we are giving in acne. So this can be tried if at all it helps.
And also there is a negative side of it. Once you start metformin, they will Google it, then they will say, I am not diabetic, you have started a diabetic drug. So all these problems create.
Yes.
For the practitioner, it is a big headache.
We are already sick and tired about answering about steroids, so this may add to the burden. So low light laser therapy, what is your opinion?
Non-ablasive
in derma, everything
laser,
everywhere, nothing nowhere.
Yeah. Somebody, I have seen in some books, so non-ablasive laser of 1470 nanometer, okay, it will help. So there are some, publications.
So the consensus is that it is approved by US FDA, but US FDA approval is regarding its safety, not regarding its efficacy. US FDA doesn't ensure or assure you about the efficacy of anything. It's safe. It has been approved for androgenetic alopecia and musculoskeletal pain, not for cicatricial ones. Again, exact mechanism is unknown, like Amway drugs. Hypothesized to act on mitochondria to alter cell metabolism and increase vasodilatation. That is what minoxidil also does, and modulate inflammation. Shown effectiveness in reducing inflammation and causing some hair regrowth after daily use for 3 months in several patients of LP. So if you can read between the lines, that is the message what this is telling. This was a study by Shapiro. So these are the treatment options. The most common treatment options for cicatricial alopecia, basically I am talking about lymphocytic ones, are till date steroids, oral, topical, intralesional and hydroxychloroquine. They are like the first line. Rest all as per your requirement and the need of the patient. Fancy things and tall claims have always attracted us, especially when we are less hopeful or hopeless, and it's better if it pays. So any fancy thing, Manas bhai, which you have tried, like all these exosomes and all, due regards to all the speakers, this is my topic, so I have just put these things. I am not against or for this.
So they claim everything. Now the so-called trichologists are claiming everything to work on the psychiatric alopecia. But definitely before all these fancy things, surgery do helps. There are a lot of surgical options are there. But so many botanical products, they also claim that they do the thing, but I never give.
Sir, anything else which you have tried? We are happy with the existing, our panelists are happy with the existing treatment options.
Yeah, absolutely. Stick to the proven ones.
So iontophoresis which used for drug delivery. Again, the catch here is the hair bulge is at 2.5 to 4 mm, and iontophoresis doesn't deliver your drug there. So this is not effective. Iontophoresis. So PRP, GFC, exosome, stem cell. Just one word answer, sir. First line, second line, third line, fourth line, nth line, money line, no line.
Not for psychiatrical.
So no line.
No line.
Sir?
No.
Sinha sir? Up. N line or with N line. First, second, third, fourth, no place of these drugs. Okay. So our panelists are of the view that we are still in the N line for these therapies. Now many patients come and tell, before you ask them something, they want you to listen to what they have done. So we tell, "Arey, ye sab bekar hai." So don't tell bekar to the few things which I will be telling now. So if they have applied honey, it should be Manuka honey, shown to be somewhat active against Staphylococcus aureus. Photodynamic therapy was shown to be helpful again because of its anti-inflammatory and immunomodulatory property. Botulinum toxin, supposed to normalize overactive immune system, because in parlors they are doing hair Botox. So I thought Botox also there is a space, but how it works no one knows. Does it work at all? No one knows. And in hair Botox which they are doing in parlors, they don't use Botox. Only the name is hair Botox, no Botox is used there. So there are only isolated case reports about all this. Super doubtful efficacy, maybe just as a co-therapy. So what we need is a more holistic approach, multidisciplinary care because of the comorbidities, a collaborative relationship with endocrinology people, regular dermatological surveillance, mental health support where and when needed, and coordinated approach ensures improving patient outcome and quality of life. So this is my final take, which I normally give in my presentations. So this is dermatologist addressing androgenetic alopecia on Instagram. We become chawa. PRP, exosome, GFC, stem, everything. No offenses here. Anything except androgenetic alopecia, this is what we become. When we get cicatricial alopecia on their 4th visit, this is what we become, and this is what I am doing in conference. Thank you very much. And thank you to our panelists. Thank you very much. And thank you everyone for staying here till 8 p.m. Thank you.
Thank you so much, sir, for this wonderful session, and thank you to all the panelists. With this, we come to commencement of the first day of 39 CUTICON Bihar. I would request you all to kindly proceed for dinner. And I would request our panelists and our moderator to kindly collect the mementos.